live at the College of Medicine, University of Lagos, Ijaraba, to cover the 25th year anniversary of the class of year 2000. The event is said to be a week-long event which started on Sunday, the 14th of December 2025, and is to end on Friday, the 19th of December 2025. The Provost of College of Medicine, University of Lagos, Professor Ademola Oremusu, is to be in attendance alongside other notable speakers.
Good morning, everybody. It's amazing to see everyone here, and all our lecturers and students. It's amazing to see you here. Thank you very much. We can't do who we are without you guys and teaching us so nicely. Shall we all rise up as we pray, please?
Yes.
Father in heaven, we thank you. We give you all the glory because you're good and you're kind. We thank you because we chose this day and now it has come, it's here, and we are having this symposium. We thank you, O God, for everyone who traveled from all over the world, Australia, Canada, the US, the UK, everywhere, God, you brought us here safely. We are grateful. We thank you, God, for 25 years, oh God. We look at ourselves and we say, see how far you have brought us. And so we are here to say thank you. As we open up today, we ask for your grace, for your presence, that everything we do today would be glorious and will be glorified. Take all the glory, Father. In Jesus' name we pray. Amen.
Thank you. I'm Dr. Nana Fatima Habiba. So happy to be amongst us today. And most of the time when we want to start anything, we start with the opening chapter of the Quran. Yeah. Let us start with the name of God, and may God see us through the holes and crown our effort with success. I'll be starting with those of you who can recite faster can recite along. I'll be starting with Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Ar-Rahmanir-Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina siratal mustaqim. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. Amen. May Allah put the barakah in whatever we are praying today. And may Allah safeguard all the offers that have come from Diaspora, from our various homes, and keep us back home. Alhamdulillah.
Can we have the national? Let's remain standing as we have the national anthem. Thank you. You may have your seats. Thank you. Thank you. Thank you. Oh. Now, the University of Lagos anthem, please. Let's rise to our feet and honor our alma mater. University of Lagos anthem.
welcome all of you here. So a warm round of applause for yourself.
On that note, ladies and gentlemen, you are welcome again to the Symposium of the YPC Y2K class, graduating class of 2000 of the College of Medicine, University of Lagos, Medical and Dental set. Now, reversing medical tourism is a thing, the overriding thing, and then we have erudite speakers to do justice to this topic. Very quickly, representing the provost of the College of Medicine, University of Lagos, today our host is none other than a professor of oral and maxillofacial surgery and consultant oral and maxillofacial surgeon. He is the Dean, Faculty of Dental Sciences, College of Medicine, University of Lagos, Professor Lekon Botolorun. Please majestically come to the high table. Let's usher him to the high table where our ushers. You're welcome, sir. We will now call the representative of the Chief Medical Director, Lagos University Teaching Hospital, Professor Wasiu Lare Adeyemo, who is here ably represented by the Deputy CMA Clinical Services, Lagos University Teaching Hospital, who is also a Professor of Internal Medicine, Professor Babawale Bello. You're welcome, sir. We have brought a very renowned person today to be the chairperson of today's occasion. We have many mothers in this school who saw us to medical school, and all of them are special. But we have singled out this one to chair this occasion. She's none other than a professor, renowned professor of cardiology, College of Medicine, University of Lagos, who recently just retired, but is still retiring, as you will see in a short while. She is none other than my own mother and your own mother, Professor Jane Ajirutuku. Professor Jane Ajirutuku, a mother among mothers, a mother of mothers. And you can imagine, mother of mothers, grandmother, but still looking 316. I told you, you ain't seen nothing yet. You can see her bouncing like the 316 that she has. A top round of applause for her, please. Ever so young. Welcome, ma'am.
So today we want to recognize the keynote speaker for this awesome event. It is none other than Dr. Kelechi Ohiri, the DG, National Health Insurance Authority. The keynote speaker for today. You're welcome. So a round of applause for you. Welcome to the high table. End of 2000. Is none other person than my professor, my father, from Ikena Isikwe, Professor of Orthodontics, Faculty of Medicine, University of Lagos. You're welcome, sir.
We want to bring up stage very quickly to join the dignitaries on the high table, the acting president of the CFUL alumni is none other than a professor of physiotherapy, Professor UAC Okafor. Can we have you? University of Lagos, Professor Aziz Butani. Then now very quickly we want to recognize our teachers here present. Professor Shanu a professor of orthodontics, College of Medicine, University of Lagos. You're welcome, ma'am.
Also with us today, we have Professor Elaine Azinge, Professor of Clinical Pathology. You're welcome, ma'am. Professor of Orthodontics, College of Medicine. You're welcome.
We want to bring off stage our deans, other deans here present.
Sitting pretty is also our professor, Professor Orenuga, Professor of Child Mental Health. Thank you so much.
To join them off stage are the following deans. First, the Dean of Clinical Sciences, Professor Passon, and then a fantastic lady that taught us pathology, effortlessly pathology. We thought Professor Elisha was the only working Cotran, but this woman is another version of Cotran in her own right and dimension. Ladies and gentlemen, dear colleagues, YPC, Y2K, welcome the Dean of Basic Clinical Sciences, Professor Abdulkarim. I want to specially recognize the presence of a Professor of Community Health and Primary Care, College of Medicine, University of Lagos, Professor Alero Roberts. Let's recognize that. Also, quickly recognizing a Professor of Child Mental Health, College of Medicine, University of Lagos, Professor Orenuga. Recognize the very special man. Of the Provost of the College of Medicine, obviously a welcome address or speech, which will be done by our own anatomy teacher several years ago, who has no need to be forgiven because he did us no wrong. Ably represented here by a professor of oral and maxillofacial surgery at the Faculty of Dental Science, College of Medicine, University of Lagos, Professor and the Dean of the Faculty of Dental Sciences, Professor Lekon Botoloro. YPC, round of applause.
But he had to be somewhere this morning. But that he will be joining us later on. He said he'll be back here by 12 p.m. So I'm looking forward to him coming. And I'm sure he'll be with us very soon. The chairperson for today's meeting, Professor Jane Ajulokuchuku, the keynote speaker, Dr. Kelechi Ohi, the General National Health Insurance Authority, the CMD, ably represented by the Deputy CMAC, Professor Bowale Bello, the chairperson for the YBC 2000, Professor Gerald Sikwe, my fellow deans present, Professor Fasomade, Professor Abdulkarim. Okay, I was forgetting UAC. The acting president of the alumni of the College of Medicine, Professor UAC Okafor. The 2000 graduates for medicine and dentistry that are celebrating today 25 years. You're welcome. The theme for today's program, Reversing Medical Tourism, is apt because we're at the time in our country where we're beginning to have anxiety concerning medical treatment. Because many of our trainees and many are leaving the country in droves. And so if we are doing something that will cause people to come back to give back to us, it will be very, very appreciated. And I'm believing that today's talk will attract a number that have left to come and give back to both the college and the country. The country needs you, primarily, and secondarily, those of us in the college also need you coming back to give to us. Having said that, on behalf of the provost, I want to say a big thank you to all alumni sets, including this set that is here today, because there are so many things that we have in the college today that was one alumni set or the other that has bailed us out. In the Faculty of Dental Surgery especially, I recall that in 2017 we lost our accreditation, and things looked very dim at the time because we lost it because we didn't have a number of dental chairs, and at that time one was costing 6 million. It's about 4 times more now, or 24 thereabout now. And in the last count, we got about 12 to 14 of those from one alumni set or the other that bailed us out and made us to be able to have our accreditation back. So the alumni set have done wonderfully. I recall in one of the last visits of the, I think it was 1975 set, and we were doing 50 years, and I was there as one of the management staff in court of the college, and some of them climbed up our staircase, and when they got up the staircase, we were really panting. And one of them said, "Why don't you have a lift in this place? You could have asked us, we have provided a lift for you." And the provost just waited until the time was supposed to give his speech and told them that we need a lift. And they promised that they will get us a lift as soon as possible. So I'm hoping that they will get us a lift also. So it shows that how much one alumni set or the other have done something for us here. For this alumni set, I'm young, at least, compared to your set. I mean, by the time you guys were in final year, I think I started residency that same year, if I recall, 2000. So yeah, your teachers are all here, so I'm sure you are going to do things for them. But in closing, as you leave to your various place of work and to the countries where you reside, please keep us in mind because we keep needing things. If the provost at that time to give me a prepared speech, what he does when every set visits is that he lists to them what we need, but he didn't have time to do that this morning. But I'm sure when you go and visit him, I'm sure you're still going to visit him, he will let you know the things that we need so that you can help us out in one way or the other. Once again, thank you for coming, and I pray that you have a wonderful time.
I'm Professor Lalekon Maikagbotoloron. I'm the Dean of the Faculty of Dental Sciences, College of Medicine, University of Lagos. But at this event, I'm representing the Provost of the College of Medicine. And it's good to be seeing them 25 years afterwards. Many of them are big men in their own right at this point, and many of them have come back to give back to the college. So we're really very glad that they are here.
Okay, sir. So the theme of the event is the impact of diaspora doctors on the Nigerian healthcare system. Do you think the diaspora doctors now have really impacted the healthcare system in Nigeria, and how do you think they have impacted the healthcare system in Nigeria?
Well, I won't say they have really impacted. I would say they are beginning to impact. They're beginning to impact in the sense that they are coming in to bring in capital, not only expertise, capital and expertise into the system, where they are beginning to set up very good hospitals. They are beginning to have exchanges that are around the country where they are providing care. This is good, but unfortunately it's still because of cost. They are still coming in to provide care for those that are in the high echelon of the society, the lower middle class and the poor are still not benefiting as much, because when they come in that way, the cost of what they are bringing in is quite high, and since many of us still pay from the pocket, it's still difficult for people to be able to have access to that care.
So you believe they can do more than they're doing right now?
They can do more, and I know they're going to do more, because by the time they're doing that to that level, and they're realizing the impact that they're having, I know many more are going to be more interested into doing more, and I'm hoping, we're all hoping, that as the time goes on, this will spread lower down to other levels of people in Nigeria.
Thank you so much, sir. We really appreciate it. Yes.
I want to recognize YPC members. I'm going to be very fast about that. Here present several people, timbers and calibers, movers and shakers, experts in their own chosen fields of life. Olusegun Ogunwale, specialists in endocrinologists and diabetologists. That was almost broke my jaw. Diabetologists. Quickly, wave to us. Let's clap for him. Dr. Victoria, public health physician and director of disease control at the Ministry of Health, Lagos State. Dr. Opesomi Eson, SD, S-Boy, S-Man, S-Baby. Fantastic guy. MBBS Lagos, the residency in cardiology, board certified electrophysiology. I don't know why somebody works and it's the lab that he wants to see like. But what he does very well at MH Christian Health. Let's start for S-Boy. Specialist in marriage to a medical doctor and services to family medicine. All the way from Australia. He's a general practitioner at Newcastle in Australia. He's ex-president Medillac Tennis Club and the Rotary Club Medillac. He's none other than Dr. Tony Amebula. Here also with us is somebody who will be reading notebooks when all of us are sweating and sweating. Exams are coming, and she will just, I don't know how many hours she spent reading, and then she just goes there, clears. You won't see any stress on this lady's face that the exam is coming. When we are busy carrying 7 textbooks, this person will be carrying notebooks and you do it. Of course, maybe she does her thing in the hiding in her room and all of that. BTS Lagos 2000, MBA in the UK. She's a dentist general practitioner. She's a partner in GP surgery in London. Ladies and gentlemen, Dr. Kemi Olayiwola. Okay, very quickly, I'll recognize others as time goes on. I want to call on the Chief Medical Director of Lagos University Teaching Hospital, Professor Wasiu Lanre Adeyemo, to give his speech, but obviously he's been ably represented here by Professor Bello. Professor Bello, sir, representing Professor Wasiu Lanre Adeyemo.
We are still wondering how we are going to not miss you, man. I got here this morning about 10 minutes to 10. I walked in and I saw you sitting in front. One of those things that we learn, which is punctuality. Even in retirement, that hasn't changed. The other thing is what I keep in my left hand all over and take it all over and share with my training, which is in God we trust. Every other person bring evidence. The provost is represented by the Dean, Faculty of Dental Sciences, the distinguished members of the high table, professors, and the YBC Y2K class. I bring you my tidings from the Chief Medical Director of Lagos University Hospital, Professor Wasiu Lanre Adeyemo, FAS, who is unavoidably absent. he had been in town, he would have been here personally, but he's had to attend to other official assignments outside of the state. CMD would like me to, on his behalf, congratulate your set on your 25th anniversary. I'm sure when you look back, it looks like yesterday when you graduated from the College of Medicine. But as they say, time flies. So today we are going to be talking about reversing medical tourism, the impact of diaspora doctors on the Nigerian healthcare system. And that has come into, one of the things that has come into the lexicon in regular communication in Nigeria is the word japa. Once you say japa, everybody knows the meaning. It means that people are living. It's interesting that that word used to be not as interesting as it is now. In many years ago, when people say "Mofe Japa," it means I'm going to a foreign country on a visiting visa and I'm not coming back. So, and that's what it used to be. So when you meet people abroad who say, "Mofe Japa si Louis," it means I came in on a visiting visa, but I have no intention of returning. We tend to look at the negative consequences on the system, reduction in healthcare manpower available to offer care in the country. When we organize interviews, advertise, we used to have 200 applicants. It used to take a whole day to do the written interview, and another day to do the oral interview. Last recruitment, about 6 months ago, we had 8 applicants. 6 showed up for interview, and 1 has resumed. So that's a department that used to have 40 registrars as one. Now, so that's when we see the overwork of those left behind and the chance that people will walk to their 80s. But there's a second part that the diaspora doctors also cause a negative consequence that nobody will talk about today. It is when, when you japa, you can't take your parents, your in-laws, your uncles, your cousins, can't take all of them. So when you have japa and then one of those left behind is ill, you quickly call somebody and do. My uncle is in this, can I bring him to A&E? That's one of the effects of migration that we are seeing. But there are many advantages that we rarely talk about. There are certainly advantages to the individuals and their families, but more importantly, there are advantages to the health sector itself, giving back. And giving back can be in the form of contributing equipment or infrastructure. But there's also skills transfer. So for example, this year, we had a mission from AMPA. AMPA is the Association of Nigerian Physicians in the Americas. And they were here for about a week, providing surveys, offering skills transfer. So that's one of the things that we frequently don't talk about. Then also a change in culture that we see. So giving back itself is a change in culture that seems to have grown as people leave the country. So this need to give back. And we are benefiting from it, both the College of Medicine, but also the sister institution, the Lagos University Hospital. So today we will listen to Dr. Ohiri talk about the impact of diaspora doctors in the Nigerian health sector, and I'm sure he would shed more light on some of the things I highlighted. On behalf of the Chief Medical Director, I congratulate you on your 25th anniversary. Wish you many more years of giving back and selfless service to our country. Thank you very much.
Thank you you, Professor Bello. Thank you. A round of applause for Professor Bello once more, representing the Chief Medical Director, Professor Larry Wasiu Adeyemo. Now, very quickly, we want to take our keynote speech, but before we do that, we just have one more welcome address or goodwill speech from the chairman. The keynote speaker will not speak before our own chairperson. No, our mom will speak first. Yes, he will not speak before our own chairperson. Mr. Keynote Speaker, sir, we know that he has to run back to Abuja and all of that. So, our mommy has to speak. Our chairperson for today, none other than, as I've said earlier, a world-renowned, very well recognized in our field, Professor of Cardiology, Professor Jane Ajilochukwu. Please, ma'am, the floor is yours. Let's hear from you once more. I will create another YDC Y2K. You should be standing up and giving her a thumbs. You saw her bouncing and she's still bouncing. Does she not look 16?
Trying to make you people not to be afraid of getting older. so I have so many caps on my head. I'm sharing today, and I'm trying to make the people who are going to retire soon not to be afraid, and for the young ones not to be afraid. Yes. Well, just to show that I am in the very much older age grade, in the elderly. Even Dr. Major believes that 70 is elderly because they've been moving the definition of elderly for some time. But I'll read my speech now. I thank everybody. Good morning. YBC Y2K. So easy. YBC Y2K. So easy. Indeed and in truth. So on behalf of all here, we gratefully acknowledge and adopt the amazing protocol already set up by the provost and the dean that presented him. Today is really a day of joy. Class of 2000, YBC Y2K. Welcome back to College of Medicine for a unique celebration of your class. The silver jubilee of your class. 25 years. And some of you look 25 years. And some of you look 25 years old. It is not a walk in the park. So 25 years ago, I want us to have a little flashback. I want to have a little flashback on your graduation day, how you looked. Yes. You were fresh-faced doctor, powered by dreams, drive, and grit. And here you are today. Even one of you brought her daughter, who is a fifth-year medical student. So can we clap for ourselves? Globally, 25 years ago, the prevailing ethos was the survival of the world from the Y2K bomb. Everybody thought that there would be a crash of everything, but it did not happen. But that year, 2000, everybody was afraid that there was going to be a bomb. Planes will fall from the sky, all the computers would crash, but it did not happen. So many times we are afraid of things, but they don't happen. And that is how, we see the world. Further. Oh, okay. Well, my TOT class, Professor Mbakwem and Professor Bello, they were the ones that did teach the teachers class for more than 10 years. And they keep reminding me that I have to hold my microphone near my mouth. So, thinking back, the triumphs and surprises of the Sydney Olympic Games come readily to mind. So I'm kind of rolling back to 25 years ago. I hope you remember that Nigeria took part in the Olympic Games. Yes. You know how many medals that we got? We got 3 medals. We had a silver, but just like things that happen in the world and things that are impossible that happen, our silver finally changed to gold. So did we, in our physics class, did we know that molecular weight of some elements can change. But it happened to Nigeria. Our silver changed to gold. So that is what I want us to remember about the Y2K. Then, in Nigeria, in the year 2000, we were also trying out our new legs on our new democracy at that time, under the leadership of President Olusegun Obasanjo, with some AI assistance. I'm trying to be AI compliant. Even though I'm still writing on my notebook, Professor Papeme is looking at me. So this girl, I'm a girl, so this girl cannot use her phone. So with some AI assistance, I learned that the Nigerian health system status in Y2K was described as desolate. So the AI called our health system then desolate. So we are not surprised then that medical tourism would thrive. For lack of time, I will not tell you of our experiences with medical tourism, but just to tell you that it is not all uhuru in medical tourism. So reversing it is, a plan that we should adopt. Today, the class of 2000 has come to tell us to unpack the perspectives concerning reversing medical tourism, the impact of diaspora doctors on the Nigerian healthcare system. Our chief, our ever amiable provost, is our host today, and he's giving us a staff support. The keynote speaker is none other than Dr. Kelechi Ohiri, the director of the National Health Insurance Authority. My humble self, I'm going to be your pilot, just to be a timekeeper and gently keep the time rolling as your grandmother. So please be expectant for an amazing day of facts and plans by the class of 2000. Thank you very, very much.
Thank you very much.
I also want to thank you because some of you have reminded me of my knee-rattling word rounds. So thank you very much. We have all learned from each other, and we are here to have a wonderful and amazing day. Thank you very much.
Please, a round of applause for the Queen of Hearts, Professor Frank Ojini, Professor of Neurology, Professor Francis Duru, Professor of Anatomy, Professor Femi Bankole, Professor of Neurosurgery, Professor Adelisi Sevier, Professor of Pediatrics, and Professor Aladisi Laiwon, Professor of Hematology and Blood Transfusion. We also have Professor Akin Akiede, Clinical Pharmacology, Sunday Olayemi, Clinical Pharmacology and Law, Professor Akomu, Professor of Hematology and Blood Transfusion, Professor Jacosta, Professor of Orthodontics, Professor Ogunewe, Professor of Oral and Maxillofacial Surgery, and Professor Aino, Professor of Psychiatry, ably represented by Dr. Adebite. Please, a one round of applause for yourself. Thank you so much for being here today.
Who remember Professor Akomo? And he will come to class. Do you ever see anything in his hand? And you will be busy scribbling at the speed of light. And we have a whole hard cover filled with notes from one man's. A round of applause for our teacher. Very quickly, we are going to take the welcome address from, he's going to do that very rapidly, from the chairman of YBC Y2K. But before he does that, I want to quickly say that YBC Y2K alone has 12 speakers, there about 12 speakers in this symposium. And we'll be recognizing them as they take their turn. So if we are not recognized yet, just chill. Okay, we'll be recognizing you as you take your turn. We are recognizing others who are not speaking officially at this occasion. Very quickly, with a rousing, thunderous round of applause and standing ovation, let's welcome our chairman, Professor Ike Nigeria, YBC on your feet, and receive the
well. Mighty man, you do him wrong. Why did you clap for Professor Ezekiel King? Good morning. Some provost will be represented by my dean, chairperson, my auntie, and our grandmother, keynote speaker, chairperson of the Alumni Association, Dr. Pastor Made, who are chief of political science, who came even at the last notice, and so of like us to be present. My dear teachers that are here, it's interesting because I've been in the college for some time as well, but my teachers are here and I acknowledge you. YBC Y2K. That's so when we say YBC Y2K, we say so busy. That's our slogan, and we've been busy for the past 25 years. I want to start on the existing protocol. It is indeed an honor and a privilege to stand before you today as the chairperson of the Medical and Dental Graduating Class of 2000 Alumni Association of the College of Medicine, University of Lagos. Exactly 25 years ago, precisely on the 29th of December 2000, we graduated from the University of Lagos with our MBBS and BDS degrees. Yes. That date heralded the commencement of our individual and collective journey as alumni of this great college and our dear university, University of Lagos, University of First Choice, and the nation's pride. Our undergraduate training at CFL provided for the foundation on which we have built successful careers in different aspects of medical and dental practice, ranging from clinical practice to academia, research, public health, and policy formulation, not just in Nigeria, but on the global scale. Some of these contributions will be presented by our classmates later today during this symposium. In 2016, we gathered as a class to formally organize ourselves as an alumni association with a purpose to promote our collective and communal relationships, to enrich our professional growth by leveraging our network, and most importantly, to support our alma mater. This marked the beginning of our give-back projects to the college. In 2017, the BDS program, as our chairperson and dean of the Faculty of Dental Sciences had said, lost its accreditation from NUC due to the lack of sufficient dental units. In 2018, we were one of the earliest sets to donate a complete dental suite, and we are grateful that in collaboration with other alumni sets, the required dental units were donated, and the admission for the dental school was soon restored. In 2018, we also took a key decision to support indigent but intelligent NDBS and BDS students with a scholarship award, which was named after one of our classmates, Dr. Leslie Garba, who passed on unfortunately in the same year. We are proud to know that this scholarship award is still running with 16 beneficiaries to date, 6 of whom are graduated from the college. We currently have 10 awardees who receive 250,000 naira annually, and also in addition to mentorship for members of the class. We are proud to announce that last year, one of the Leslie Garba scholars, Dr. Miriam Alayo, was the best graduate student and valedictorian for her class. Our support as a class has not been limited to the college, and we recognize the key role played by Lagos University Hospital in our training. Thus, in 2020, during the height of the COVID-19 pandemic, we came together as a class to support groups with donations, with PPE, personal protective equipment, to support healthcare workers in the drive to combat the COVID scourge. This year, as we mark our 25th anniversary celebration, we have chosen a unique give-back project. We have decided to acknowledge the most important people in the system, our teachers, who made it possible for us to be where we are today. Please give them a round of applause. So, in the latter part of this program, we shall be recognizing them duly, as we believe that teachers should be appreciated for all they have contributed to the system. We are also especially grateful to our provost, Professor Debola Oremosi, for all his support to us as an alumni class, to our chairperson, Professor Jena Juju, who graciously accepted to chair this occasion on just the eve of her retirement, and to our keynote speaker, Dr. Kelechi, who we know is very busy, but made out time for the very busy schedule to be here. It is interesting to know that all three individuals are distinguished alumni of the College of Medicine. I want to extend my gratitude to all my classmates, members of YPC Y2K. Welcome home. Many of us have not been back to the college in many years, and a few of us have not left. We recognize that many have traveled from far and near, including Australia, the United States, and the United Kingdom, and even Lagos, to make this event. Our reunion started on Sunday, and we look forward to having a very fun-filled week. It has been an honor for me and other members of the executive to serve in a leadership role over the past 10 years. We look forward to electing a new leadership at our AGM later today. Finally, permit me to recognize members of the executive who have worked excellently well together in the past decade and tirelessly as well. Please rise as I mentioned your name. Professor Aziz Butali, Dr. Ekpesomi Esong, Dr. Tope Lawal, please rise. Professor Kemi Odukoya, Dr. Bolade Ogun, Dr. Kwang Bajabiabila, and our reunion chair, who is the engine room behind this reunion, Dr. Nkemo Kafo. We appreciate your service and dedication to the class. Finally, we are grateful to everyone who has made our time to attend, and once again, we especially welcome our teachers. Thank you very much. YBC Y2K, YBC Y2K, YBC Y2K.
Thank you. Please, a round of applause for Prof as he goes back to his seat. Thank you very much. While he was speaking, somebody very important came in, Professor Godwin Arotiba, a one-time HOD, Faculty of Dental Science, is a professor of oral and maxillofacial surgery. Thank you very much for coming, sir. Yes. Okay, former Dean, Faculty of Dental Sciences. A round of applause for him again. Thank you.
So quickly and eventually to the keynote speech. Before we call on the keynote speaker, we would love to have every speaker henceforth in front so that we can capture them both on the screen and in our recording. Of course, this keynote speaker is going to lead in that as he comes forward to have the speech. But before we call on him, I'm going to call upon a beautiful, delectable young lady. Maybe I should look messy to do that. A beautiful, delectable young lady. You can put your hands together for her first before you get to see that person. This lady is going to do the citation of Dr. Kelechi Ohere, who is the Director General of the National Health Insurance Authority. Mercy, over to you.
Okay. Thank you. Women supporting women, right? All right. I'd like to call on Dr. Nkem Abegunde, Hospital Administrator, Sinai Hospital, Chicago. A round of applause as she comes forward to read the citation of our keynote speaker. Please keep clapping, keep clapping.
It's my distinct pleasure and honor to read the citation for Dr. Kelechi Ohere, our keynote speaker. So, Dr. Ohere's extensive experience in the healthcare sector spans clinical medicine, health policy, finance, management consultancy, and advisory roles in both the public and private sectors. Before his appointment as DG, NIH, he served as Chief Strategy Policy and Innovation Officer for Gavi, the Vaccine Alliance, where he previously served as Managing Director for Policy, Program Policy, and Delivery Support. Prior roles included serving as Chief Executive Officer of HSDF, a healthcare advisory firm, and a visiting scientist at Harvard University. He also co-founded the Healthcare Leadership Academy and was a partner at Flint Atlantic, a social impact investment and advisory firm. His public sector career included previously serving as a senior advisor to 2 ministers of health and the Minister of Finance in Nigeria. In these roles, he led the delivery of several large-scale transformation programs in the country, including Saving 1 Million Lives initiative, which aimed to reduce maternal and child deaths in the country, as well as the conceptualization and design of the National Social Safety Net program to reduce intergenerational poverty. Prior to this, he was engagement manager with the London office of McKinsey & Company, where he served public and private sector clients in Europe, the Middle East, and Africa. He also worked with the World Bank Group in Washington, D.C., having joined through the Young Professionals Program. His focus was on social protection and strengthening health systems in countries in Asia, the Middle East, and Africa. Dr. Ohiri has written policy papers, peer-reviewed publications, and co-authored books on health systems. He has served on expert advisory committees for the Institute of Medicine, the U.S. Center for Disease Control and Prevention, the World Bank, the Global Fund, the World Health Organization. He served on the board of the World Health Organization's Alliance for Health Policy and Systems Research and the Program and Policy Committee of the Gavi Alliance Board. Dr. Ohiri earned a medical degree from the University of Lagos, of course, and he also holds a Master of Public Health degree and a Master of Science in Health Policy and Management, both from Harvard University. He is a Desmond Tutu Fellow of the African Leadership Institute and a member of the Aspen Global Leadership Network. It is incredibly my honor to have you here. Thank you for honoring us with your presence, and welcome. Have you been? Fine.
YBC. Chairman, distinguished ladies and gentlemen, permit me to stand on the very well-established protocol today. And it's an honor and a pleasure to be here. One of the things I remember your YBC said very much so, because I was once a YBC chairman, and this was my other favorite YBC group. So busy. And I believe you're still busy today. I'm really honored because it's not typical that one YBC set will ask another YBC person to come to grace their occasion. So when I was approached, it was very difficult, but I felt I should make the time to be here, because indeed, it's a very special YBC group, and I really believe in what you have all been doing, and thank you once again for the opportunity. The topic today is on the impact of diaspora doctors on Nigeria's healthcare. And in my current role in government, it's something that we deal with quite a bit and we try to address. So I have a presentation I'll quickly walk through and hopefully be able to, one, give some reflections on the issue as it affects the health system in Nigeria, but also be able to give some perspective as to how the government is thinking about this. And from a payer perspective in health insurance, also talk about some of the things we're trying to do to mitigate the problem. And of course, we're dealing with a very complex issue. And one of the mistakes we always make is assume that it's just a purely health sector issue that we're dealing with. But we're dealing with bigger issues around labor markets globally, issues around demographic changes in populations around the world, and what role Africa is beginning to play as a net exporter of labor across multiple sectors. So hopefully we'll try to bring an intersectoral perspective to this as we go along. I don't have a flipper, so please, if you can oblige me just to so next slide, please. So setting the context, next slide. I mean, if you look at the evolution of medical tourism in Nigeria, we see that, first of all, initially it was a thing of choice, mainly amongst those who had means, seeking specialized care that was not really available in Nigeria. And this probably what pertained in the 1900s and 2000s. Then gradually it grew because people had more access to the rest of the world. And then we had an industry that emerged where we had travel facilitators. So even for conditions that could be treated here, people preferred to go abroad, and there was very aggressive marketing by many countries who had built their health systems and needed an influx of people paying out of pocket to service them. And of course, then with increasing life expectancy in Nigeria, the prevalence of NCDs, and a health system that was not keeping pace, more people began to go to places. Now it wasn't only those that were super wealthy. And so people started exploring other countries in the Middle East, in Asia, and in some countries in North Africa. As of now, it still exists. And in fact, sometimes you hear people going as far as Pakistan for healthcare. Once I went to the Embassy of India to get a work visa for some projects we're working on. And I probably was the only person there that was not seeking a medical visa. People were being wheeled in on trolleys and wheelchairs just to capture their biometrics to travel, and it was like a marketplace. So this still persists. Next slide. The estimate by Afrexim Bank is that Nigeria loses about $1.1 billion annually in medical tourism. Some estimates have put the figure at $2 billion. It's hard to estimate because these are numbers basically from people who actually declare their reason to travel abroad. And so it's a big market, and what happens here is that when people travel, that money is spent on other health systems, and that's money that could have been in the Nigerian health system, actually developing our own health system, but others are beneficiaries of it. And in fact, many countries right now, even in our neighboring African countries, are building their health tourism sector with an eye on Nigeria and Nigerians. Next slide. So when you look at the trap or the vicious cycle we have, the Nigerian health sector is underfunded. And so when you do a comparative analysis and look at other countries and how much we spend per capita, it's still quite low. Limited financial protection. And that results in poor quality of care, unreliable and unpredictable health outcomes. Therefore, patients seek care wherever they can. Those who can afford it seek care abroad, which also means that low revenue within the health system and the reduced ability to invest in capacity, training, and quality. And that also goes back to the low funding. So we are trapped in a vicious cycle that leads to medical tourism. Next slide, please. So how does this manifest? A lack of trust in quality and care outcomes, constraints in specialist care, delays and inefficiencies in receiving care, and then of course, they often talked about brain drain of medical professionals, and it's not just financial. Many people leave because they don't have the enabling environment to work in. And so you have these outcomes and this impact, and it's hard to actually convince people to stay in the country, improve the quality of care, because it's something that needs a whole of society approach to actually tackling. But what do we do? Next slide. So when you look at the root cause of the issues, there are things we need to do on the supply side. We need better investment in infrastructure. We need to improve quality of care, period. We need skilled specialists that need to be retained. We need the supply chain that makes sense. And I think one of the pivotal moments was during COVID, where every country had to rely on its own systems. And I think that was a wake-up call for many people. Because when the global supply chain failed, it was the resilience of your health system that would, go back to the previous slide, that was going to keep you alive. And that's why, and I'll come to that later, the government has decided to focus a lot now on working with the private sector to look at how we invest and create some form of independence in our health system so that we can withstand further shocks. But supply side is not enough. if we have a health system where 70% pay out of pocket for care, and when you look at the poverty rate in the country, how many people have money in their pockets to pay, then we know that some things have to be done on the demand side. It means we need to move from out of pocket to establish proper insurance schemes. It means that we need to create guaranteed markets for those who invest in health and the private sector to thrive, because it needs not just the government but also requires private sector investment. It means our regulations have to be strengthened to enforce quality standards, and it means that we have to have better ways of measurement using things like ICD codes and other forms of investment in data. Next slide. I mean, many studies have been done that show the same pattern, the same root causes, and the same issues that we need to address. Next slide. We've already seen certain trends of the diaspora coming back and establishing very good quality centers in the private sector. Here are just a few of them, championed and led by diaspora. So we're beginning to see some shift, but a lot more needs to be done. Next slide. So against this background, where we come into a system that, one, we have poor health outcomes, we had high out-of-pocket expenditure, so even the healthcare we have is really unaffordable for most, and we have this crippling problem of the brain drain and outbound medical tourism that weakens the resources we have in the system. Then what are the things that should be done to capture it or to address these issues? So 2 years ago, with the administration of His Excellency Bola Ahmed Tinubu, we signed a compact led by the coordinating Minister for Health, Professor Mohammed Pate. We run a national health system, which means that we have to recognize that we have a federal, state, and local governments all involved in the concurrency of certain aspects of our health system. And we set a goal, which was one, to save lives, reduce both physical and financial pain, and produce health. Because you have to imagine the kind of health system we run can't be one that is focused on diseases and people falling sick. There has to be a preventive element that focuses and builds on primary care. So there were 4 pillars mainly. First was about governance, and governance addresses the complexity of the health system in Nigeria. And so something called the sector-wide approach was put in place, which means that government should have visibility to all the actors in the health system. Typically, you would go to a primary health care center in some places. It's funded by the federal government, it's funded by the state government, it's funded by the local government, 3 development partners are probably supporting it, and was probably built by a member of House of Representatives. Where is the accountability? And you have certain places that are oversubscribed and lots of places that have no investment. So governance, please can you go back to the previous slide, please? So governance was a critical part that if we're actually going to move forward, then we all have to be rowing in the same direction. The second thing relates to the quality of service being provided on the supply side and on the demand side. And a lot of investments are being made in primary health care, but also in secondary and tertiary care. I will come to that. And then on the demand side. And the third thing is on unlocking the value chain. And this was really important because the healthcare value chain from a private sector lens is really important. Nigeria is the largest market for bed nets, is the largest market for anti-malarials, has the highest burden of, or second highest burden of HIV, top 5 in tuberculosis. But we barely make any commodities, diagnostics, or drugs to address many of these conditions. And you can extrapolate the same thing to the rising burden of non-communicable diseases in the country. So if we don't shape a market where we promote local manufacturing, but also better efficiencies from procurement, we'll continue to look for money to spend inefficiently in the system. So working to set up a budget, so the president set up an initiative to unlock that healthcare value chain, working with the private sector to do that. And then lastly, health security. I think just a few years post-COVID, I think that we all know the importance of that. Next slide, please. So a few reforms going on in the country. One is, how do we procure? A pool procurement means it signals to the market that if you came in and you invested in a syringe manufacturing firm, that this is the market for that. And many of the challenges that Nigeria faced was from the way the system was structured, it discouraged anyone even coming back and setting up. If you set up a clinic or a hospital, who would pay? If you set up a factory to manufacture even sputum bowls, who would buy? As long as it remained fragmented and the way the government procured was giving it to thousands of vendors, it doesn't signal, it doesn't make for a good investment case. So pulling procurement and doing bulk purchasing was a signal to the market that there was an off-taker. Now we're seeing the ravage that cancer is causing in our society. The government invested in end-to-end cancer centers to expand, building on the example with the Sovereign Wealth Fund in Lagos, but also looking at signing and building these cancer centers, I think one in every geopolitical zone in the country. A lot of projects in many tertiary hospitals. In my view, more must be done and more needs to be done. And then, of course, when we talk about medical tourism and the Japa syndrome, I mean, two things are clear. One, everyone has a right to decide their career trajectory. And whether that means they want to travel abroad and get better trained, the labor market will work that way. You can't over-legislate that. Except in cases where the government invests in people's education and training and decides maybe they sign a bond or a contract. But it's also important to increase the training capacity we have in Nigeria and also make provisions that there will always be attrition. People always travel. But we should also keep producing, because with a population of over 200 million people, human resources are not things that we lack. But if we don't invest in our human resource and our human capital, even just beyond the brain drain, we'll continue to lack the critical resource that will be necessary to build a system. So we've increased enrollment of nurses by investing in expanding nursing programs across the country by 3x, from 28,000 annually to now 115,000. We launched a National Health Fellows program, and across many teaching institutions, we've also started increasing medical school intake and gradually postgraduate medical training that the government will actually invest in and pay for. It's a strategic investment and something that we must do. And it would have been better if it was done 10 years ago, but the second best time is now. Next slide, please. So a lot of things on the supply side, and there are many things that are going on. But the elephant in the room was always, when we do all these things, who's going to pay for it? And that's where health insurance comes in. And when I assumed this role about almost 2 years now, 2 years ago, we set out a strategy, which is, well, when you look at it, what's our business really? It's helping reduce out-of-pocket expenditure because it makes people health poor. So health poverty is a big deal. And what does that mean? It means two things. One, there are people who are too poor to afford healthcare because there's nothing in their pockets. But secondly, and more ominous, is the fact that there are people who have money but are just one catastrophic illness from being plunged into poverty. And so you find people selling everything. So there is a better way to, by pulling risk and pulling resources, to expand health insurance coverage. That's why this was one of Mr. President's priorities, that to make sure that we expand coverage of Nigerians and move towards universal health coverage. And a presidential executive order in September came to life that we have started working with different organizations, and I'll speak to that in a minute. But 4 key things. One was coverage, really, because except you have more people covered, then we can't continue in trickles. So when I was YBC chairman, during our YBC, actually the topic was health insurance. And the irony of life, now you have to come back and fix that thing that you were agitating and advocating for when you were a medical student. So be careful what you guys do right now, because all the things you said when you were a student, you'll have to come back at some point to address them. So 3 things need to hold for us to improve coverage. One is the National Health Insurance Act made health insurance mandatory for all Nigerians. Enforcement was the challenge. And one of the places I'm going to after this is to sign an MOU with the Bank of Industry that all their clients, businesses that come to get loans from them, have to produce a certificate of compliance that all their staff are insured. And we're going to go facility by facility, company by company, with Bureau of Public Procurement for doing any tender with government and also individuals. So we have to enforce the mandate, and we have to put more resources into the system. But it's not just enough to say it's by force. Are people aware? Even when people are covered and they show up, do they know what they are covered for? Insurance can be too technical for a lot of people, so it needs to be simplified. More education and more awareness is critical. And the third thing is really to rebuild trust. There's no point you have insurance and you show up and you still don't get the care that you have, or the care you get is suboptimal. Having insurance must mean 2 things. It means that when you are sick and you show up, that as long as it's within the benefit package covered, that thing that ails you, you should come out of the hospital better, or it should be addressed. The second thing it must mean is that you're not expected to put your hands in your pocket and pay again for that thing that is already covered. If those 2 things don't hold, then it makes no difference. That's why enforcement is one of the critical things we have to do. Then there's equity, and I think it's important to speak to this. Not everybody will be able to pay premium for health insurance, because we always have people who cannot afford it. And when you look at the statistics in terms of the multidimensional poverty in Nigeria, there are lots of people struggling. So equity has to be the cornerstone of that. And what have we done so far? I'll speak to 3 programs that we are implementing. I think the first is called the Basic Healthcare Fund. And 1% of federal government consolidated revenue goes into primary care. About 2.5 million Nigerians right now have their premiums paid for by the government under these schemes, working with the state health insurance schemes. Between December 2023, when there were about 16 million people, Nigerians, covered with any form of insurance, as at October this year, that number was 21 million. So it's a 5 million increase in the number of people covered, and that's been like the fastest rise, and we're hopeful that the effort will continue to pay off. There's something called the Vulnerable Group Fund, where we define those who are vulnerable in society, the elderly, the poor, displaced persons, but also a critical group, women at risk of dying in childbirth. Nigeria has one of the most appalling maternal mortality indices. And so one of the things that we decided to do in the government was to take it on and innovate around it. Of course, at the end of the day, basic primary health care is important. But we've been doing that for years. But what do we do on the demand side? We can't wait for everybody in Nigeria to get covered before a woman who has a complication gets access to care. And so last year, we've made it compulsory now that any woman in Nigeria who is in labor and has any complication, shows up at any accredited hospital and cannot afford the care, treat her and bill NHIA. And that's what we've been doing. So right now, about 35,000 women since October last year, when the program was started, have benefited from this. And so, at about almost 300 secondary and tertiary hospitals that have been accredited by NHI participating, both public sector and private sector and more involved. And because crashing maternal mortality is a national priority, financial barriers should not be an issue. And that's why we put money behind it and say that treat, ask us, will pay. And this is independently verified by some of the third-party administrators. And as at last year, we also started that for neonates as well. And by January Q1 next year, we started in Lagos and in Kano, and we're going to expand across the country next year. So these equity approaches is because we understand that to achieve universal health coverage, you can't wait for it to trickle down. So you have to be intentional about equity and about how you target people. And that's why this is there. Because even as we talk about medical tourism, there has to be an incentive for people to treat even those who are poor. And that's where the payer comes in. If they know that treatment will be reimbursed and paid for, then we'll begin to focus on what really matters, which is saving lives of people. A lot of things on quality of care. I will speak to that. One of the things that we looked at was the poor tariffs, which lead to poor quality. If people are not appropriately paid for the care that they provide as doctors, then what's the point? So we came in, we saw that the last time it was reviewed was probably like 12 years ago. Like I said, in God we trust, in everything bring evidence, right? So we looked for the evidence, actuarial evidence of what we should pay. That was reviewed, and that led to a 95% increase in what we paid out as capitation, and a 373% increase in fee for service, just to incentivize and move to better quality care. Because we can't talk about brain drain or outbound medical tourism if the quality of care remains poor. There is a pull factor, definitely, but there's definitely a push factor. And if our system remains underfunded, we'll keep doing that. So that's why we had a very significant increase in what as NHI we reimbursed people. And of course, market efficiency is looking at our role as regulators and how we can ensure that it's not just the NHI scheme, but the same thing applies to other schemes run by states and by the private sector. Next slide, please. Of course, we did a lot of things to repair trust, but also empower the enrollees and improve quality of care through some of our digital programs. Next slide, please. So this is what I spoke about in terms of increasing capitation and fee for service that we did last year. So a 378% increase and a 93% increase to match more reality because of the medical inflation. Next, please. Lots of initiatives were being done, including improving quality of care. Next slide. For the sake of time, I won't spend too much time talking about this, but recall this vicious cycle. And I think the key is here. When we pull risk, pull revenue, and make it more predictable, it sends a signal that you can provide good quality services that will be paid for. So you don't need every doctor, every dentist, every nurse to be a hero who is working and not getting reimbursed for the care that they provide. A system has to work. That's the only way it can be sustainable. And most of us have seen what has happened in the world these days. And when the US government decided to axe USAID, so that world where we expect help to come from elsewhere to fix our system, that's not real anymore. And not only did the US government do that, other countries also did the same thing. But it's also a wake-up call for us as Nigerians. What kind of system are we building? How do we build with sustainability in mind? And that means we have to have better ways of covering care. We have to build bankable healthcare projects, including local manufacturing of commodities that can be produced here. Hopefully that combination of the demand side intervention and the supply side intervention improve health outcomes. We must restore trust and confidence. Now if you want to get care in many places, you have to know someone who will verify and attest to the credibility and the capacity of a particular doctor, etc. And a lot of us are fortunate that we know some of these excellent doctors who are working here in Nigeria, and we can navigate our way to make sure that we see that. But it shouldn't be based on an ad hoc level of knowledge. We must have ways of guaranteeing and assuring quality of care across board. That's where we begin to restore confidence in people. Because when you pull a scheme, you want both those who don't have anything to pay, but also those who could have gone abroad to also pay into that pool. And that's the way you have a risk pool that cross-subsidizes, where the rich subsidize the poor and the healthy cross-subsidize the ill. They will lead to higher revenue in the health network, the ability to invest and improve quality of care. Because in many instances, it's not that we don't have excellent doctors. We do have them in leaps and bounds, but we have to have a system that works. And that system means how everyone interacts, from the doctors to the commodities, to those running operations, to the administrative staff, everything. We must have systems that work. And that will enable us to invest in the system, and then we move from having that vicious cycle that we currently have to a more virtuous cycle that we aspire to have. And we're beginning to see a change in that, but we still have ways to go to get to where we must get to. Next slide. So this hopefully is a frank, reflection of the challenge that we have in the country, but also the opportunities we have and what has been done so far and how we can, with this trajectory, continue to turn things around. One of the things that will be the call to action, which is what can you do? Because the aim is not to disempower. There are things that we can do. Of course, the advocacy is important, right? The voices need to be there. We need to be held accountable, and we need to be reminding us of what we must do to make sure that things improve. There are many integrated models at play. There are those who are building medical cities. There are lots of the diaspora that come back and forth to bring their skills. There are people that collaborate with institutions here to train, to build capacity. And there are those that actually invest in healthcare. In Abuja, I think it was Afrexim Bank invested in a center of excellence recently, and more of those we see are coming up. But there has to be the ability to pay. Otherwise, yes, it will reverse some of the tourism, but might not address the problems for all Nigerians. And we have a policy and a government that's really big on equity and making sure that even those who are poor have access to care, because health is one of those fundamental issues that we need to make sure we tackle. And of course, reverse innovation models using technology. We have evidence of lower cost models that are high volume, lower cost in many countries in India. So it's also a challenge for us to rethink service delivery models in Nigeria, leveraging telemedicine, etc. So the fact is, there are many ways you can play in this as the diaspora. There are many ways you can contribute to this. And it's not always the case that you will just pack up your practice and then show up in Nigeria with a cape and ready to save Nigeria. It's not going to work that way. But I feel like by at least engaging in some of the critical conversations, speaking to people, and really exploring ways that you can be part of this change and transforming the healthcare system, I think we will be well on our way to improving things. So I think that should be the last slide. Next slide, please. Yes. So just to say thank you very much once again. The issue about reversing medical tourism will be one that we'll continue to deal with. And it's not just in the health sector, it's across sectors. We're part of a larger labor market issue that has even led some countries to now begin to set up policies to prevent migration. But as populations in other countries continue to age, they continue to depend on our skill sets. People continue to go, and with them, they go with the skills. And what happens is that the patients will follow those who have the skills. And many people, when they go to these countries, it's Nigerian doctors that treat them. And it's graduates from Luth, graduates from Ibadan, graduates from other places that will address this condition. So I look forward to hearing what YBC Y2K will do, and we look forward to partnering with you to reverse medical tourism and to rebuilding our health system in Nigeria. Thank you once again for the opportunity.
Please keep clapping, don't stop, keep clapping. That was a power-packed presentation. So many things to take in, so many things to learn. But can you imagine that Nigeria, we have limited financial protection, obviously. And this is something we need to, we have a lot to do in order to have health security, effective governance, efficiency and equitable health care, and also to unlock value chains. Sir, can you imagine that $1.1 billion is spent on medical tourism? Let that sink in. 1.1 billion spent in other countries. Something that could be used here to improve our healthcare, to improve our lives.
$1.1 billion. I caught cold. I caught cold because, and he didn't stop there. He said, that's a loss to our country, yet some people are building their entire healthcare industry in their own nations on top of Nigeria's loss of 1.1. I think the values are even more, perhaps big, because it's making me think of some figures. He even went as far as saying that we found ourselves in a cyclical trap. We lack advanced infrastructure, enough specialist training, local production and chain supply, and that if you get all these things right, you will improve the quality of care. He didn't say we'll get the $1.1 billion back. He said we'll improve the quality of care because his focus is on the people. A thunderous round of applause for our keynote speaker today, who we will still ask to step forward as YBC Y2K give him a token of our appreciation in the form of our award. He asked us a pertinent question: what kind of healthcare system are we building? YBC Y2K, what kind of healthcare system are you helping Nigerians and yourselves and our future generations to build? Our dear mommy, we're going to call you retired but strong, refired and refiring, fantastic, young at heart and young in body. You can see her bouncing. Imagine those steps. Professor Jane Ajuluchukwu, as she presents the award to Dr. Kelechi Ohere, our keynote speaker.
On our behalf, it's my great pleasure and honor to present this plaque to Dr. Kelechi Ohere as the keynote speaker to the theme Reversing Medical Tourism at the Symposium of the 25th anniversary celebration of the College of Medicine, University of Lagos, Medical and Dental Graduating Class of 2000 Alumni Association. YBC Y2K.
Good afternoon, sir.
Good afternoon. My name is Dr. Kelechi Ohere. I'm the Director General of the National Health Insurance Authority.
It means NHIS.
NHIE.
Yes. NHIE. It's not
Yes.
S anymore.
Authority, not scheme. And this is because our mandate is beyond providing insurance through a scheme, but also involves regulation and promoting health insurance.
Okay, so in accordance with the theme of this event, which is impact of diaspora doctors on the Nigerian healthcare system, how do you think it could, align with the values and vision of NHIE?
I think it aligns very much with the values and vision of NHIE. Well, first, the credit has to start from the top, where the policies are set. So, Mr. President Bola Ahmed Tinubu decided that universal health coverage was going to be one area of focus for Nigeria. So what he did was he signed a compact with the state and local governments to make sure that we are all together focusing on the same priorities, which is to improve access and also to reduce the poor outcomes. And so NHI's role is to make sure that people have financial access to good quality healthcare. And that is why this aligns with us, because if healthcare quality is good, there'll be no need for there to be medical tourism. And for that healthcare quality to be good, it means we have to invest in the provision, but also it should be affordable to people. And the only way it can be affordable in a sustainable way is through health insurance coverage. And so that's why it aligns very much with what our vision is.
Thank you, sir. One more question. How does it feel being back at the College of Medicine after 25 years or so much more?
It's an amazing feeling to be back. It reminds me of the dynamism. It's great and humbling to see all my professors and people who are here working hard, the doctors, the nurses, who are here and are really doing their best. As you can see, a lot of our professors are here, so it's really amazing. And to see a lot of our colleagues who are doing very well, I mean, it's really amazing to be back here. University of Lagos is the best.
Okay, very quickly, before the next phenomenal speaker comes up, a very highly accomplished and renowned surgeon comes up to give his lecture. I want to quickly recognize the following in quick succession. ACP Dr. Bose Salami, Medical Director, Directorate of Force Medical Services, Lagos State Police Command, a member of the International Chief of Police and several professional bodies. Also humbly recognizing Dr. Abimbola Oshinowo, a Director, State Malaria Elimination Program, Lagos State Ministry of Health. Dr. Riri Festus, General Practitioner, and is with the 68 Nigerian Reference Hospital, Yaba, at the Psychiatry Department. Dr. Abdulwasiu Busari, Consultant, Nephrologist and Clinical Pharmacologist, College of Medicine, University of Lagos and Lutz. Dr. Caleb Yakubu, somebody say Agama, Consultant Radiologist, Lagos University Teaching Hospital. Dr. Dakwa Shinyobi, our Permanent Secretary at the Lagos State Health District 5. Dr. Chiwe Adebiyi, Senior Director, Therapeutic Area Lead Neuroscience, Johnson & Johnson, USA. We have a series of lectures on discovery science and clinical translation. There are 3 phenomenal speakers who will be giving us profound lectures in quick succession. The first on the list is another phenomenal surgeon. He is none other than a renowned board-certified plastic and reconstructive surgeon, dual certified by American Board of Surgery and American Board of Plastic Surgery. He's a distinguished alumnus of this great citadel of learning, the College of Medicine, University of Lagos, and received his MBBS degree in 2000, winning the Neuroanatomy Prize. I thought you clap for him. He completed his residency training in general surgery at Howard University Hospital, Washington, D.C., and fellowship training in the plastic and reconstructive surgery at St. Louis University Hospital, with further specialization in craniofacial. It should have been outstanding, but it's okay. And pediatric plastic surgery at the University of Tennessee and Necker Hospital, Paris, France. He is a fellow of the American College of Surgeons and a member of the American Society of Plastic Surgeons. He practices at Posh Plastic and Reconstructive Surgery in Mansfield, Texas, focusing on adult and pediatric plastic and reconstructive surgery and cosmetic surgery. Friends at YPC Y2K, this personality is none other than Big Ben himself, Dr. Uzoma Ben-Bule. and for the audience consumption, this guy specializes, amongst many other things, in separating conjoined twins. I told my son, come and meet this guy. I've been telling my son about this guy. Separates twins, conjoined twins, and they met this morning. Though we are classmates, it's my pleasure to meet you again, sir.
Good morning, afternoon, everybody. I believe I'm very well known in this room, so I really don't need any introduction more than my name is Uzoma Bulie. I made a comment this morning that I'm probably the proudest graduate of this college, and I mean that in so many different ways, because I feel like, yes, we're talking about reversing tourism and healthcare, but I feel like any and everywhere that you find yourself, that you should represent your background. So I represent myself, my family, and of course, I would be nothing without the College of Medicine, University of Lagos. So Dr. Ajuchukwu is here. She has been a mentor, and the interesting part is she helped me in more ways than she knows. Like, she was the one person that convinced me I was never going to do cardiology. Because she was so good at it, and she was always so excited, and I could not find that excitement at all. So, but what she did teach me was that whatever I do, I needed to be passionate about it, and I am. So, but anyway, if this works, we'll be ready. Okay, so we'll be having, why don't you push it forward to me, right button? So I've had the pleasure of training at many facilities. I think obviously College of Medicine, University of Lagos is where I started, and 25 years later I'm very proud to be back. Next slide, please. So the name Conjoined Twins is, most people actually don't recognize it, but they recognize the name Siamese Twins. And it's because of Chan and Eng Bunker, the original well-known Siamese twins. They were born in Siam and they lived to be very old. There's two theories of conjoined twinning. The more accepted theory is that there's an incomplete separation of a monozygotic embryo. And the other that is less accepted is that there's actually two embryos that for some reason fuse, and then the twins are born with a union. Why is it important? Conjoined twins is quoted as 1 in 50,000 to 200,000 births, and actually only about 5 to 6 of them about 5 to 8 of them are viable births. A lot out of those, at least another third, really die within the first 24 hours to the 1 week, so it's very important. Now, conjoined twins are very, very rare, and doctors that treat conjoined twins are also very, very rare. So most physicians will go through their entire career without ever treating a conjoined twin. And in fact, the percentage is, they said, literally next to zero. And separation requires a specialized team. Now, places like CHOP, Children's Hospital of Philadelphia, have made a name for themselves for conjoined twin separations, but for me, I was privileged to be in 2 different institutions where we were able to do a total of 3 sets of twins. So we're in an academic center. Pegas means stuck or joined, and that basically the classification is based on where exactly that anatomic union is. Next slide. Still not working. So depending on where the union is, that's what that's how it's classified. So for instance, cephalopegus means they're joined in the cephalic cavity, the head area. And pygopegus means that they're joined at the sacral area. Omphalopegus means they're joined in the abdominal area, thoracopegus. So you get the drift. Basically, depending on where the union is, that's how the classification is. Next slide. Just a brief history. Next. Actually, Istanbul used to be known as Constantinople, and that was where the first recorded separation happened in 945 AD. Go back, please. So there's actually a set of grown male Zygote twins, in other words, were joined at the upper abdomen, and they did separate them by basically using a ligature, but one died 3 days later, while the first one actually died before the separation. Next. Johann Fatio is a Swiss surgeon who is actually credited with the first successful separation. It was again Zygote twins. They were joined in the upper abdomen. So it sounded from the description that the union was really just skin and some soft tissue, because what he did was a progressive ligature. Basically, he tied sutures over the union and kept adjusting those sutures over the course of 9 days. Obviously, if you impede blood supply, it's going to lead to ischemia. Ischemia is going to lead to necrosis, and then in this case, it led to a tissue breakdown, and that was actually the first set of twins that is recorded worldwide in 1689 that was successful. Next. So, this is my experience. I trained at University of Tennessee in Memphis, and I got there and there was actually a set of twins already there, which was amazing because I didn't even know that had happened. So my first set was Pygopicus twins, Joshua and Jacob. They were joined in the butt area in 2011. Fast forward in 2016, as an attending plastic surgeon, also in University of Tennessee in Memphis, we had a set of Ischiopegus twins, which interestingly, the set of twins actually came from Nigeria, and we made the arrangements to bring them over. And then the last set was recently in 2023, Thoracomphalopicus twins. So I'll talk briefly about this. So my goal is to give you guys a behind the scenes. So anyway, prenatal diagnosis is important. We have a lot of OBGYNs in the office, in the audience. So obviously, the earlier you can diagnose a problem, the more successful you're going to be at solving it. So in this case, the mom had great prenatal care. The conjoined twinning was diagnosed in utero. They were found to have Pygopicus twins. So usually when you have conjoined twinning, the plan is cesarean delivery so that you minimize any potential complications. I would say that a cesarean delivery is not an absolute thing for a conjoined twin, but I don't know any center that will deliver anywhere else because you don't want to take any risks. So they were born at Lebanon Children's Hospital in 2011, and the great thing about having the facilities that you need to practice is that you can do really, really good pre-separation imaging. Imaging is really important. It helps you knowing the anatomy, knowing what you're going to encounter, planning the separation. The theme of conjoined twin separation is planning. And without proper planning, even when you have proper planning, things will always not necessarily go according to plan, so then you have to have proper planning. So in this case, the history for them, this was apparently the sixth set of twins that have been recorded being born in Memphis, and they were the first Pygopicus twins. In other words, they were joined butt to butt, backing each other, and they had never actually seen each other except in the mirror until they were separated. And they were the first set of twins that were separated in Lebanon, and it was interesting because when I came back to Lebanon after training, and they now had another set of twins. So usually you want to, just like any major procedure, usually at somewhere between the 9 to 12 month age mark is when the kid is grown enough to tolerate, the kids are grown enough to tolerate anesthesia, the tissues are healthy enough to tolerate separation, etc., etc. So usually the emphasis of the first few months is getting them to feed, getting them to be viable, getting them to add weight, and getting them ready for separation surgery. So in plastic surgery, we have, there's something called tissue expansion. Tissue expansion is the technique of recruiting skin. Fun fact, the largest organ in the body is actually the skin. Most people fail to recognize that, but the skin is truly important. So yes, we are skin surgeons, but we actually extrapolate it to everything else. So in this case, you put in a modified tissue expander, which is basically a modified balloon with a remote port. You put it under the skin, you can put it under the fascia, and then you add fluid and use that fluid to stretch it out. So this is what we did with them. We put it in their lower back with the anticipation that we would need to recruit and mobilize skin because the defect was anticipated to be in the sacral region. Now, the separation then happened about a month later. By then we had recruited enough tissue. The technique used for skin closure, because again, everything is critical, but you need to have good skin closure so that you have a good result. So this is, if you look really closely, you see where we marked the flap design. So I think I have a better picture actually. So we use double opposing hip skin flaps. What that means was we basically designed a skin flap from this baby and another skin flap from the other baby and flip them around after separation because the blood supply on this was coming from the other baby and on the other way around. So this is when they were separated. In this case, the union was basically skin and bone. There was a concern about the spinal cord, which eventually was found that they were not united, so that was great. But basically, we wanted to make sure we had healthy skin closure. So in this case, you can see where the skin that came from this baby is now going to that baby, and skin that came from that baby is going to the other one. So that was pretty cool. Post-operative care, obviously, neonatal, pediatric ICU care. You need to make sure that they're breathing well, they're oxygenating well. In this case, they did very well. Unfortunately, Jacob is the baby behind. He unfortunately died a few years later from cardiac problems. Remember, I remember my D1 training. Once there is one congenital problem, there's going to be other congenital problems. So in this case, he had a cardiac issue and he eventually succumbed to it. And Joshua's still doing well. So that was my first set. So I left Memphis after my training, had a job, and then came back as an attending surgeon. And then, of course, my best friend Samia calls me and said, hey, there's this congenital twins in Nigeria. And I told them that you can do it. I'm like, oh, okay. and that's how he single-handedly got me involved again. So meet miracle and testimony. So they were born in Nigeria. The diagnosis was at 24 weeks pregnancy. They were born at 38 weeks. I put up Lincoln Hands Foundation because FA, who runs the foundation, is the one that was instrumental in arranging. She did everything. She got the airline to give them an award ticket, bring them, because basically my conversation with the hospital, Labona Children's, was, I think we can do it. And they said, okay, you know what? If you guys can make them show up in the United States, we'll take it from there. And that's what we did. So at 7 months, they were at Labona. And basically, we spent months working them up, getting all the imaging and making sure they were healthy, make sure they're ready. So what we found was, if you go back to the picture, they had a single umbilical hernia, they had 2 bladders with a ureter each, and they had a single colon rectum which had to be reconstructed, they had a single anus for the twin B, and then luckily they had separate spinal cords. And then the major challenge, this was more complex than the first case, so it did give everybody some pause. But the major challenge is going to be they had the open book pelvis, where the question is, what are you going to do with this? And obviously this is going to affect everything because the pelvis is absolutely necessary for your stability, your gait, etc. But Labona had some really good orthopedic surgeons from the Campbell Clinic, so they figured that they could do it. So here we go again. Okay, so we used tissue expanders again to recruit skin because we anticipated there's going to be a defect here. So these expanders, these are the remote incisions for the expander placement. These expanders basically stretched out the skin so that when we needed to mobilize skin over the defect, would have additional skin. They also had to have that perineum reconstructed because, as you can tell, there is no genitalia here. The genitalia is all posterior. So basically, post-separation, the urologists have to mobilize everything back towards the midline. And then, of course, for their pelvis, the open book pelvis, they needed to have osteotomies to allow rotation of the pelvis. Sorry, still having audiovisual issues. Okay, so this was the separation plan. If you notice, there's a lazy S incision. Usually in plastic surgery, you make a straight line incision. That's standard. But if you do a curved incision, you can recruit more tissue. So use a lazy S incision, and then we've already deflated the expanders. So if you look closely, the skin here is now loose, so that when you're pulling on it, it helps with the skin closure. Let me try this again. And then same thing in the back, another lazy S incision. The other thing with the conjoined twin separations is most, of course, we live in the United States, is highly medical legal. Nobody wants to get sued, et cetera, but labeling the kids is actually one of the biggest challenges because you don't want, because technically you have two patients that you're treating in the same spot, which is a recipe for disaster because what if you give this kid medication and you think you gave it to the other kid? So that's really, really important. So if you notice, everything's color-coded. Miracle was green, Testimony was pink. So literally everything that they had was color-coded, labeled, et cetera. Now, they do have what's called vascular. They're not completely separate vascular-wise, but usually about 10 to 20% of what you put in one baby is going to end up in the other. So in the anesthesia, basically all these factors have to be calculated and thought about and anticipated, et cetera. So this is the result of separation. So that's a large soft tissue defect, basically with the bowel, the genitalia is all posterior. So this is when the orthopedic surgeons did the osteotomies to be able to rotate the pelvis. The good news was that rotating the pelvis actually made the holes smaller, and then we just advanced tissue to close. Had to use acellular dermis, which is processed human skin, to be able to help close the defect, and then progressively close everything. And that was the result on the table. Obviously, surgical drains, they have the external fixators, et cetera. So Miracle and Testimony, that was their story. And then I have to give it up for the teams because you can see the number of people involved. I'll talk about that a little bit at the end. But this is the team at Labana Children's Hospital. They're excellent. Everybody had their own color codes and stuff. And this is, of course, the parents now get to see the twins separate. And they're big girls now. You know, the funniest part is that when I look at this picture, what amazes me is they can cross their legs. Stuff that you take for granted, but yeah, but they're all grown now. So this is now post-Memphis. I've moved to Dallas. I'm now in private practice. I'm no longer an academic plastic surgeon. So the set of twins we're going to talk about were diagnosed at 14 weeks pregnancy, and the ultrasound, the pregnancy ultrasound showed they were thoracomphallopagus. They were joined in the upper abdomen, lower chest. And interestingly, the OBGYN seeing the mom said, oh, you know what, these are conjoined twins, they're going to be, the separation is going to be challenging, and recommended that they go to Texas Children's Hospital in Houston, which is far away. And obviously, the family didn't want to do that. So I remember when I went to the private practice and I was setting up my website, I said, I'm just going to put in that I separated conjoined twins. Interestingly, I get a call, my office gets a call saying that a patient wants to see me for conjoined twins. And I was like, when my manager, she was like, I wanted to tell her that you don't do that, but I said, let me ask. I said, you're glad you asked. So it turns out that my patient, which is a breast cancer survivor that I did a breast cancer post-mastectomy reconstruction on, happens to be close friends with their grandma, or soon-to-be grandma. So she was like, oh, no, my doctor does conjoined twins. It's on his website. You don't need to go to Houston. So that's how. So it was very interesting. I would see so obviously this was diagnosed at 14 weeks pregnancy. So I saw her, talk to her. She said, listen, I don't want to go to Houston. If you think you can do it here, talk. So I talked to the pediatric hospital. All of these arrangements and discussions were happening when she was just 4 or 5 months pregnant. And then I just said, okay, you know what? You'll be seeing your OB and you'll be seeing me. So yeah, I had a pregnant woman come into my office as a plastic surgeon. It just looked weird, but I mean, you do what you gotta do. So they're eventually born in 2022. And again, the goal is always when the kids are born, you have to do a thorough workup, imaging, try to make sure that what are the critical structures that were involved. In this case, because the union was in the upper abdomen and the heart, and the lower chest, the question was, is there any union in the heart? Luckily, the heart was separate, but the pericardial sac did have a union, so that was one concern. The liver, each of them had a fully formed lobe of the liver, but then there was one common shared lobe. So the question was, how much blood loss are you going to have during the separation? And obviously the liver has the hepatic system, the hepatobiliary system, and the vascular system, but the imaging suggested that they could be successfully separated. So this is a model, a 3D model that was made, just to show that you can see the liver right there, and then the heart separate, but the sac did have a union. Luckily the kidneys and the posterior structures were not united. So we did a 3D imaging just to kind of conceptualize what we're doing. You can go to the next slide, please. Okay, so the operative plan. We felt that there was enough skin that we didn't need to do tissue expanders. Tissue expanders are great because they help you recruit skin, but if you can avoid them, that decreases your risk of complications. So again, I went back to my lazy opposing incision, so S on this side, opposite S on the other side, allows more stretch of the skin when you close. And then the plan was to divide the liver anatomically using a high energy system like a Bovie, etc. And then pericardial sac separation and repair with the pediatric surgeons. We're going to do with the thoracic surgeons on backup if there was a problem. And then abdominal wall mesh reconstruction and closure. So day of separation, everybody's excited, everybody's waiting, kids are coming down. I have to always give it up to the anesthesiologist. I always say that most surgeons think that they're the best things in sliced bread, but there really would not be any surgical advances without anesthesia. They do tend to take a lot of time, but time is safety, so that's fine. So when we brought the kids down, and everything was set up again, everything's color-coded. In this case, went with green and purple. They took their time lining up the patient, getting all the invasive lines, because really the goal was to make sure there was no problem. You're better off taking more time and not having a problem than being fast and having a problem. And in this case specifically, because of all the concerns, we did this in a large operating room with 2 beds, with the goal that as soon as it's separated, they'll go to the next bed. So that was the impatient surgeon right there waiting. Because anesthesia was taking time to do the thing. So, but anyway, so we got to work. January 23rd, 2023. We did a layer separation, made the starting on the right side of the baby A, dissected down, got to the liver, did the liver separation, did a pericardial sac separation, and then went on the other side, flipped over, made the incision to separate, and then on the table was separated, moved to the next table, and then did the closures. So again, it's teamwork. The Cook Children's team, everybody, you can see everybody in their color codes. And we needed the 2 primary specialties, plastic surgery and pediatric surgery, because eventually we did not need thoracic surgery. But usually, depending on the structures involved, that's how you set up the team. Can you see if this video will play? Just push next. Yes, it's playing. In volume, audio. Oh, there's no audio. Okay. Anyway, this is a video that was made by the hospital actually just to chronicle the journey of the congenital twin separation. Cook Children's has been in the Fort Worth area for over 100 years, and they've never done a congenital twin separation. So when we came up with the idea, it really kind of a lot of discomfort, to say the least. But with thorough planning and execution, we thought that we could do it. And I felt that everybody did a phenomenal job pulling this off. And of course, on the flip side, the part that most people don't give credit to is the pediatricians who took care of the babies after. Well, basically, they took care of the babies before and after, because they had to optimize the kids. So, when the kids were finally born, I had to go to the pediatric hospital to see them, make sure they're doing okay, and I got the whole team set up. And, when you're doing a project like this, because this is really a project, you deal with a lot of egos, because everybody is a quote-unquote king in his own right. So the job of the team leader, who's usually the pediatric surgeon, is to make sure that everybody's voice is heard and that everybody's concern is addressed before we take a final decision on how to go. And the goal is to make sure that while you may have a problem, that problem needs to have been anticipated and planned and strategized for. So that's what we did in this case, and quite honestly, this particular operation, there was no major problems, but I feel confident that if anything had happened, that we were actually ready to address it. So. So this is Amy Lynn and Jamie Lynn, the last set of twins that were separated. They are cute, to say the least, and they're doing very well. So I did this presentation just to kind of go over my personal experience because this is such a rare thing. But these are the lessons that I learned. One, it's a team sport. Like I said, everybody is greatly skilled in their own right, but you have to put all those skills together as part of a team. Communication is key, planning is key, doing a dry run is key, making sure you anticipate all the problems, and you always have to have a contingency plan. And the plastic surgery part, for me, you always have to design the incision because it's not just about opening the doors, how do you close it? And then, again, you measure many times and you cut once, and then you can use your tissue expander. So the teams, the core surgical teams in each of these cases that I did, for the first one, pediatric surgery is always going to be involved because they do the majority of the work in terms of the kids, they're the kid surgeon. And then depending on what structures are involved, you may have orthopedic surgery, neurosurgery, and then for us, plastic surgery, skin surgeons, structure surgeons, we are the ones that are responsible for the skin closure because without proper skin closure, you will have breakdown, you will have infection, you will have problems, and the goal is to avoid problems. Then the nursing staff. The nursing staff is absolutely critical because without proper nursing care, then you are not going to have a good result. And obviously, anesthesiology, radiology, and all the ancillary services. I have to recognize Professor Leshy and Professor Remus. My staff mate said I have to put this slide in because this is a video that I did after the separation and it was just silly. But anyway, thank you guys for paying attention. Next slide. All right, so I really appreciate the opportunity to share my experience with you guys. I cannot overemphasize the fact that I sincerely appreciate the background that I got from here. And without College of Medicine, University of Lagos, Diaspora, there will be those Uzoma board certified plastic and reconstructive surgeon. I have so many of my mentors here, Dr. Juchuku, Professor Leshy, Dr. Remusu. I just want to say thank you. So please remember, doctor is not, it's still, Professor Remusu, of course. Well, thank you guys very much, I appreciate it.
Good afternoon, sir. Please introduce yourself.
My name is Uzoma Ben Boulier, class of 2000 YBC Y2K, University of Lagos, College of Medicine.
Right now, what's your area of practice in medicine?
So I'm a board-certified plastic and reconstructive surgeon. I have my practice in Mansfield in Texas in the United States.
Okay, so we saw your impressive presentation of separating 3 children successfully. And in line with the theme of this symposium, how do you think, as a diasporan doctor, how do you think you can help in the Nigerian healthcare system, especially with children who would need reconstructive surgery, they need plastic surgery, all this cleptomy and all that. How do you think, in your field of medicine, you could also contribute to the Nigerian healthcare system?
So, obviously, this is not an easy fix, right? There's no easy solution. I think that the bottom line is that as a country, Nigeria needs to decide to do better, period. None of the procedures that I did would have been possible doing here because we don't have as much facilities. Now, things are getting better, so it's not all doom and gloom, but I think we need more government help, government facilitation, and then as a people we need to actually demand more, because if you demand more, then the government will know that you're serious about what you want. We're here at the College of Medicine. This should be a place of innovation, which it is. We have some very brilliant minds here. So I think that if we have the proper support and also with industry, the industries that we have that have the financial strength can also help in terms of bringing the facilities that we need. We already have the expertise. There is no industrialized nation where you go to at any level of healthcare and you don't have a successful Nigerian. So we have the manpower, we just have to have the determination and the plan to move things forward. So I'm hopeful, but it really is going to take a lot of work from all parties involved, not just from one person. It's easy for me to say, hey, I'm just going to come back and do surgery here, but the system as a whole really needs to be revamped and to be improved.
So do you think it would help if the government specializes in plastic surgeon, not that they shouldn't, specialize in other practices, but due to the high need of plastic surgery on the people, do you think specializing in a plastic surgery hospital would do a lot more for Nigeria's healthcare system?
So that may work, but I think that if you did that, that would be more of a top-down approach. So the way we think of healthcare is starting from primary care to secondary care, tertiary care. Plastic surgery is up there in tertiary care. I think that if we can sort out the problems at a primary care level, at a primary healthcare delivery level, in terms of just having the basic facilities, I mean, we're still struggling with light and water supply in Nigeria. So how do you improve when you can't have something as basic as uninterrupted power supply and potable water being available? So it's really not just a healthcare problem, it's an entire country problem. So I would say that even if they did that investment and open a plastic surgery hospital, if you don't have the basis, if you build your house on a shaky foundation, it's going to, it's not going to last. So I think that we really need to focus on basic infrastructure, basic healthcare delivery, and then the additional expertise will come as we improve that.
So just to ask a student layman question that is not a medical student and saw your impressive presentation of separating 3 children that were joined together. For a pregnant woman who has done her antenatal, found out that, your twins are joined together, what do you advise her? How early is she supposed to find out about this? And are there preventive measures for, expectant mothers to, not make their twins to be conjoined together?
So it's such a rare condition that nobody really knows if there's a way to quote unquote prevent it. Obviously, we do know that there's some families and some areas of the country that are higher. We have higher twinning rates. So if you're from one of those areas, then you're more likely to have twins. I think the most important thing is just good antenatal care. I think for as long as you have good antenatal care, because there are already standardized times at which you have to do an ultrasound, there's standardized times that you need to get lab work and stuff. So if you actually have good antenatal care and follow the instructions in terms of what you're supposed to eat, the supplements you're supposed to take, and then get the imaging that you're supposed to take to get in pregnancy, then there's a better chance that it can be detected. Now, the complexity of the joining would then determine the treatment that would be required. Unfortunately, right now, most facilities in the country would not have the facilities to do it. That being said, there are not as complicated cases where if you have a tertiary facility that has all the specialties required, you could at least attempt to do it. Now, the truth of the matter is, in terms of conjoined twin separation, the first step is always going to be, can you deliver the baby safely? So and then once you deliver the baby safely, can you keep them alive and thriving safely? That's going to be a function of what is the complexity of the organs that are joined and how are they doing well. So if you don't think you can, then they probably need to seek medical care abroad. I'm hoping that the next time somebody asks me that question, I can be like, yes, we can go to this facility and we have all the specialties and we can take care of it. But right now, it's probably not the case.
All hopeful with you as well. Last question. How does it feel being in the same room with your classmates after 25 years?
It's good. It's good. Luckily, the majority of us have kept in touch, but they're great people. They're each and every one of them has done really well in what they've chosen to do. So it's good to be able to be surrounded by people who are equally and even more successful than you are, because they give you that drive to succeed and to excel. So I think we have a very good class, and I think that in cooperation with the university and the college, we can do even better things in the near future.
Thank you so much. It's really good.
Diola Eko, as she steps forward to help us stretch. But as you come forward, Diola, please step forward, Diola. Health and safety. Move, let's see you display health and safety.
Okay.
But before Diola takes over to shake us up, I want to recognize my provost and respectfully ask him to join us on the high table. Professor Ademola Oremosu, Provost College of Medicine, University of Lagos. Lover boy, Baba Professor. That's what I call him. Lover boy, Baba Professor.
Okay, good afternoon, everyone. We're just going to have a few health and safety moments, which we should have had before we started.
I must do this now, not after this shake-up. There is one personality, wonderful human being, wonderful personality. I have many mothers, she's one. And if you say, what would Arogunre specialize in? Everybody will say prosthetics. I have to recognize my own mommy to so many of us, and I don't know about others, a professor of prosthetics at the Faculty of Dental Science, College of Medicine, prosthodontics. I would say prosthetics, but prosthodontics is the larger picture. Okay, prosthodontics. But for me, I sleep, drink, think of this personality, prosthetics comes to my mind. She's none other person than Professor Patricia Adetokunbo Akeredolu. We want to specially recognize you, ma'am. Thank you.
Okay, sorry, you're all welcome once again. So we're just going to have a few we should have had this safety moment before the program itself started, but it's never too late. We've all been sitting down for a bit, so I would just crave your indulgence for all of us to just stand up for about a minute. We need to stretch our limbs. We've been sitting down in the same position for a while, and we need to, be more limber. Just stretch out a little bit. You can twist from side to side, move your feet from side to side, just to get a little bit of movement in there. Because we're all getting on, you know, there are a lot of, you know, we're all getting on in age. We all have to stretch and, you know, be just a little bit mobile. You can have your seat after that, it's just for you to stretch. But there are other things that, so you can take your seats now, it's just for you to, you know, get up, move, get a little bit of circulation going. There are some things that I would like for us to notice. There are actually 4 doors within this room. So there are actually 4 exits, but there are 2 that are visible. There are 2 that are actually being covered by the curtains, but we need to understand that in the event of any emergency, we can either go out through here, through the door that is close to the stage, or go out through the door that is at the back. It's a little bit chilly in here, so we may have to reduce, or rather turn up the temperature of the air conditioners, because a lot of people are complaining that it's chilly. But we're going to have a tea break or something later on, so please bear with us. Thank you very much.
Thank you, Adiola. Please, let's put our hands together for Adiola.
Thanks.
You may have your seat, Sir Zama. Thank you.
Okay.
Before we call up the next speaker, Mercy Elijah, some people walked in and it's just in order that we quickly recognize them. Here we have Dr. Tolu Akilo. I call him Oyinbo. He's in private practice in Lagos, Nigeria here. Diola will often say, you can't get Tolu to say, you can count Tolu's words. Actually, she said that this morning again. You can count Tolu's words. Tolu doesn't speak much. Tolu wave at us. Even when we asked him to wait, he was looking back as if the Tolu is at the back. Very funny guy. Okay. We want to quickly also recognize Yanga concepts. Who know Yanga concepts? Dr. Ngozi Bolanle Emeka Onyema ni Nwagbara. Where is she? Stepped out. Okay. She's a director at the Lagos State Civil Service Commission. Let's clap for her in absentia. Dr. Tosin Kayode, I should be recognized. Ni Odesoya. If Tosin is not in the garden, that garden is not complete. Yes, she's there. Yes, she's here. MBBS Lagos 2006, consultant endocrinologist and diabetologist, works in Northeast England. Okay. And then Dr. Tolako Adiaga, a diplomate of the American Board of Psychiatry and Neurology. She's a clinical psychiatrist at New Jersey Hospital, New Jersey, USA. And of course, Dr. Omolade Ogun. Double certified with American Board of Family Medicine and American Board of Obesity Medicine. Let's clap for Omolade again. I want to quickly recognize our teachers, some of our teachers here present. One of them wrote a very beautiful piece about our program in this season. It's not just this symposium we are having. But first, to recognize a professor of ENT, ear, nose and throat surgery, or otorhinolaryngology, Professor Umawolo. Are you there, sir? You're welcome, sir. And finally, for this session, a professor of anatomy, who I said wrote a beautiful piece about our program and our coming home, Professor Okonlawon Abayomi, Professor of Anatomy, College of Medicine, University of Lagos. Simplicity, very simple, professor of many years standing, yet very simple. Okay, over to you, Mercy.
Okay, thank you very much, sir. Y2K, YBC. Oh, YBC, Y2K. All right. The next set of lectures, series of lectures, will be on public health and public service. And the first speaker will be Dr. Temitope Mariam Masha. Please, where is Dr. Masha? Now, Dr. Mariam Masha is a distinguished public policy leader with 18 plus years experience advising top Nigerian leaders. As Senior Special Assistant to the President, she drives national development strategies and regional initiatives. A dentist by training, Dr. Masha holds degrees in public health from Johns Hopkins, organization leadership from Oxford, and conflict management, Geneva Graduate Institute. She's a fellow of the Nigerian Leadership Institute, Archbishop Tutu Fellow, AFLI, and visiting faculty at King's College, London. Please, with a resounding round of applause, let's welcome Dr. Mariam Masha. Thank you.
How do I follow Uzoma? Thank you, Butali, for setting me up nicely. But well done, everyone. It's really an honor to be here. Mine is a departure from clinical practice. But I'll say that I'm going to be speaking about how dentistry prepared me for public service. I think it's one of the things Uzoma said earlier, that wherever you find yourself, and I found myself in public service, and I think that my training actually started here. So my distinguished colleagues, lovely to see everybody after 25 years. You all look beautiful. Friends, our teachers, thank you so much. None of us would be here without you. Thank you very much. It's an honor to stand here 25 years after we took the Hippocratic Oath. And a time to reflect on a journey that I don't think any one of us has ever fully anticipated, neither of myself. And a journey for me that took me from dental clinic to the front lines of public service. Starting from my home state in Lagos and going into the deep conflict-affected communities in Northeast Nigeria, and how now I'm working on regional development across the country. On reflection, I realized that the foundation actually started here at the College of Medicine, University of Lagos. If we look beneath the surface, I can say that dentistry taught me how to problem solve, systematically, compassionately, and scientifically. And these were the steps that we mastered in clinical practice and steps that I brought into public service. And if I miss this, it's Butali's fault. And I think I remember it as history taking, examination, provisional diagnosis, investigation, definitive diagnosis, and treatment planning. And these were the backbone of my work in clinic and also my work in government. So if I can transpose myself from the clinic into public service now, and I start with history taking. With history taking, we were taught and we learned how to listen. Listening not just to respond, but listening to understand before acting. And in dental school, where we learned that history taking is the soul of diagnosis. 80% of your diagnosis is in the history. And these skills became invaluable to me when I left clinical practice and started public service. If I start from Lagos State Government, Lagos is complex, it's vibrant, and it's layered with all sorts of issues. But I found myself doing what I did in practice first, which is to listen first. I worked in the Ministry of Transportation, go figure. I had to work in the midst of NURTW. I learned to listen to people who had worked and lived decades of what you might understand or see as, or perceive as disorder. Listening to market women whose daily realities often don't match what we read in papers. Listening to LASMA, our frontline officers who understand the system's pain, the pain points better than any consultant can. The courageous men and women who contribute to driving Lagos economy by keeping traffic moving. But later I found myself unexpectedly in Northeast Nigeria. I was thrown into that region. I was in Borno State, the epicenter of Boko Haram insurgency, and this was about 10 years ago. It was still very rife. Now, working in those communities where there was a lot of trauma, it was dangerous, and working with families that had lost people who'd been traumatized, history taking for me at that point became more than a technical skill. It was actually a moral duty. Now, so history taking taught me that you can't build trust or design solutions from a distance. You have to be there. You have to listen to people and listen without judgment. And I learned that policy also begins the same way. You listen and you then sit with people, you hear the stories, you understand the context. We heard that from Kelechi earlier. And that by doing that, you allow their reality to shape your response. So history taking for me was big. It taught me patience, empathy, and humility before prescribing solutions. Now, if we move quickly on to examination, and here I look at it as seeing beyond the surface, what the data actually doesn't tell you. Now, examination in dentistry, we learn to observe nuances, color grades, changes, mobility, and things like that. In Northeast Nigeria, examination meant going beyond whatever briefing we were giving. I had to be in there, I had to see for myself. We talk about schools being rebuilt after the conflict. How functional is it? The schools are there, but how functional? Where are the teachers? Are the families even, do they feel safe or comfortable enough to let their children go back to school? Those are the things that the numbers don't exactly tell you. And I'll share a story with you, a brief story. One of my first assignments when I took the job with the Buhari administration, and I was working as a strategic advisor on the Northeast at the time. Go figure, I'm from Lagos, I'm a Yoruba girl. But yes, so that was the job I took. I had to lead what was called the Recovery and Peace Building Assessment. And this was a task that we had to do because the federal government was trying to get a loan from the World Bank to rebuild the Northeast. And this was something we did with the UN, the EU, and of course the World Bank. We had to assess the damages and the needs in the Northeast to be able to make a case for this loan that we're taking. And we had to travel the 6 states. Bear in mind at the time, I think it was only the UN plane that was going around, so we had to basically be in there on a Tuesday. You can't get out until Thursday or Friday or something like that. But it was basically a touch and feel within the communities. And we successfully, in our minds, successfully done this across a number of states. And then we got to Taraba State. And I vividly recall that in Taraba, let me break it down to you. So we had Borno, Adama, and Yobe were the conflict mainly affected states. Gombe, Taraba, and Bauchi were also affected, but more from displacement, not as much as the other 3 states. So what you found was people moving, displacement within the states and then across state lines to other states. Now we got into Taraba and we were engaging with the communities, different stakeholders. And I remember that we had a team from the World Bank, the EU, and I pushed back I thought there was a need for us to have a lot more of local partnerships and local engagement, because one, we don't want to repeat this, and if it does happen, we want to be able to be skilled to address these issues. And why aren't we the ones also going to other countries to consult and also help them in dealing with these issues? So that was one of my first fights, and it was good. I didn't even have an understanding of the system, so I pushed back without any skin in the game as it was. But one of the things that I noticed was that the community kept pushing back. Each time we talked about bringing interventions for people who had been displaced by conflict and were in their states. And somehow we weren't reading that very quickly. But at a point, I noticed that the body language changed. People kept quiet and basically agreed with everything we're saying. And at that point, I was like, no, this is looking very dangerous. I didn't understand the language. I wasn't a child from the region. So I began to just pull back and started asking questions. And what I found, which the data hadn't shown, was that with the people, while they welcomed people from other states, they were also dealing what we call today farmer header crisis. They had communal clashes, they had displacement from that, they had challenges from that. Now we were coming in to provide solutions to Boko Haram insurgents coming from another state into their state. We weren't helping them look at their own issues. They also had children who were out of school because people coming from other states were using their schools as IDP camps. So their lives were also being disrupted. They were also challenged with these communal issues, but we weren't paying attention to that. Now, if we had gone in without paying attention, we would have ended up causing more of a conflict, because people were beginning to push back and hate was being brewed without us knowing. So it was important, again, examination, seeing beyond the surface what the data doesn't tell you. If I go into provisional diagnosis, here is where we make sense of imperfect information. And in my line of work, I have to read quickly, even when I don't have the full data. Now, dentistry taught us, you synthesize information quickly to form a provisional diagnosis, even when the picture is imperfect. And exactly the same thing. During emergencies, humanitarian crises in the Northeast, managing social development programs, because this has to happen. We can't wait until it's ended. Is there an end? We're almost having a resurgence today, but we still have to keep going. Now, the capacity to form a working hypothesis guided me through, my teams providing intervention and really remaining flexible and adaptable in such challenging situations. So provisional diagnosis taught me something deeper. Certainty is a luxury. And as a leader, you require courage in the face of uncertainty because that's just what you have to do. Now, if I move into investigation, evidence before data. Investigations in clinical practice range from a number of things, radiographs, vitality tests, etc. In public service, I learned to gather evidence from stakeholders, baseline assessment, actual visitation, and data from anyone we could talk to, whether it was any form of beneficiary, community leaders, students, young ones, old ones, anyone we could talk to. And we use this needs assessment and community consultations the same way we use our investigative tools in the clinic to form our impressions and continuously refine our approach. This discipline prevented us from treating symptoms while missing the underlying pathology. Now, definitive diagnosis, this is where we bring clarity to complexity for action. And one of the most valuable things that dental training gave me was the ability to, again, synthesize evidence and arrive at a clear, defensible diagnosis. And in my current work, which is now looking at regional development, how are we going to address the disparities and how do we address the drivers of instability across the region? We often come with a one-size-fits-all and we think, it's a health issue or it's each region is complex in its own way. Each region is colored in its own way. There are contexts and local contexts that you have to understand when you address issues in the different regions. So in a region, it may appear underdeveloped. But the true diagnosis may be just, is it a political influence? Is it governance fragmentation? Is it a lack of alignment between a federal and the state system? Or is there a deep trust deficit that's been caused by years of conflict? Now, dentistry shaped my ability to say with confidence that this is not a funding problem, for example. It's a coordination problem. This is not a community problem, it's a trust problem. Or this is not an infrastructure issue, it's a systems issue. And with clarity, teams can align, stakeholders can collaborate, and policy can take shape. And the impact can then finally be measurable. With this ability, I'm able to engage with multiple stakeholders, and I have done that with presidents, vice presidents, governors, ministers, commissioners, state government, development partners, and traditional rulers to form unified action. So moving on to treatment planning, and this is where we design solutions, and we want those solutions to not only work, but we want those solutions to last. Treatment planning in dentistry teaches us sequencing, customization, and sustainability, simplifying what is complex. And this is where science meets practicality, and that's exactly what development itself demands. You don't place a crown, for instance, on an unresolved infection. And similarly, you don't implement innovation without strengthening the foundational systems. In Lagos, I learned that improving transportation requires sequencing and reforms. Law and order comes before infrastructure, and enforcement before we look at expansion. In the Northeast, I learned, for example, rebuilding schools requires trust, psychosocial support before we worry about academic improvement. And just like in the clinic, every patient is different, every community itself is unique. In regional development today, I've learned that inclusive growth requires respecting local priorities and not just like imposing generic frameworks and expecting that it will work. Sustainability does matter, And as dentists, we look for long-term oral health and not just cosmetic quick fixes. And the same thing in the public system. The idea is to build systems that outlast political cycles. So in conclusion, the clinic was my first public service classroom. Everything else after that has been specialization. Today, I help to shape regional strategies for inclusive growth and development. And I realized that dentistry didn't actually take me away from, public service didn't take me away from dentistry, actually. It just expanded my patient. It's no longer my one-on-one, it's now the nation. And from the individual sitting in the chair, it's now moved to communities across Lagos, fragile populations in Northeast, and now entire Nigeria. So dentistry gave me the discipline to analyze problems systematically, the compassion to listen deeply, the courage to act even when information is incomplete, and the humility to place people at the center of everything that we do. So as we celebrate our 25 years, I stand extremely grateful that the skills that I learned and we all learned in our early clinical practice prepared me not just for practice at the time, but for nation building. Thank you very much.
Please, a round of applause for Dr. Miriam Masha as she steps to her seat. I never knew that examination, clinical examination, diagnosis and all could mean something so much in the real world. I never knew it was going to be more than just a one-on-one patient affair. And I also learned that you can't build trust or solution from a distance. That was by Dr. Miriam Masha. Please, a round of applause for her once again. Thank you so much for that insightful section. While she was speaking, Prof. Abiola Oduwole walked in, the pioneer pediatric endocrinology, Nigeria and West Africa. Please, a round of applause for her, please. Thank you so much for coming, ma'am. Now, briefly, we would like Professor Leshi to speak, just for a brief second, on what he thinks about this program. Thank you, sir.
To my respected senior, Professor Juluchukwu, to the teachers who are here, who have impacted into the lives of our alumni, and to the returning set who have done so well for themselves and made us so proud. I want to appreciate the invitation to be here today. I must say that when you look back and you see how Idiaraba molded each and every one of us, we may not have appreciated it then, but now we know that it actually set us up on a good foundation for what we're doing today. And for that, we are always grateful. Personally, I remember when I was provost, I had to make an effort to reach out to the alumni in the Americas, UK, in the diaspora in general, to encourage them to give back. And I really want to say, as I've always done to all the alumni sets that I've had reason to interact with, I really want to appreciate you for the support you have given and you continue to give the College of Medicine, University of Lagos. That is highly appreciated. I know that it was the alumni, both abroad and at home, that got us our dental accreditation back when we lost it, because, and I really want to thank you for that. I want to use the opportunity for you to go round and see what you have done. That those chairs that we got then are still in use now and they're still properly being maintained and they're delivering service. I want you to go round this campus and even on the main campus. The Diaraba you knew then is different. So much has happened. And I want to thank all the successive leaders, both in the college, in the university, and in the hospital, for what they continue to do to improve the service and the teaching and the research and the impact we have. So it's not the time for long speeches, just to say thank you. Bengbuli has always been, even as a student, although he was a bit, you had to, so I remember, that is sit on him, but he's done so well, and everyone else has done so amazing. Dr. Masha, I'm proud. I just listened to what you have said, and I really see, and you brought it in a different way. Thank you so much, and keep up the great work you're doing in nation building. Thank you very much, everyone.
Okay, ladies and gentlemen, it's time for faculty awards. Faculty awards from YBC Y2K.
Good afternoon, everybody. And special thanks to our teachers that are here. The background to this award is, like you've seen, our classmates have demonstrated the knowledge and the skills and the mentoring that you gave to them, and they've gone to the world to deliver. So today we also want to say thank you in our own little way to appreciate what you've done. So we're taking a little break to do that because this is very important. Actually, for me, this is the most important, to say thank you, because I'm also in faculty now. I'm a professor, so I know what it means to teach and train people. So we're going to recognize all our faculty now, and we'll project the list on the screen, and we'll call our colleagues to present the awards to our faculty. So I'll hand over back to the MCs and we'll call accordingly. Thank you very much. Sorry. Since our provost is here, Provost sir, I would like to make a few remarks while we're getting set with the awards. Thank you, sir.
Thank you very much. I want to appreciate the management of the University of Lagos. So permit me to quickly recognize again the Deputy Vice Chancellor, Development Services, Professor Folabi Leshi, and our revered, just retired but not tired senior colleague and wonderful professor, Professor Jane Ajulichukwu, known as the Queen of Hearts. My old teacher too, Professor Abayomi Okolawon, and I use him as proxy to all the professors and the wonderful teachers that are seated. I want to really thank you. I've enjoyed the lectures, and I really am amazed at how you all have gone into your own spaces and you've done wonderfully well. And like I said, when you came in the morning on a courtesy visit, I am extremely proud of you, and this college will continue to interface with your class and with all of you, and we really appreciate you. Coming from all over the world, you did not choose, some exotic destinations, but you chose Lagos in our dirty December period. We're quite grateful. And it's just my joy that through the Alumni Association, we'll continue to monitor your progress. And the other thing I do apart from being provost is being a pastor, so I'll continue to pray for all of you that it's going to be well with you and your families. And when the children are getting married, please send me an invitation. And then when you become grandmothers and you abandon, especially the ladies, you abandon your husbands. So without wasting time, thank you very much. And for choosing to honor your teachers, honor will continue to follow you. So on behalf of the management of the college and the university, I say have a happy reunion. Thank you and God bless.
Keep
clapping, keep clapping. Thank you very much, Professor Oremosu, for that. Up next is the Faculty Awards, and we await.
Yes, good afternoon.
Good afternoon.
First of all, how has this event been for you, seeing all your students back here after 25 years in the College of Medicine?
Yeah, it's very surreal to see people that were young boys and young girls who have, over the years, grown professionally and grown family-wise and grown also mature as, as persons. And so it's very touching, and they also have done something that's very unique this year. They, rather than doing infrastructure, they focused on saying thank you to all the teachers, and I think that is very, very, very commendable, and I appreciate that. Yeah.
Yes, sir. So, in line with the theme for this symposium, which is the impact of diasporan doctors on the healthcare system in Nigeria, how else? Because I've interviewed a few of them, and they've given different ways diasporan doctors could give back to the healthcare in Nigeria. In your own way, in your own understanding, how do you think diasporan doctors can do more for Nigerian healthcare system?
Oh, that's a good question. I want to first of all thank the present government under Bola Ahmed Tinubu and those who are working with him. The Honorable Minister launched a Diaspora program to give back, whereby they could virtually, remotely, also give a lot of pieces of advice and a lot of lectures in areas of their expertise. And so that's one of the areas, and still actually come in for a period of time, do some medical missions, and also medical tourism, reverse the tourism, as they have said. So we're really getting out of what used to be very poor health services. But the only thing I will still say to many of them is that majority of our people, 70%, still live in the rural areas. And so as much as they want to come to the city because there's money and a lot of things, we should still consider those in the rural areas and reach out to them. Yeah.
So let's come home to us here. There are doctors coming out of College of Medicine every now and then, every year. After 6 years, they do their practice and then they specialize in different areas of medicine. How do you think they can also impact the healthcare system here in Nigeria, not just as doctors, but also as individuals?
Okay, so the good thing is that we have over 60 medical schools right now in Nigeria. And on the average, each one, let's say on the average, turns out 100.
Very quickly, in the spirit of us recognizing faculties, our teachers who took us, taught us while we were here, trained us. 3 of them are on the high table, many of them are on the floor, many of them are not here because they are engaged in one thing or the other. Let's first, on the first level, put our hands together for all of them. They are like parents to us, mentors to us, we are mentees, and then you saw and heard when Ben was recognizing and appreciating Professor Leshi and Professor Oremosu. Okay, so one after the other, who's the first person up there? Professor Akinyede Akinkumi A. Okay, next person, they were here earlier, they've left. Professor Banjo Adekumbiola Aino. Okay, next person. Let's clap for them in absentia. Let's clap for them. Yes, Professor Abdul Karim Fatima Biade. She was here too. I saw her and recognized her. Professor Mrs. Damola Adetola Olubumi. Are you here, ma? Next person, Professor Akomu Alani Suleiman. Professor Akomu Alani Suleiman. Are you here, sir? Okay. Professor Milabu Sunday Aremu. Are you here, sir? Okay. Professor Mrs. Ogunshola Folashade Tolulope. You are bringing the whole of Akoka here then. Okay, Professor Mrs. Oduyebo Oyinlola Omoni. Professor Mrs. Azinge Elaine Chinyelu. Professor Mrs. Oreduba Folake Adenike. I don't know if I saw her earlier. Okay. I saw Professor Utomi. Professor Mrs. Ifoma Linda Utomi. Yes. And so imagine that 25 years ago, she was not different, as in babe, always a babe. What are these people doing? What give us the secret of portion, not yet, whatever it is. So we'll call on Provost sir, please present this plaque to Professor Linda Ifoma Utomi. Sir, ma, please move this way. Okay.
Thank you. On behalf of the Class of 2000 Alumni Association, popularly known as YBC Y2K, they are presenting to you this Teaching and Mentoring Excellence Award presented to Professor Mrs. Utomi Ifoma Linda this Tuesday, December 16th, 2025. Congratulations.
Let's clap for Kemi, Dr. Kemi Olaiwola, as she joins them to take the photograph. Kemi Olaiwola, please stay back to present the next award. Let me have their name. To imagine that the professor, yes. Somebody say yes. Yes. Professor Mrs. Sanu Oluwatosin Oshinyemi. Oh, Oluyemi, is it Oluyemi? Professor, I'll just keep it at Professor Mrs. Oluyemi Shanu, a professor of orthodontics, Faculty of Dental Science, College of Medicine, University of Lagos. Sorry about the mix-up, man.
Okay, sorry. My heart skipped a bit, but it's correct on the plaque. All right, so yes. So the College of Medicine, University of Lagos, Medical and Dental graduating class of year 2000, now their alumni association, known as YBC Y2K, present to you this Teaching and Mentoring Excellence Award, Professor Shanu Oluwatosin Oluyemi, this Tuesday, 16th December 2025. Congratulations, man.
Okay, Provost, sir. Thank you, sir. Congrats, ma'am. Professor Mrs. Let me check the name first. I know the first two names. I'm not familiar with the third, but is it correct? Are they all correct? So I don't make the same mistakes twice. Professor Mrs. This particular professor, wow. Professor Mrs. Oluranti Olatokunbo Da Costa. Okay, she's coming back. Professor Mrs. Orenuga Olubimi Omolola Orenuga. I saw her now. She's here now. I saw Professor Orenuga is here now. We know the difference between Oreduba and Orenuga. We know the difference between. Ma, we will pick you out in the dark. Please step forward, ma. We will pick you out anywhere. Right, this is Y2K. Round of applause for her. I want to call on Tope Masha, just walk up the stage with her. Since you are going to give her a big hug and come and present Okay, Fumi. We want me. Okay. So Fumi, join us too, please. Join us. Fumi Shijuade and Dr. Miriam Masha are presenting.
All right. On behalf of YBC Y2K 2000 class, we present this award to Professor Mrs. Orenuga Olubumi Omolola for being an exemplary teacher in child dental health. But thank you so much for all you did for us. Thank you. Thank you very much. Very well. Thank you, ma'am.
Panjo is in the house.
So
they are next. So, can we roll back the slide? Technical, please. Can we roll back to slide to where we have Professor Akomu? Professor Akomu. Okay. So, can we have Professor Alani Suleiman? Professor Alani Suleiman Akomu. Alani Suleiman Akomu. You're welcome, sir. I wanted to help him up the stage, but you saw what just happened. After 25 years, they are still up and kicking. Tony Amefula, all the way from Australia, will be presenting the award to Professor Akomu. A round of applause again for Tony Amefula. Hold on, Tony, 1 second. Properly, if anybody is presenting, please send them up. Then I'll know.
The College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, YBC Y2K, we're presenting this Teaching and Mentoring Excellence Award, presented to Professor Akomu Alani Suleiman. Today, Tuesday, December 16, 2025.
Congratulations, Professor Akomu and all the awardees. Professor Mrs. Azinge, Elaine Chinyelu Azinge. Dr. Habib, Nana Habib Adeyemi.
Thank you.
Oh, yeah.
Thank you very much. On behalf of the YBC, the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, YBC Y2K, I present to Professor Mrs. Azinge Elaine Chielu this day, Tuesday, December 16, 2025. Thank you very much, Ma, for being our mentor and taking quiz for us. Thank you so much.
Professor Milabu Sunday Aremu. Is he here? Professor Omilabu. Professor Abdul Karim. Professor Fatima Abdul Karim. Biade. YBC, who's coming up quickly? Dr. Roke Awe. Dr. Roke Awe. Dr. Roke Awe.
Otherwise, you pay fine. Where's the one?
Okay.
Thank you, Ma, for all the sacrifice you made for us. Thank you for teaching us. Thank you because we are who we are really because of you guys, because you taught us, and thank you very much. So on behalf of the YBC class of 2000, we present the Teaching and Mentoring Excellence Award to you, Ma, Professor Abdul Karim Fatima, on today, Tuesday, the 16th of December, 2025.
We have an undisclosed token that we are sending to all the awardees, all our lecturers, mentors. Maybe some will be going on already and then some after, but we have a token that we are giving to them, just to a token of our appreciation, our love, our gratitude over the years. Dr. Abdulwari Akinshipo.
Sir, it's my pleasure to It's my pleasure to present this plaque to you. The Teaching and Mentoring Excellence Award presented to you today, Tuesday, December 16, 2025, in appreciation of all that you've done for us and you are still doing because you are still a faculty. And we thank you very much. Thank you, sir.
Okay, joins in the house. Professor Akinyede, Professor Banjo. So, is Professor Ogunlewe here? Okay, so quickly, Professor Ayobade Joma. I'm not like her lips are not even moving. To present this award, Health and Safety and Environment Specialist. Your house can't catch fire with Diola there, you know. Yeah, you know now, you know. Dr. Diola Eko.
So on behalf of the class of YBC, the class of 2000, that's Y2K, would like to present this award to you. Thank you for being a mentor, for being somebody who gave us, a lot of us, words of encouragement whilst we were in school. You were quiet, but you had this quiet strength, and you transmitted it to us, the students, and we're very happy to be able to present this little token to say thank you for everything that you did for us, and for all that you continue to do for the College of Medicine. Thank you.
Next is an awardee who probably comes from 2 or 3 generations of professors. I don't want to give my own lecture, so I'll just simply say the former or past Provost, College of Medicine, University of Lagos, should step forward. Professor Leshi Folusho Ebun. and Deputy Vice Chancellor, Development Services, University of Lagos, Professor Afolabi Ebun Folusholeshi. And to present that award, you see a collaboration here between the plastic surgeon and the pediatrician. Aha. So Big Ben is going to give his lecture all over.
So.
Ben Bule, ladies and gentlemen.
Professor Leshi, one of my first memories of this gentleman here was thinking when I first met him that, oh wow, you can be a doctor and still be cool and dress well. and I'm very pleased to say that it hasn't changed, and I'm trying to, emulate. But anyway, this is from the class of 2000, YBC Y2K. We're still very busy, and we want to give you this Teaching and Mentoring Excellence Award, presented on Tuesday, December 16, 2025, to Professor Afolabi Leshi.
You didn't invite us when the baton was handed over, so this is YPC Y2K asking you to still hand over the baton by giving Professor Ayodele Ademola Orebosu his own award. Okay, from YPC Y2K class, Simi will join them. Ageless Simi, clap for Ageless Simi.
How are you? So just a correction. I was the 14th provost. Then there was the 15th provost. And Professor Remusu is the 16th provost, I believe, yeah? So there wasn't a direct handover. But on behalf of the YBC Y2K class, this Teaching and Mentoring Excellence Award is being presented to you, sir, Professor Ademola Ayodele Oremosu, the current provost of the College of Medicine and a teacher of this class. Congratulations.
Professor Alero Roberts, please. And to give that is Dr. Victoria Egunjobi. Dr. Victoria Egunjobi is a 3-time graduate of the College of Medicine, University of Lagos. She has 3 degrees from this great institution. Ably supported by Tosin Kayode.
Okay, thank you very much. Good afternoon. Tosi and I are presenting on behalf of the YBC Y2K class this Teaching and Mentoring Excellence Award presented to Professor Mrs. Alero Roberts. Today, Tuesday, December 16, 2025. Congratulations, ma'am.
Mommy at the Faculty of Dental Sciences, College of Medicine, University of Lagos, Professor Mrs. Akeredolu Patricia Adetokunbo Patricia Akeredolu. I'll call on our Symposium chairman, Professor Aziz Butali. Professor Aziz Butali. Okay, please step forward, ma'am.
Can I have the dental class of 2K join me here, please? Dental class, please.
So this is very special. No, it's not partiality. I'll tell you why. So Said is claiming that she's her mom. She's his mom, right? She's my own mother, first mother. The thing is, after my father called me professor when I was in high school, the other first person to call me professor was Professor Akewedu. And this was during one of our presentations. When I gave a presentation on guidelines, we used to think they were physical, but I went to the library and I realized that they were imaginary lines. So when I gave that presentation, she just said, Professor, we were born you. And she took me to the clinic to make that presentation to the residents because we were all confused. We thought it was physical. But guidelines are imaginary lines of insertion and removal of dentures. So, for me, this is personal. I'm very grateful to God that we're here to celebrate you and to thank you. Thank you so much, Ma. So, on behalf of the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000, I'm proud to present this Teaching and Mentoring Excellence Award to a mother, a teacher, and a passionate counselor. She tells you beyond the class. Professor Mrs. Akewedu Patricia Adetufumo. Class of 2000 Dental, please join me for a photo with her.
More than. So I think I was in the clinic area that was dressed. Don't forget, sure, skirt. To school today. She said, I don't want, she dragged me in like this. It was the dress and the sleeves were like a little bit, and she said, no, I said, Ma, I didn't come to school today. She's like, let me do it. She dragged me out. So yeah, she sent me home. She sent me home for wearing the short skirt. And I was like, oh, okay, man.
Yeah, that's the mother in her, and we appreciate you.
I think it's quite interesting.
It shows he studied embryology.
So on behalf of class 2000 YBC Y2K, I'm presenting this Teaching and Mentoring Excellence Award to Professor Ayokogbe Olayinka on this day, Tuesday, December 16, 2025. We thank you so much for the mentoring and all you have done for our class. Thank you. God bless you.
The next award goes to Professor Ojini Francis Ibe. Ojini Francis Ibe, kindly step forward. Thank you.
Is it Tosin Odesonya that Kayode that is coming forward? One more YPC rep.
YPC!
Omalade, you can step forward, please.
Professor Francis Ibe Ojini. It gives me great pleasure to be presenting this fantastic award to yourself.
You won't leave here today.
You know, when I was in medical school, we just used to look at Dr. Ojini with, you know, the consultant with the swag, you know? You know, and when he's teaching us, he's always very gentle, very cool, very calm. And I remember the day I met him for one of my exams. I did very well. You know, you've been praying to meet Professor Ojini when you are having your exams, whatever it is. And I did, and I was so grateful to God. And then, you know, neurology. I didn't like neurology, but as soon as I met Dr. Ojini, hey, it became a part of me. So I want to present this award to you, sir. A Teaching and Mentoring Excellence Award. Today, December the 16th of 2025. 25 years post YBC Y2K. We love you and God bless you, sir. Thank you so much.
Thank you.
Yes, sir. Yes, sir.
Professor Temie Adamison Olusoji. Professor Temie.
Tosi. Incoming Chairman Chudi Osegbe. Incoming YPC Chairman Chudi Osegbe. You're welcome. The name is Edami Son, Professor Edami Son. Okay.
So I want to say first that in medical school, we have pre-clinicals before clinicals.
Okay.
And we don't seem to understand the reason why pre-clinicals are there until you get into clinicals. Yes, you are cramming all those things those days. By the time you get into clinicals, everything now makes sense. So I thank you for the knowledge you impacted in us. And on behalf of the class of 2000 YBC Y2K, I'd like to present this to you, Professor Temie Edomeso Olusoji, this Tuesday, December 16th, 2025, the Award for Teaching and Mentoring Excellence Award. Thank you, sir.
Professor Bankole Olufemi Bankole, are you there, sir? To present this award is Dr. Tolu Akilo, one of our teachers. He really impacted me personally, you know, and at that time he was so young. You remember? One of the youngest, fine young man. I'm a guy, so there's no problem. But you understand, you remember? He was amazing, but he could be harsh. You remember that too? And no boy, it really impacted me. I'm not even joking. I really loved general surgery. At that time, general surgery, you know, so it was worth it. It made medicine lovely. That's all I can. So, the College of Medicine, University of Lagos, Medical and Dental graduating class, we are presenting this to you, Professor Bankole Olufemi B, on Tuesday, December 16th, 2025. Teaching and Mentoring Excellence Award. Thank you. God bless you. God honor you. God promote you. God establish you in Jesus' name. So Professor Duru Francis Ikechukwu. Amazing. I was looking at Professor Duru since, and because he's attired as an Igwe, or like an Igwe, I didn't recognize my own teacher. Today, sir. Welcome, sir. And congratulations, sir.
Good afternoon, Professor Duru. I actually fought to do this one because I remembered a story you told us, and it stuck to me for years. Yes, I want to repeat it. Yeah, they told me. When you told us that a virgin got pregnant, can you remember the story? We're doing pelvis and perineum in anatomy, and he told us this story, and that really messed up with our heads because we were like, how? And he gave us as a quiz, go and think about how it happened. So I'll be catching up with you later to ask you. But I could never forget that story. I remember it. Thank you so much for making anatomy fun. You used to crack a lot of jokes. You used to make it a fun class for us. Thank you so much. And on behalf of YBC Y2K class, we present this award for Teaching and Mentoring Excellence Award presented to Professor Duru Francis Ikechukwu on Tuesday, December 16, 2025. Thank you so much. And they will sort it out for you.
The representative of Professor Adebayo Onojole should start stepping forward as we receive another YBC member to present this award. Aloysius Inokomo. Aloysius Inokomo, obstetrician and gynecologist at Bagada General Hospital.
Thank you very much. Probably maybe because I came a bit late, that's why you set me up. Because I'm trying to figure out who I'm presenting the award. No problem. I'm sure he probably was one of my teachers. I had many teachers when I was there, and I'm quite grateful to all of them. I'm sure you are representing one as you're standing. So, the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association gladly present this award to Professor Onojole Adebayo this day, Tuesday, December 16, 2025, for being an excellent teacher and impacting on all of us. Congratulations. Thank you.
Professor Omilabu Sunday Aremo, who also will not come to class with any notes, and then you end up with higher education filled up. As he steps forward, I want to recognize a public health physician of distinction, Professor Oshibogunsa, former CMD Lutz, Professor of Public Health. Professor Oshibogun, we recognize you, sir.
Thank you very much. I don't think it's a coincidence that I was asked to present this particular award. So, Professor Mbakwem is a mentor, the teacher, and I dare to say, my friend. So I'm very glad that I'll be given the privilege to present this award to you. On behalf of the YBC class of 2000, the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, Teaching and Mentoring Excellence Award was presented to Professor Mbakwem Chinyere on this day, Tuesday, December 16, 2025. Thank you very much for being an awesome teacher. I love it.
Dr. Omilabu, sir. Sunday Aremu Omilabu, Professor. Sorry, Professor Omilabu, Professor Sunday Aremu Omilabu. Please step forward, sir. Can Majesty S-boy please come and give Professor Omilabu. Dr. Somi Eson, please step forward. Cardiologist, electrophysiologist. My Michigan clinic. Please step forward to give Professor Omilabu. Okay, Dr. Ogunwale, endocrinologist and diabetologist. Let's give him a round of applause, Dr. Ogunwale and Dr. Nana Habib Adeyemi.
Okay, remember those days that in particular we mentioned two viruses, chikungunya virus, oyang virus, virology. Thank you very much, sir. Okay, thank you very much, sir. Those are our memories, and it helps us to remember. In class, I don't like to read too much, so once I just close my eye, remember those words, I know what is being asked for. Thank you for. Virology was abstract to us, but you made it interesting in your own way. and we are grateful for that. Thank you very much. On behalf of YBC Y2K, the ever busy class, we present this Teaching and Mentoring Excellence Award to you. Today, Tuesday, December 16, 2025, Professor Omulawu Sunday. Thank you, sir. Thank you very much. Congratulations.
Okay, yeah. Present it.
Okay. Thank you. Thank you. Where's the award?
Sir, on behalf of the College of Medicine Y2K class, YBC Y2K, it is our distinguished pleasure and honor to present to you this Teaching and Mentoring Excellence Award to Professor Akinsoya Olajide Oshibogun today, Tuesday, December 16th, 2025, for all your love, for your care, for your support, for your warm words. I think it's nice to be able to say, as a public health physician, I don't think there's any public health physician in Lagos today, and maybe a larger percentage in Nigeria who have not passed through you. So we say thank you for your support to the cause. Thank you, sir. The public health people have come on.
Cardiologist, my Michigan Clinic, Michigan, USA, to present this award to Professor Mrs. Adetola Olubumi Daramola. Okay. Banjo. Oh, sorry. Why am I missing two?
He's not here, but we can.
Okay. So, sorry for the mix-up now. So you collect, Professor Banjo will be collecting that award on behalf of Professor Olubumi Adetola Daramola. S-boy.
So on behalf of the class of 2000 YBC Y2K, we are pleased to hand Mother Teaching and Mentoring Excellence Award from the YBC class of 2000 to Professor Banjo Adekun Biola Aino on this day, Tuesday, December 16, 2025.
Thank you very much. Thank you.
Oh. So Professor Onokoya will be receiving an award, and to present that. Yeah. So, one-time VP2, Nigerian Medical Association. This is a politician standing before us. Let's put our hands together for him. Dr. Adenekon will be receiving the award on behalf of Professor Mrs. Adiola Onokoya. To do that, we call on Dr. Tolu Akilo, quickly. Tolu, you won't speak few words, so you read everything there.
On behalf of the YBC class, we, the College of Medicine, University of Lagos, Medical and Dental Graduating Class of 2000 Alumni Association, YBC Y2K, This is the award for teaching and mentoring excellence, presented to Professor Mrs. Onokoya Diola O. Today, Tuesday, December 16th, 2025. Thank you. God bless you.
Professor Nwawolo Chukwemeka, are you here, sir? Please, let's give him a round of applause as he majestically steps forward. Incoming Chairman Chudi Osegbe, please step forward to present this award.
I stand here on behalf of the YBC Y2K class to present to you, sir, Professor Nwawolo Clement Chukwemeka, this Teaching and Mentoring Excellence Award, today, Tuesday, December 16th, 2025. Thank you, sir, for all you have done to us in our lives. Thank you.
Dr. Tony Amefula and Dr. Inokomo, please step forward as you present this award to Professor Mrs. Oduwole Abiola Olanrewaju Oduwole. Tony, don't rush out. Nana has been stepping up to hug them since. She didn't step up to hug me once.
On behalf of the YBC Y2K Ever Busy, the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, we're presenting this teaching and Mentoring Excellence Award presented to you, Ma, Professor Mrs. Oduwole Abiola Olanrewaju, today, Tuesday, December 16, 2025.
Is Professor Adesonya Adedoyin Adekunle Adedoyin Adesonya here? Please step forward. As we present the next award to Professor, a phenomenal teacher. I don't know how many of the YBC members read his write-up concerning this program. Phenomenal. Olugbenga Abayomi Okonlawon. Professor Olugbenga Abayomi Okonlawon. Phenomenal teacher. Okay. This is a phenomenal teacher. Simplicity defined.
Thank you, pleasure.
Always cracking jokes, made anatomy. Now that all of you have come upstairs, who is going to present the award?
I remember Professor Okonlawon. He used to tell me then that you're my daughter, you're my teacher's daughter, so you have to do well. Mr. Akisoye from Baptist Academy.
So it is with great honor on behalf of the College of Medicine, YBC Y2K, that we recognize you for teaching and mentoring excellence. Thank you so much, Professor Okolawo, for everything. We're deeply appreciative of your sense of humor, your sense of style. We're very grateful. Thank you.
Provost is coming, please. You can imagine, he is the teacher of not just the provost, he is the teacher of the college itself. He taught the College of Medicine itself.
Yes. So proud of you. Thank you.
Oh.
Thank you very much.
And the Queen of Hearts happens to be his classmate. Thank you. Okay. Malade and Tope, please stay behind to give this award to Professor Akinyede Akinkumi. Akinkumi A. Akinyede Triple A. Professor Akinkumi A. Akinyede. Let's give him a round of applause as he steps forward. Obviously a gentleman. You're welcome, sir. That we should have given the award. Oh, okay, this should be Akinwumi, not Akinkumi. Okay. Okay. So, point of correction, Professor Akinyinka, Akinwumi, Akinyede, the guy who inscribed it, spelled it according to his own tongue. Yes. Akinyinka, Akinwumi, Akinyede. In any case, it's still Triple A. Many congratulations, sir. So, who's presenting? Tope Masha. Sir, this award is coming not just from YBC, but from the presidency now.
Thank you. So this award is presented to you from the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, the YBC Y2K. It's the Teaching and Mentoring Excellence Award presented to you, Professor Akinyede Akinwumi Akinyinka AAA. Tuesday, 16th of December, 2025. Thank you so much.
So, the short lectures on discovery science, I just want to say, on behalf of the class, to all our awardees, that it is not only the plaque that we are giving. We've had some will I qualify the logistic challenge, and so the other gifts has not been able to be packaged, well enough for everyone, but we're going to give those that are present here, because there's a token appreciation from the class. So there are some blue boxes that our chairperson is going to give, and let me just say that there's just something little in them, and it's supposed to go to all the awardees. And so what we will do is that those that receive these boxes will have their names. Those that do not, we will reach out to them, because we can send it to them electronically without saying too much. So even what we have here is just for 5. There are some other boxes that will be given to others, and we will give. So for those, if you don't get a box now, if you can wait a bit, you will get a box. Otherwise, we will get your details and we will send the contents of the box to you. So prayers, yes, for our teachers, something better than prayers. Prayers. Okay, what can be better than prayers? Prayers in physical form, answered. Thank you. Before we go over to the next set of awards or awardees, there is an award for a very, very special person. Everyone is special, but this one is special amongst the special. But before we do that, we're going to call on Somi Eson to do a citation, brief citation of this next awardee, a fantastic personality, Somi Eson. So we'll be giving this award. This particular personality will be getting 2 awards today. We'll announce them, but the citation first.
So this is a seminal moment for me, Ben, come, or for us, because you rise on the shoulders of those who have come before you, and inspiration comes in a twinkle of an eye. And so this personality, because I can't really call her by her name, is a titan, is someone who has shattered glass ceilings involving gender barriers in a male-dominated field, and she has done it with beauty, grace, and poise. To say that she is amazing is an understatement. She is a graduate of this esteemed institution, the class of 1980. And since then, she has blazed through different continents, including Madison, Wisconsin, where my parents both went to school, crossed over to Australia, and landed here somehow. We managed to grab her back here in Louth, where she has inspired so many of us. This is a journey that has come full circle. Unlike Uzoma, my best friend, I knew that I was going to be a cardiologist after my one encounter with her, clinically. In Louth, as medical students, we never really, at least I didn't, never really had the opportunity to read ECGs in a routine fashion. And so, to me, it looked like a high-polluting tool that you will never be able to understand. And suddenly, Professor Ajuruchukwu just walks in and just looks at the ECG and just immediately spot diagnosis. And she did it over and over again. I thought she was a winch, but that's just me. But she demystified it. She demystified it. And that was the way she has always carried herself. The way she conducts her ward rounds. It wasn't a ward round of you stand there and I'm going to be pimping you with questions. It's a ward round of you sit down, colleagues, you discuss what you don't understand. She will teach you. She's not just a brilliant cardiologist, but she's also Obi and Ifeanyi's mom. She wears those hats. And so it is really phenomenal to see her juggle all these things, break glass ceilings, women doing fantastic things in medicine is something that she has pioneered and she has championed. Ma, there is no cardiac electrophysiologist without you. There is no Bosse Afolabi, clinical cardiac electrophysiologist without you. We stand on your shoulders. You demystified arrhythmia, and that's why we are here. Well done, Ma. You deserve your flowers. We are so, so proud of you.
I need my help now.
You deserve your flowers. Yes. Well done, Ma.
I mean, all your students here have achieved a whole lot, and listening to them, they are very, very successful. How would you, what would you advise them to contribute more to the Nigerian healthcare system? With what Nigerian healthcare system is at the moment, what do you think they can contribute to help it be better?
Well, we have had a symposium and we already know that they're on the track. They know where they started. They have a heart for home, and they're already telling us we are available. How do you need us? So it is us also that will say, this is where we need you. So they are ready, they are willing, they have achieved, and it's for us to also do our homework and also articulate where we would need them most. Okay, so we at home also, we have our homework to do, but we know that they have achieved, they are available, and that they are there for us. So that would be my...
So how does it feel? How does it feel seeing your students after 25 years?
I am so excited to see them, and then some of them look so young, they don't even look 25 themselves. And then to think that they were already in school 25 years ago is very heartwarming, and they've done very well.
You're really proud of Judge?
Yes, I am. And they have also done us proud. They have this particular set, they invited all their teachers, and showed that they appreciated what we have done. So this is the first of its kind. So they have a large heart, they have a heart for giving, and this particular set also, they have done so much for students, for infrastructure, and this year they remembered their teachers, so we are also proud of them.
So I want to ask the question that's on everyone's heart, especially for those of us who are not medical students. What do you call the Queen of Hearts?
If you're given a name, I think the question would go to the person that
Excellence
called you that
Award
name. So one or two people have asked me that question, and I always say, go ask the people who call me that. So that is what I will say.
Thank you so much, ma'am, for your time. Really appreciate, ma'am. Yes, ma'am. Thank you, ma'am. Yes, ma'am.
Congratulations. One more award from the provost.
Yeah, well done, Ben Wigley. The reason why the two awards are not joined together is that Ben separated them. It's also my singular honor and pleasure to do this for Professor Ajuluchukwu. In recent times, we've had almost 3 ceremonies like this. So I want to, on behalf of the Y2K, present this award of appreciation to you, Professor Jane Ajuluchukwu, as chairperson of this symposium on reverse in medical tourism. And this is being presented at the 25th anniversary celebration of the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, YBC Y2K, presented this Tuesday, December 16, 2025. Congratulations, man. No, I'm... Someone collecting on his behalf. So, yes, right. Okay, ma'am. Incoming chair, please come and present this award to Professor Aino. We are baptizing you with YBC work. Dr. Adegbite, you're welcome, ma. He's collecting this award on behalf of Professor Olatunji Aino and presenting his incoming YBC Y2K chairman, Dr. Chudi Osegbe.
I would like to present this award to Professor Aino Latunji, a Teaching and Mentoring Excellence Award from the College of Medicine, University of Lagos Medical and Dental graduate students of class of 2000. This Tuesday, December 16th, 2025, for his contribution to our life. Thank you, and thank you for holding this award.
On our public health and public service series, we want to call on Dr. Simisola Alabi. Dr. Simisola Alabi, MBBS, MRCGP, MSc Health Policy and Leadership, DRCOG, DFSRH, PGCET MedEd, is a distinguished public health physician and health policy consultant dedicated to advancing equitable healthcare in Nigeria and beyond. As project lead for Nigerian's Pathways to Malaria Pre-Elimination and Digitization Project, she drives PHC protocol development and digital health innovation. Dr. Alabi also advises the Lagos State Ministry of Health on policy and strategic initiatives, while founding the Dr. Simisola Alabi Foundation to tackle childhood stunting, maternal health, and social insurance access in underserved communities. A passionate educator, she teaches at Imperial College London and mentors primary care specialists. Recognized for her impact, Dr. Alabi has received multiple awards, including the Advancing Health in the Community Award and Powerhouse Global Awards. Please, a round of applause as we welcome Dr. Simisola Alabi.
That was done. Hi, everyone. Okay, I'll get my slides up first, and then we will. Oh, standing on existing protocol, but I have to recognize the provost. Thank you so much. And the chair of today, Professor Ajulu Chukwu, one of our best teachers ever. Even for me, thank you so much, Ma, for everything. So this is going to be a very, very interesting. The noise makers will always make noise. I can name them with my eyes closed. Toasting. Yeah, number one. I won't call the other people. Toasting is you. Toasting, you are the instigator. Come and stand here next to me. All right, okay, so let's on a more serious note, I'm very honored to be here. Before I actually go straight into it, please put the first slide, next slide, please. I want to make two comments about two things that were said earlier today. First thing, I know you guys will like that picture, that's why I put it there. All right, look back to me before we go back to that photo. Sorry? I should read it. Okay, she's here. Oh, how lovely. No, stay there for a minute, just for a moment. She's my friend, she's my sister, so she's supporting me. There are two things were said earlier today. I was listening to. One was Dr. Ohiri said that you can't just pack up your practice and move. I beg to differ. You can do. You can do. Wherever you are, you can do a bit more back home. You can do a little bit more and contribute. Second thing that I heard today was Professor Leschi said, Provost needs more support for the hostels. And if you guys remember, I've been doing the hostels, so we'll need more from you to join to do the female hostels particularly. So that's the two things I wanted to bring up today before we start. Okay, Sophie, I'll release you. You can go back to your seat now. Thank you. All right, first slide now. So my talk is on public health as a legacy. What will we be remembered for? And it's really all about legacy. And I put that first slide up. The first slide up to remind us where we started from. This first picture was us in this. Okay, so this first picture is us in this same hall 25 years ago. And then the picture after that, who remembers that picture? The one where we're all smiling on Makoto, yes, and that was my little group. I cooked the whole week for everybody that week, cooking fresh fish, making food every evening, and as a reward for my cooking role. I think me and Kavita were put in the chief's house. So we stayed with the chief while the men went to, I don't know where they stayed, I'm not sure. Okay, so 25 years ago, we left Idiaraba with excitement after an intense 6 years of extreme hard work. We had a very clear sense, or at least I did, of who I thought I was going to become. We were young, we were ambitious, we were often exhausted by the 4-day on-calls. I don't know if anybody else remembers those on-calls. We did our youth survey, some of us stayed, some of us emigrated. We were quietly hopeful. We were determined to be part of protecting, promoting, and improving health before people get sick and reduce the harm caused by illness. We spoke about becoming consultants, surgeons, leaders in our field, getting married, having children. If you remember the yearbook, we had all sorts of things in that yearbook, if you all remember. I remember writing in that yearbook that I was going to have 4 children. I did, in fact, too. And you know, we believe if we worked hard, excellence would naturally translate into impact. And in many ways it did. But 25 years later, the question before us is no longer about success. It really isn't. It's about legacy. So this will be 3 parts. The part 1 is where we started. The first 25 years, that made us all doctors. Idiaraba shaped us. It shaped me. It taught us resilience long before it taught us comfort. When I see my children now, they complain about some things, I think, goodness, I mean, you know, you guys don't even understand where we've come from. We've created, I think that resilience gave us the ability to give them the comfort that they have. We learned medicine in crowded rooms. They were asking me if I remember something. I can't really remember many things. I remember that big anatomy room. I remember Dr. Norona, you know, really grilling us in that room. I remember the little room on the side with the clean path and, you know, but it was a blur. All I wanted to make sure was that I didn't have any receipts, and I didn't have any. So that board, when I walked to that board, it had better be a pass credit or something, you know, just not a receipt. You know, we learned responsibility very early. We learned to make decisions that mattered. We made friendships that have now lasted decades, and many of our teachers have become our mentors, you know, and our big brothers, our friends, our fathers. I'm very, very grateful that we had that. Some of us moved away from home in search of the proverbial greener pastures. And we worked in the US. I mean, Gulie, what you described today is amazing, and we're all very, very proud. We're proud of everybody here. UK, Canada, South Africa, everywhere else, Trinidad and Tobago, Australia, you know, just shout it out. But there, I mean, I moved to the UK for 22 years. There we saw something different. You know, we saw clear pathways, we saw predictable systems, we saw structures that supported both patients and clinicians. But in all of that, home never left our minds. Whether you're here or you're abroad, home never left our minds. College of Medicine never left our minds. We continued to give back in individual ways or as a collective. For many of us, that contrast planted a question. If systems can work elsewhere, why not here? So that takes me to the second part. Well, that picture was of me when I first moved to the UK. I think that was my 2nd year. And that was at Royal Free Hospital, where I was SHO Obs and Gynae, because my path then was obstetrics and gynecology. I did 4 years in Obs and Gynae. And then, well, I'll go back to the previous one first. So that, over the last few years, some of us have not just practiced clinical medicine, we've also stepped into public health and public service, at home and abroad. Not because it was easy, but because the gaps were too visible to ignore. And for me, the biggest thing was the COVID pandemic. I don't know about you guys, but for me, it was the COVID pandemic. And that taught me 3 hard life lessons. And this was me in 2020, on the left here. At that time, I was the Primary Care Network Clinical Director in Luton, and then I was clinical lead for population health for the Bedfordshire, Luton, Milton Keynes region at the time. And as soon as I took on that role, I took on the role in July 2019, and then by January, the pandemic happened. And that's all the whole group of our team, when we were setting up to start giving the vaccine at the time, you know. So it taught me three big lessons. The first lesson it taught me was do what you must do today. Tomorrow is not promised. It will not be perfect what you're doing, but if it makes a difference to one person, that's good enough. This was the point in time when I decided I was going to do more back home, and that was when we started thinking about what can we do in the hostels and getting money together. Some people here donated, and even if it's not perfect, till today people come up to me and say, oh, you're the one that did the reading room, oh, you're the one that did that, not for the glory, but for the fact that just do what you have to do today. Whether it's good enough, whether it's not perfect, just do it today. And as doctors and as medical people, we like things to be perfect, and nothing is ever perfect, so do it today. The second thing the COVID pandemic taught me, because those days I would be driving down the roads of the M25 and M1, and it was empty, nobody. We're the only ones allowed to be outside because we're doctors. And I will have seen patients the day before, and the following day, they're dead. You know, we're recording 3,000 deaths a day at the time. You know, and I remember profoundly a young woman who was pregnant and a nurse at the hospital. She was one of our patients in my practice where I was a partner. We'd seen her, and the next time she was dead. You know, it was a time that was very sobering, and it changed our lives. So the second lesson it taught me was this: you go further when you go together, always. You know, the progress we make in caring for ourselves at the time could not have been done in silos. No, we like silo working, you know, but it couldn't have been done in silos at the time. The world came together like it had never come together before to tackle that scourge, and because we were together. So I'm very lucky, we're very lucky that we have YBC, Y2K, because we've always worked together. You know, all of us here are networked in some ways. Moving back, when I moved back home, I mean, Victoria is here, I'm always in her office, Talkwell's on her Nana, you know, it's because we're together. Butali, we all do things together. You can't do it alone. So remember to always, you will go further if you go together. And then the last thing, the third thing it taught me was love. My daughter always says, Mommy's always talking about love all the time. Love was the last thing it taught me. At that time, my father passed during the pandemic. It was tough, and all of you here rallied around me and supported. That was really tough, because I couldn't come for his actual funeral, and I came a few months after. Love clearly and love unambiguously. Surround yourself with people that actually care about you and people you care about. That's your anchor. Everything else is irrelevant. I'm telling you, trust me. So when I came back, my first assignment was working in Lagos State on the malaria pre-elimination project and primary care strengthening, and also as a technical advisory at the Ministry of Health, which I am still doing. That was intense, a privilege and critically important. But what I also learned from this assignment, I'm still learning because it's still ongoing, we finish it at the end of this month, is that patients do not experience the system in fragments. So if you say I'm a great doctor, it doesn't matter if you are a great doctor, if you don't have a great nurse, you don't have a great receptionist, you don't have some, you know, it's a whole pipeline, the whole system. You know, so they experience outcomes. They don't experience great doctors. When a fever, and this is talking about fever now, because we developed the malaria negative fever protocol as part of this process, which I'm very, very proud of. So if you want to see it, please ask at the end. When a fever is mismanaged, when referral pathways fail, when data is missing, people suffer, they suffer quietly, and they suffer repeatedly. It's constant suffering. So with Lagos, you know, with the whole idea of malaria, when everybody's being given ACTs, given medication, antibiotics, they are suffering because actually they didn't need it. Malaria in Lagos is only 5% positivity. We don't have malaria in Lagos, not at the scale that we think it is. So what changed for me with this job, and I'm talking about public health now, my public health role, what changed when clinicians are engaged, you know, it was not just about policy on paper. It was translating that policy into action. Clinical insight shaped the protocol. The frontline realities informed the decision. So it was basically the health information officers, the OICs, that were actually shaping those decisions that were being made. Digital tools were designed with patients and providers in mind. In fact, the ministry, I think Bimbo is gone now, we developed the protocol together with the patients, with the ministry, with external stakeholders. It was slow, but actually the impact was much better. So this work reinforced for me a simple truth. Public health moves when doctors show up, not as critics, but as contributors. And it taught me this: public health is not abstract, it's practical, it is slow, and it lasts. You know, when I was in England, we always say, oh, Nigeria is terrible, this is bad, this is bad, this is bad. You know, it's easy to speak, it's easy to criticize. What is more difficult is actually action, sitting down and doing the work. And I'm very glad that I was able to be involved. That takes me to part 3 and the concluding part. So that was me coming back home. And the first picture is me at New Massey Street. And second one was in the room at Lashma. So we're trying to get Lashma to pay for the fever, to pay for the patients that go to the PPMVs and test for malaria. And when it's negative, rather than give them medication, they send them to the primary healthcare centers. And we wanted Lashma to hold that managed care plan and pay for it. So we're here just talking about the managed care plan and what will be paid for. So the part 3 of my talk is the legacy work. So this brings us to the next 25 years. So we've done 25, now the next 25 years. What is next for us, YBC, Y2K? YBC, Y2K, so busy. What's next for us? What's next for us? Legacy, thank you. And actually that's what my talk says, the legacy work is what's next. This phase of our lives is no longer about accumulating qualifications or proving competence. We have done that. Whatever degree you have, even if you only have MBBS, that was already hard enough. We have done that already. It's about consequences. Public health is where legacy lives. It is where individual excellence becomes collective protection, where medicine stops being episodic and it becomes structural. None of us need to leave clinical practice to contribute. You can continue practicing. It doesn't mean you have to leave your practice, but you can still contribute to how this Nigeria improves. What can legacy work look like? What can we do at YBC, Y2K? You can do advisory roles. You can serve on board from wherever you are across the world. You can mentor younger doctors. You can help shape policy. You can support primary care. And I'm happy to introduce you to whoever you need. You can invest in prevention. You can lend your credibility to decisions that matter. Not as coming in from abroad, but as being part of the system. Being part of the system. If clinicians do not occupy these spaces, others will. And the others will do it without an understanding of the consequences on the ground. So we are the generation with experience, with credibility, and with a voice. The question is whether we will use that voice. So in closing, we have spent our first 25 years becoming doctors. The next 25 years, we have become accomplished professionals. Now we are being invited to do something deeper. What will remain because we were here? What will be left because you were here? You know, public health is not a career detour, it's a legacy platform. And when the story of the healthcare in Nigeria is being told, may it be said that our generation did more than succeed individually. May it be said that we helped build systems that worked. Thank you for listening.
Powerful words, very insightful words. Thank you very much, Dr. Simisola Alabi, for that word of encouragement. She said, do what you must today, tomorrow is not promised. And she also said, public health moves when doctors step up, not as critics, but as collaborators. So please, a warm round of applause for her once again. Thank you very much, ma. Okay. Next on the Discovery Science and Clinical Translation series, we'll be calling on Dr. Nana Fatima Murtaza Habibu Adeyemi. Dr. Fatima Adeyemi is a distinguished obstetrician, gynecologist, and certified minimal access surgeon with expertise in fetal-maternal medicine and gynecology. Her impressive credentials include MBBS, DRH, DMAS, FMAS, FWACS, and MPH from the University of Leeds. Dr. Habibu Adeyemi has pioneered initiatives like the Mother and Child Unit at Evercare Hospital, Lekki, and founded Pearl Specialist Medical Center and Pearl Specialist Foundation. She is a highly sought-after consultant, serving as medical director and local consultant at various hospitals, and has received awards for her outstanding contribution to obstetrics and gynecology. Everybody, a round of applause for Dr. Nana Fatima Habibu Adeyemi. Thank you.
Thank you, Dr. Mercy Elijah. Just before Nana starts speaking, we have our AGM after this occasion, and yet we still have the finals of the YPC Y2K Femi Lawal Tennis Competition, 4 p.m. So let all our speakers going forward be mindful of that. Thank you.
Thank you very much for giving me the opportunity to speak. I want to stand on the existing protocol, and I want to gain some strength from the earlier speakers. Just talking about legacy, like Simi just said, in 3 parts I'll also be giving something on uterine fibroids, and the reason why I started with uterine fibroid, but I'll be fast with that. Then I'll just give 2 rare cases that happened to me in that was involved in obstetrics, then round it up with what I feel is one of the legacies I want to give back to the society. I'll just go through this outline and ending with the PSL, which is not on the board there. So as a form of introduction, Boulier spoke about a rare thing, that Siamese twins. I will be talking about something very common among women. Is one of the commonest gynecological cases we find in women, and we have the commonest among us black ethnicity. It's about 5 times common among us. If we take about 100 uterus after surgery, about 80% of it will have uterine fibroid in them. Now, what are fibroids? Fibroids are known as uterine leiomyomas, benign tumors that grow in the uterus. They are a common condition affecting many women of reproductive age. It's normally found in the reproductive age women. However, these days we tend to see them in younger women as well. And going into the extreme of the ages, if it is not dealt with there, in very rare cases, about 0.1%, they transform into what we call leiomyosarcomas, which are cancer. So it's important, when I see elderly women, I tell them, if there is no symptoms there, yes, we leave it. But if we suddenly find a fibroid that is growing and is giving pain, then it's a red flag. We need to deal with it. So fibroids, they can be very varied in size. We can have sizes from what the naked eyes cannot see to very large sizes, bigger than babies. I'll show some as we go on. And you can see as little as 1 fibroid in the uterus, and I've been involved in a surgery where we removed about 60 fibroids. We were on an outreach, and recently I removed 55 fibroids. The person is here to give testimony. So that's a normal uterus on my left side, and on the right side we have a fibroid-ridden uterus, showing the different types of fibroids. We have the pedunculated hanging at the top there, subserous on the body. We have the ones that are intramural, in between the myometrium of the fibroid, and the endometrial ones just inside the endometrium where the baby is supposed to be. So like I said earlier on, about 50 to 70% of women will have it, and all these are said earlier. So generally, the causative factor of fibroid is not really known. However, we found out that in a family where there is somebody that had fibroids, the females in that family have higher chances of having, so it's genetical. And the hormones that are estrogen and progesterone also encourage the growth of fibroid and the growth factor in the body. However, we can't pick on a particular thing because there are people that even all these three, they are normal, they are not in any abnormal rate, and you still see them having fibroids. Then we have what we call the risk factors. I've been mentioning we black having the higher risk, so that's the black risk. Family history, early menarche, obesity. Most of the time in the very obese women, you will find out that they have fibroid in the uterus. Then hypertension and nulliparity. We have this slang in the ONG parlance that a uterus that does not carry baby will carry fibroid. So what are the symptoms? The symptoms of fibroid are just mainly mainly as impact, as a reflection of where they are, and maybe pressure symptoms. So, and sometimes they could just be asymptomatic. So it's not all fibroids that we go after for removal to operate on them. There are some you just watch. That's conservative management. It causes a lot of menstrual irregularities. If any woman comes in and says, I'm seeing blood after my period, there are many things that can cause that, but one of the things is fibroid. Then, as a result of bleeding, fibroid, when it's in the endometrium, that's where the baby is, it increases the surface area. So such women, we have what we call menorrhagia, excessive bleeding. And from excessive bleeding, it can lead to anemia. And we all know what the symptoms of anemia is. That's the fatigue, dizziness, headaches, and all that. And because it's in the pelvic, sometimes it's pressing on the bladder, causing excessive urgency and excessive micturition. Then, depending on the area and where it is in the uterus, if we have ruled out everything causing infertility and in a woman, and the woman has fibroid and she's still not getting pregnant, then we have to go after the fibroid to remove it. Of course, cosmetics impact of swelling of the abdomen. You see some women, they'll be telling them, Asokale Anfanio, that's the Yoruba language, trying to tell them that may you deliver your baby peacefully while they are carrying fibroid, which is not baby. So this summarizes the impact that I can give depending on the location in the uterus. A submucous fibroid, what it gives, and the intramural, subserous, and the pedunculated one. Also, there are complications that arise as a result of the presence of fibroid in pregnant women, and I've actually mentioned this, and the non-pregnant woman and pregnant women. This gives us some of the things we see in pregnant women. There is what we call rare degeneration. They have sudden pain, intense pain. These occur as a result of the sudden growth of the fibroid and it overgrowing the blood supply. So there is necrosis, and you know what happens now, all the charade of things that occur, and it causes pain. Sometimes it can cause preterm labor and placenta abruption. If the baby's placenta is attached to a fibroid, it's not a good attachment, and anything can happen from that. And as a result of a fibroid in the cervix or the lower segment of the uterus, it can lead to the baby not rotating to the cephalic position, causing malpresentation. Also, it could cause obstructed labor. If a woman is not properly cared for in pregnancy and has fibroid, goes into labor, the woman may keep, the uterus may keep contracting till, and they are waiting for baby to come, and this can even lead to uterine rupture if not well taken care of. And in a uterus that is carrying fibroids, After delivery, contraction of the uterus leads to the closures of the blood vessels that have opened as a result of the detachment of the placenta. But in the presence of a fibroid, the contractions will not be effective and the blood vessels are left open. So the woman keeps bleeding away. So it's very important to take note of this and put things in place to prevent postpartum hemorrhage. And because of fibroid, in most cases, not all cases, that a woman that is pregnant will have to have cesarean section. But most cases, if they are on the lower segment, or depending on the size, the woman may be planned for cesarean section. How do we manage fibroid? Like I said earlier, we have to individualize this patient. Is this person still desirous of conception? If she's still desirous of conception, there are various methods that we can use to manage the fibroid. If not, we can just manage it conservatively, giving medications to make the quality of life of the patient better if she has symptoms. Otherwise, if she doesn't have symptoms, she just leave. And in this management, we can have the medical management, we have the invasive management, and the surgical management. The medical management includes using drugs like NSAIDs, it includes using hormonal medication as well. And when we talk of minimal invasive, we can talk of the uterine artery embolization, which is done by radiologists these days. The blood vessels, the uterine artery is obliterated by sclerosants. It blocks it, there is no more blood reaching the fibroid, and sometimes it shrinks. Most of the time, it shrinks to about 50% of its size. Then when we come to surgical management, part of the non-invasive is also using laser. There are laser treatments these days, and there is what we call ultrasound guided. Sorry, I'm going so much into the management without investigation. After the history, we have to examine the patient and we do our investigations. And under the investigation, that's where we know some of the complications that is coming. Maybe we take the full blood count, electrolyte, urea and creatinine, because sometimes they have the kidney impact as well. Then we do imaging studies. We have to do scan, transvaginal scan. Sometimes we need to do an MRI to differentiate a large fibroid from a leiomyosarcoma. The MRI is very important in differentiating that. I think I've spoken about this. I had the surgical left. Under the surgical, we have open surgeries and we have endoscopic surgeries like hysteroscopy. That's for most times fibroids are in the endometrium. Then we have the laparoscopic surgery as well. Yeah, these are what I've mentioned earlier. Hysteroscopic, laparoscopic, robotic surgery, open, and the definitive treatment, which most of the time is very easily given abroad, is hysterectomy. Once the uterus is no more there, you can't think of the fibroid recurring, but because there is a 20% chances of fibroids recurring. So these are some of the fibroids we have dealt with during my time. Yeah. Can we prevent fibroids? There is really no known prevention, but it's been said that lifestyle modification, eating healthy, doing a lot of exercise will help. Since we don't know the exact causative agent, we just have to maintain a good health for that. Yeah. I've spoken about the first part. Now I'm coming to the second part. I have to bring up this disclosure because the second part is mainly videos. And there were videos of when I was in Evercare, the cases I was involved with in Evercare, that the training I got from this place really helped me. That even while I was there, remembering my teachers here helped me save the patients that I saw. All right. These cases are cases of perimeter cesarean section and a true umbilical knot. For the first case, before he pressed the video, this lady was a 40-year-old gravida 3 para 2 plus 0 2 alive woman who came in at 33 weeks 3 days with preterm contractions, developed severe preeclampsia in the ward. And on a Friday that I was taking over on call, I met her. She had an asaka all over. And her BP was so high. I instituted some things down that I needed them to do for her. But the following morning when I came, that was when the actual event took place. Because I just came in, I had other women contracting. While dealing with them, immediately I told my medical officer to just check on the patient and let me know what vitals are, and if they've given all the things I asked them to institute. And she just came back and told me that urinalysis is 3 pluses, that rang a bell. BP is 195, 155. I started shaking because I had a multi that was contracting away in active labor. But I quickly dealt with that. And there was no porter, it was a Saturday. That day was like watching Grey's Anatomy. Because immediately I started looking for the neonatologist, the anesthetist, and everybody. The anesthetist was busy with a case in the theater. Luckily, the neonatologist met me and I told her we have an emergency. We are going to theater. However, there was no porter to move the patients. And the theater people were telling me to bring the patients upstairs. And how can I bring the patients upstairs? We have a theater for labor. They said, well, we have to use 2 theaters beside each other. That was the 5th floor. I was on the 1st floor. And I was being told, bring the patient to 5th floor. No porter. So as we were talking, I just said, let me examine this woman. And here and behold, the membranes are bulging. This is a 33-weeker, and a multi, she can expel right there and there. And tears was coming out of her eyes. I screamed, called the matron, and we rushed her to labor ward. And from there, before we got to labor ward, by the time we got to labor ward, the nurse tried to get the heart rate of the baby. It was gone. And as we were trying to do that, because I just said, put on the CTG, let me do it myself. As we were doing that, the mother started shouting, I'm going, I'm going, And if you see her, you could see that she, a woman with an asaka, she can't breathe, she's in pain. Everything goes flat, it deepens. Everything down. To the extent that at a point in time, the fetal heart rate was 70. When contraction was going on. Then the next time it will be 190, 200. I just had to take a decision because I looked at it, the service was still closed. If we continue with this like this baby will not make it through. So I told her, sweetheart, we have to bring her this baby immediately. I reject it. It is not my portion. She started praying. Jesus Christ, I will give birth to this my baby myself. I said I've entered one chance. And this somebody that is a family friend, my husband's friend's wife. So initially I waited. I said, okay, you put her on oxygen. Do this, do that. We did everything. This baby said, no, save my soul. No, baby was just crying. I had to call her husband. I said, you need to talk to your wife. Speak with her. This baby, I need to bring this baby out. And the earlier we bring this baby out, we'll get a healthy baby. If we stay too long, I don't know what can happen. She continued saying, she continued saying that she continued saying she won't. However, I now told her, well, I'm no more your friend. I don't know you. I don't know you from anywhere. I'm your doctor. I need to bring this baby out. If you are not going to let me bring this baby out, I told the medical officer, go and bring that man form. Let her that man leave. I can't go on with this labor. So when I said that, she knew I was serious. He now said, okay, we can go on. By the time I brought out the baby, oh, sorry. By the time I brought out the baby from CS, I discovered a true knot. Kindly let me put it on the second video. No, not this one. I just want him to forward it to where the true knot is so that we appreciate what a true umbilical knot is. You can fast forward it. Where they showed yeah. Forward. Forward. You will see something like coming from theater. We didn't pick that from ultrasound. It hardly picked from ultrasound. But that was that. By the time I don't know if I could use my phone now. By the time we brought out the baby anyway, when I was just bringing out the baby, everybody in the theater screamed when they saw the true knot. But I had to calm them down. So she was curious, why were we screaming afterwards? So we took the picture, we snapped it. I went to show her. It's like when you tie a knot, that is what a true knot is. And when the baby is coming out of the birth passage, it tightens further. So it's like the baby is committing suicide. And by the time the baby comes out, we have a fresh stillbirth, a baby who has just died. So it was saved. That's the second case. So coming to the third part, I want to just briefly talk about legacy. Talking about legacy, talking about Pearl Specialist Foundation. It's a charity foundation, a registered non-profit organization committed to equitable access to surgical health care. It's a health-focused organization established to improve the quality of health care for mainly women, and it's established for the treatment of fibroids. A lot of women in our society have financial barrier and limited access to specialist care. This causes delay in diagnosis and treatment for many of them, leading to complications setting in from the condition they have. So this project seeks to bridge that gap through a multi-phase community-led intervention. What's our mission? To promote equitable health care access, improve health outcomes, and empower communities through education, prevention, and targeted health support programs. And the vision is to have a society where every individual, regardless of socioeconomic status, has access to essential healthcare services and the knowledge needed to live a healthy life. Our core focus is on outreach, where we recruit our patients and we give support for the treatment of fibroids. It's from subsidized to free, depending on the category, the cadre of the society where the patient is. This was, it appears all the videos are not functioning. This was one of the outreach we did. Yeah, the outreach we did. And she was giving testimony. One of the fibroids you saw earlier came out of this woman. So, in the light of giving back legacy, it's a very important thing Dr. Simi has drawn us to. And the resilience that our mentors, our teachers have given us has made me to think inward and thought of what can I give back. Having learned all these years, I also want to give back something to the society. That's why we brought this. I thank everyone today. I thank YBC for bringing my group. I thank our mentors and all those that have participated here in the surgery that are not here. They also, I thank them for making this a success. And I pray for all of us that one day we all look back and thank God that, yes, we are doctors, we have something we have given back. Thank you.
Dr. Fumi Shijuade. I caught your camera, just step forward. So that both of you, in quick succession, will present this award. First year, Professor Omobolanle Ogunlewe. These people are excited to see you. They've not seen you in 25 years. And yet they can still see a pretty face. Your pretty face after 25 years. Very highly distinguished oral maxillofacial surgeon, consultant oral maxillofacial surgeon, and professor of oral maxillofacial surgery at the Faculty of Dental Sciences, College of Medicine, University of Lagos. Our chairman. Okay. So Fumi Shijuade Ni Akinwande is presenting the award to Professor Mobalale Ogunlewe.
Hello? Yeah. I am so privileged to present this award. And the reason I grabbed it from Kevin was that I had to. Because during my house job, I was in your team. I don't know if you remember. You were the first person that made me present a paper or a topic where you case presentation. And I've gone on to present more cases. And it was during my house job. I learned a lot during my Max Facts house job. You also taught me how to give an ID injection without using my finger to look for the external oblique ridge. I remember when you were walking past and you saw me one day, I said, let me show you, so that you don't prick yourself in a safe manner. And I do that method till today, and I talk about it at my work. So I want to say thank you so much. So on behalf of the class of 2000 Alumni Association YBC Y2K, I present this award for teaching and mentoring, the Teaching and Mentoring Excellence Award, presented to Professor Mrs. Ogunlewe Omobolanle on Tuesday, 16th of December 2025. Thank you.
So the next award goes to, or should we say, and the winner is Professor Olatokunbo Oluranti Da Costa. You can take it.
On behalf of YBC Y2K and the entire dental set, I'd like to say thank you. I do remember you a lot more. I started my residency in orthodontics, and yeah, I ran away, but yeah, and I definitely remember all your teachings. Thank you very much, Ma. We do really appreciate you. And so on behalf of everybody, the College of Medicine, University of Lagos Medical and Dental Graduating Class of 2000 Alumni Association, YBC Y2K, would like to present this Teaching and Mentoring Excellence Award
presented to Professor Mrs. Dacosta Oluranti Olatokunbo on this day, Tuesday, December 16, 2025. Thank you very much and God bless you. Thank you very much.
Thank you.
Let's give her box.
Thank you very much for the award, but this blue box is very heavy, and I'm very, very grateful. I think I should thank you especially, not you too. Maybe when you open it, you. Don't off the mic, don't off the mic.
I'm so proud to see that so many of you have done so well in life. That's always our prayer when we're training. And I remember when I was training a lot of students, I accept that I probably wasn't the most popular teacher in the set, but you learn to appreciate after the fact. And what I want to say to you is thank you so much for this beautiful box. It's very much appreciated, and I wish you all the best going forward.
As Dr. Fumi Shugade steps forward to present her lecture, is Dr. Miriam Malayo there? Miriam Malayo. Ladies and gentlemen, let's clap for this young lady as she steps forward. Dr. Miriam Malayo is a YPC Y2K scholarship beneficiary from year 1 till she graduated. And she's a distinction student, or was a distinction student. Very much worth supporting, and she did not fail YPC Y2K. So she has a few things to say. Miriam Malayo, you have 2 minutes, please.
Yes. Thank you very much, sir. To the members of the I table and the distinguished members of the YPC Y2K alumni class, I say good afternoon to you all. All existing protocols duly observed. I am Dr. Alayo Miriam, and I stand here today as a past beneficiary of the Leslie Gaba Scholarship Award sponsored by the YPC Y2K alumni class. Today is a profoundly humbling moment for me, and I want to especially thank Professor Isikwe and Professor Butali for giving me this opportunity to stand before you, not merely as an individual, but as a voice for every past and present beneficiary of the Leslie Gaba Scholarship Award. And on behalf of us all, I extend our deepest gratitude. Years ago, when the YPC Y2K alumni class made the deliberate choice to give back, you did something extraordinary. You chose to invest in lives you were not obligated to support. You chose to stand in the gap for students whose dreams were at risk of being delayed, diminished, or completely lost. We came from different homes, from different backgrounds, different circumstances, and different struggles. And some of us worried about tuition fees, some about accommodation fees, some about basic learning materials, and we carried silent fears about how long we could keep going. For many of us, that decision you made arrived at a defining moment, especially for me. You have impacted 16 lives in total so far, supporting some of us in my cohort for about 5 years consistently. This scholarship became our anchor. It offered stability when everything else felt uncertain. Personally, I am a living testimony of that impact. This scholarship gave me more than financial support. It gave me peace of mind. It allowed me to focus, to persevere, and to pursue excellence without fear. Because of the consistency and the belief shown by the YBC Y2K alumni class, I was able to give my very best academically, and at the end of my journey, I emerged as the overall best graduating student. However, I say this with humility, that achievement did not begin with me. It began with you. It began with a decision made by the YBC Y2K alumni class to believe in the potential of young people. And beyond financial support, we were also privileged to receive mentorship. I currently attend the Butali Lab meeting, and we also had guidance that shaped our thinking, encouragement that strengthened our resolve. I see Professor Isikwe on the corridors, and he tells me, don't worry, everything will be fine. And the words spoken at moments when we needed them the most. I am very grateful for Dr. Fumi Shiduade, those words. Those moments reminded us that we were seen, valued, and expected to succeed. The true impact of the scholarship cannot be measured by grades alone. It built confidence, it nurtured resilience, it restored hope, and it transformed lives. To the beneficiaries, this scholarship is a reminder that we are supported, we are believed in, and we are expected to use this opportunity not just for our own benefits, but to make a difference in our communities. Let us carry this legacy with pride and responsibility. And at this point, I would like to invite all the past and present beneficiaries of the Leslie Gaba Scholarship Award who are present here today to please come forward and stand. Please make it snappy. There are 16 of us in total, but some are unavoidably absent. So please come forward. Where is Joseph? Okay, he's not here. Okay. So I want you to take a look at us, and as we stand together, what you see before you is more than a group of individuals. You are seeing stories rewritten. You are seeing dreams that have been preserved. You are seeing futures that have been secured because the YBC Y2K class chose compassion over convenience. Distinguished members of the YBC Y2K alumni class, this is your impact, this is your legacy. These are lives you touched, the burdens you lifted, and the hope you restored. On behalf of every beneficiary, both past and present, we say thank you. Thank you for your generosity, thank you for your consistency, and thank you for believing that giving back is not an obligation, but a legacy. We assure you that the lives you have shaped will in turn shape the society, and we will definitely pay it forward. Thank you so much, and God bless you all.
Awesome speech. Awesome speech. No truer words were spoken. Awesome speech. Let's give them a round of applause.
Good afternoon. Please introduce yourself.
Okay, I am Dr. Alayo Miriam, a past beneficiary of the Leslie Gaba Scholarship Award, sponsored by the YBC Y2K alumni class.
Okay, so how did you come to know about the scholarship program?
Okay, so it was just a particular day. Our class rep, as at then, just sent a message to the group chat that, if you are an indigent student, kindly send your details to this number. And that was how I got to know about the scholarship. I only texted the number, and then we were invited for a general interview before they assigned us to different alumni classes, and different, let's say some churches were also sponsoring some other scholarships. And that was how I got to meet the YBC Y2K alumni class.
Okay, so the scholarship, how has it impacted you, apart from you impacting you academically, as a person, as a doctor now, how did that scholarship impact you?
Okay, so aside academics, it has impacted me in such a way that it's built confidence in me, and it also nurtured resilience. And
yes, go ahead, please.
Okay, Dr. Fumi Shiduade, BDS Lagos, PG SAT, MSc Manchester, FCG Dent UK, is a highly experienced dentist with over 20 years of clinical experience, serving as co-principal dentist at Cherry Hinton Dental Center. specializing in cosmetic and aesthetic dentistry. She offers advanced treatments including surgical extractions, implant dentistry, and smile makeovers. A fellow of the College of General Dentistry, UK, and member of the British Academy of Cosmetic Dentistry, BACD, and British Association of Private Dentistry. Dr. Shijuade is a dedicated clinician committed to ongoing postgraduate training and excellence in patient care. Everybody, a round of applause for Dr. Shijuade. Thank you very much.
Good afternoon, everyone. I know we've been here for a long time and people are tired, so I'm going to make it really short and snappy because it's supposed to be a short talk. I feel this talk kind of embraced the two parts of YBC, which is the dental and medical side, and it's the mouth and the general health. It's a very large topic, so it's very hard to squeeze it into a short talk. I've always said to myself that the mouth is the mirror to the body. It reflects what is going on in the body. Your mouth, you can see a lot of things in the mouth and then tell people what is going on in the body. From the stress when the masseter muscles and other muscles of mastication go into overdrive in an individual, when they start to brox, and it leads to headaches and things like that. So because this topic is very, very vast, I would like to split it into 3 areas just to quickly sort of cover it. The first area is relevance of dentistry in maintaining good health and diagnosing certain health conditions. Second part is relevance of dentistry in treatment of ailments, including medications, and the role of a dental and medical practitioner, taking detailed medical history and spotting disease quickly. Okay. So if we go into the relevance of dentistry in maintaining good health and diagnosing problems, I'll first start with the WHO definition of good health. It says that good health is a state of complete physical, mental, and social well-being, and not merely the absence of disease. So if we're to go into that, we go into the physical well-being. Physical well-being, maintenance of good oral health can mitigate certain diseases. One of the ones that is most common of these is periodontal disease. Periodontal disease has been linked because of bacteria like Porphyromonas gingivalis that have been linked to heart disease because they promote inflammation, plaque, and fatty deposits that cause increased risk of stroke, myocardial infarction, and infective endocarditis in the heart valve. And this has led to the culture or the practice of patients taking prophylactic antibiotics before certain dental surgeries, such as extractions, implant surgeries, biopsies, periodontal surgeries. So because we've got bacteria in the mouth that can culture in the heart, we need to be very aware of the necessity of the need to have good oral hygiene, promote good oral hygiene amongst our patients and also the educating our colleagues about it. I go on to mental well-being. I would highlight aesthetic dentistry here. That's my sort of area of niche. In this case, one cannot overemphasize the effect of a good smile to mental well-being of an individual, especially in the world we live in now, where social media gives a lot of credence to appearance and the number of people exposed to social media and its influence. In my practice as an aesthetic dentist, where people present for the first time, I have patients who come into practice, into the surgery, and they'll tell me things like, I don't smile because I hate my smile. People will say to you, I haven't been able to go on a date because I don't feel confident. For us, it might seem very simple and very easy because we have probably will have what we consider good, nice smile, but you would not believe when you treat when you treat a patient and you give them a new smile and they break down in front of you crying, or they come back and tell you testimonials like, I went on a date for the first time in 20 years, or I got out of the house for the first time. That tells you the impact, of what this does to our mental health. There is also the body dysmorphia, depression, body dysmorphia in the sense that people will bring the photographs of their favorite celebrity and will give it to you and say, can you reproduce my smile? Can you make my smile look like this? So things like that, And then we go on to the social well-being. Halitosis, I would highlight in this, that is bad breath. So halitosis would affect people's social well-being, because if you're in a crowd and you have bad breath, you start to get conscious of yourself. You become very self-aware. I would describe, some become social vagrants, where they're coming into the room and people are dodging because they're like, okay, this person has a bad breath. These are simple things that can be corrected. These are simple things that can be easily diagnosed, that also relate to either our general health or our mental health or social well-being. I would go back to talking briefly about diabetes as well, because that is a big one. And I know that there are many doctors in the room, surgeons, oncologists. Amongst my colleagues, I would like to ask, how many of you regularly ask your patients if they've gone to their dentist, to see their dentist? Thank you. Yeah, because it's important, and that will be highlighted in my next topic, which is relevance of dentistry in treatment of ailments, including medication. So, for cancer treatments, in cancer treatments, a lot of anti-angiogenics and anti-resorptive medications are used to treat cancer patients. Medications. Sorry, I'm young, but my eyes are telling me separate. So medications such as oral bisphosphonates have also been used to treat patients with osteoporosis, and human monoclonal antibodies like denosumab are used to treat either osteoporosis. They are used as adjunct medicines with cancer patients. These medications are very important in the sense that they do affect what we do in dental surgery. Hence, I asked the question, how many of you ask your patients? Because we do see patients who come around after they've started cancer treatment and they have problems and they need extraction. And you realize that they've been on things like alendronic acid or zolendronic acid. And those are dangerous places, because once you take out their tooth, there are risk of having what we call MRONJ. MRONJ is MRONJ. That's medicine-related osteonecrosis of the jaw. These are horrible, horrible conditions that could be prevented, in the sense that the minute you take out a tooth from a patient that is already on alendronic acid and they develop it, they're very painful. They're roughening of the jaw. So things like these are what, the relevance of dentistry in terms of treatment and in terms of medication. Also immunosuppressants, like methotrexate, and things like that. We go on to antiplatelet drugs as well. I'm trying to sort of catch up so that I don't take too much of your time. Antiplatelet drugs and anticoagulant drugs as well, to go with the I noticed that Somi didn't raise his hand when I asked if you regularly ask your patients if they go to the dentist. Because cardiologists give us a bit of, sometimes as well. Before you have cardio surgery, before your patients have cardio surgery, please send them to their dentist to have them checked so that teeth with poor prognosis can be dealt with before they do that. Because once you have the heart surgery, it's so difficult to manage those patients. Patients on antiplatelets and anticoagulants as well. We have regimes that we put them through, and the knowledge, we work together with cardiologists to be able to say, okay, what would you say? This patient, should this patient be taking prophylactic antibiotics for starters? Because the guideline keeps changing, every year. Sometimes we give them antibiotic prophylaxis, then don't give them, then depends on how severe it is. Antiplatelets, anticoagulants as well. General practitioners, before you place them on it, let them do their checks as well. And whilst they're on their checks as well, let the patients know what it entails. They might need to stop their anticoagulants. We might need to send them off to go and do their INR if they're on warfarin. So those are the things. And the fourth one, there are so many other conditions that can make a patient contraindicated for certain dental procedures. Dental procedures like implant dentistry. For example, implants, as far as we're concerned, are elective surgery. Implant surgeries are elective. They're not they're not life-saving. They're not, your life is not dependent on it. It's an elective one because there are other options that you can have to replace a missing teeth. So a patient with severe renal disorder, for example, or severe heart disease, or a patient that has just recovered from myocardial infarction, we cannot be presenting to us to have implants placed immediately, especially within 6 months of having these incidences. So those are the things that we need to be aware of, both for the medical and the dental colleagues as well. Also, psychiatric disorder as well is important. So I'll quickly go on to the role of the dental practitioner and medical practitioner. With all that I've said today, we all have a role. The dental practitioner, you have a role to carry out detailed medical history on your patients. Please do not say to your patient, are you fit and well? That's not medical history. It's a bad habit that people tend to have. Oh, are you fit and well? Then you write it on fit and well. No, you need to take detailed medical history. I have personally come across patients, and my colleagues have come across patients that are on this medication, and they do not tell their dentist, and they just say, oh, are you on any medication? Oh, I'm not on any medication. By the time I'm not on any medication relevant to you. By the time you dig deeper and you tell them, oh, you're on alendronic acid, why did you not say, oh, I didn't think it had anything to do with my teeth because my doctor gave me for my bone. So as dental practitioners, you need to dig deep and say, give me a list of the medication you're on. In my practice, they bring the list of medication. On the NHS, you have your prescription, they bring it in, and we scan it onto their record. Detailed dental examination is important. This is where cancer of the mouth comes into practice. Not just telling your patient, but you as healthcare professionals as well, you should go and see your dentist regularly. How many of you go to see your dentist regularly? Thank you. Thank you, Uzo. Thank you, Somi. Thank you. Thank you, Somi. Yes. Thank you. It's important because people think dentistry is just teeth. It's not just teeth. It's your oral health. It's everything in your mouth, your tongue, under your tongue, everything. So that's very important as well, so that things like, cancer can be detected. The earlier, the better. Detailed record findings, prompt referral as necessary if you find anything as a dentist. If I see a patient with bad periodontal disease, I usually send them off to go and have their HbA1c blood test done. Because for some patients, some of my patients are presented with bad perio disease, and they've only found out that they've got diabetes after I've referred them to go and have the HbA1c, and then they found out they've got diabetes. So those are important. Patient education for medical practitioners, as you can see there, oral health enlightenment for our practitioner. That's why we're doing this talk. Like I said, this is a whole topic for a whole day. But at least, hopefully, you can take one or two things out of, from here. That if you're working in oncology, cardiology, or even general practice, please tell your patients to go and see the dentist. And if you're about to place them on certain medication, be educated about the effect of the medication you're placing your patients on, the oral effect of it. You're educated in the effect on the kidney, you're educated about the effect on the liver. Please be educated about the effect of this medication in their mouth. So that's why I said enlightenment. Robust treatment planning that includes oral health, which is referring to the dentist before you start chemotherapy or radiotherapy and things like that. So that is it for me. So ultimately, I wrote this down, so I wanted to write it, to read it. Ultimately, we took an oath to do right by our patient and first do no harm. So thank you very much.
Please introduce yourself.
All right, so my name is Dr. Fumi Sijuade, and I finished from College of Medicine, University of Lagos in 2000, so I'm a part of YBC Y2K. I currently work in the United Kingdom, a special interest dentist in cosmetic and aesthetic dentistry, and I also do a few surgical procedures as well in my practice, like crown lengthening and surgical extraction of wisdom, impacted wisdom teeth and things like that. I'm a fellow of the College of Dentistry, United Kingdom, and a full member of British Association of Cosmetic Dentists. So I'm a cosmetic dentist at heart. Yeah.
Wow, that's a lot of achievements. Okay, in line with the theme of the symposium today, which is the impact of diasporan doctors on the Nigerian healthcare system, how do you think the Department of Dentistry can do more for the healthcare system in Nigeria?
Oh, wow. That's one of the areas I'm quite passionate about, and that kind of featured in my talk today, even though it was a very short talk, so I couldn't really express it. I think the first thing is enlightenment, not just enlightenment of the general public. I think School of Dentistry can do, or Faculty of Dentistry can do a lot more in enlightening people to their dental health. Everybody knows something or the other about medicine. They know that if they have a headache, they'll go to their doctor. If they have this, they have that. But with dentistry, yes, they know that if they have a toothache, they'll go to the dentist. But they don't know that in dentistry, a lot of the issues in dentistry has to do with diagnosing and knowing it and treating early, so that it doesn't get worse. And that's the unique thing about dentistry, that you don't have to have a symptom to go to your dentist. And in a lot of cases of dental or oral health issues or oral pathology, it doesn't show up with symptoms. So for example, oral cancer, a lot of the times people don't have symptoms, but they already have it. They already have the lesion and they don't know because there is no symptom. In a lot of times when people have caries, a lot of the times they don't necessarily have symptoms. Yes, some of them will now start having sensitivity to hot and cold, to sweet, and then they'll go to their dentist. Sometimes by the time you take the x-ray, the caries is already really huge and becomes a big filling, or the caries undermines the tooth, or it goes into the pulp and it becomes something else. Whereas if they go for regular checkups, the dentist can pick up early caries, which can then be prevented from becoming a big caries, or it can be quickly filled before it becomes big. Also, they can detect other health issues like precancerous lesions that can be detected early, biopsied, removed, and taken care of before it becomes something big. Or they can have periodontitis. A lot of people with periodontitis don't have symptoms until it's gone too far and the teeth start falling out. Early detection of periodontitis means they won't lose their teeth. It also means that it can mirror other diseases show other diseases like diabetes and things like that. So education, I think they need to put a lot more. And if they do that, if they educate the populace, you will find out that the reception of dentistry will be better. And then the students that they are releasing, graduating and releasing to the public will have jobs, because that's another problem with dentistry. A lot of dentists that are graduating, there's no job, or they're being paid wages that if they didn't even go to school, They're being paid hairdressing. If they didn't go to school, they would get even better wage if they're doing hairdressing and doing their own business. I've heard of some really bad wage being offered to dentists. Why? Because there's no job. But if the population know about this and they come, and the uptake of dentistry is a lot more, it will create jobs for them as well. Yeah.
Okay. So I know you're more based in the UK, your work base is over there. But here in Nigeria, do you think there are enough dentists right now circulating the healthcare system?
I don't think there's enough healthcare providers in Nigeria. There's not enough dentists, trust me. The number of dentists...
Time is fast spent. We are running behind schedule. We have had with us since morning the acting president of the CMUL Alumni Association. I'm sure all of us know UAC, we call him his group, but let me be formal. Professor UAC Okafor is a professor of physiotherapy. He was here with us when we were in medical school. There was some years that senior. So Prof is going to just talk to us about the Alumni Association very briefly, and then we will call it a wrap for this afternoon. Our MC is heading to the lawn tennis court. Dr. Robert, you've done a fantastic job. Thank you so much. We will meet you at the court in a short while. Thank you.
Thank you very much. Y2K. YBC2K, sorry. YBC Y2K. Yes, thank you very much. Ike, I'm a friend of the house. Some of you were my next door neighbors. Where's Bafana? Bafana is back. Where is he? Why is there Tietie? Don't worry, I'll catch him. So I want to congratulate all of you for being here and coming back to college, and particularly coming back to give back to the college. The College of Medicine Alumni Association will be following your track records of your set in particular, in spite of especially the scholarships you've been given, and I'm happy the students came to testify. On behalf of the Alumni Association, I want to thank you very much, and to specifically thank Professor Butali for all you've done for this set, and for all you've done for the Dental Alumni Association, and also to my friend Ike, Prof. Ike, very hot. Professor Ike, yes, please, you can't miss it. I want to thank you, Ike, for all you've done for dental and also for the set. I want to congratulate you and also wish you safe journey when you are going back. Don't forget the college. Always remember where you come from. Thank you very much.
Thank you, sir. Please, more round of applause for him. Thank you very much. Okay, as we bring today's symposium to a close, we thank you all for your individual insights, discussions, shared reflections, and renewed connections. Your contribution today affirms the enduring impact of the YBC Y2K class of 2000 on healthcare in Nigeria and beyond. On behalf of the organizing team, we want to say a very big thank you for being a part of today's success. So I want to call on Dr. Nkem Okafor for the vote of thanks. Dr. Nkem Okafor. Please, a round of applause for Dr. Nkem Okafor as he comes forward to give the vote of thanks.
YBC Y2K? No, that was late. YBC Y2K. Thank you all. Thank you. Professor Juluchukwu, thank you. Oh, thank you, Ma, really. You were... you were one of the few teachers that made medical school for me bearable, to be honest with you. So, well, thank you. Thank you for your kindness. Thank you for your knowledge. Thank you for everything. So, on behalf of all the members of YBC, I would like to extend a sincere gratitude to the provost. He's not here, but we'll thank him anyway, of the College of Medicine, University of Lagos, Professor Ademola Oremusu, for his presence and his support in ensuring that this program was a huge success. We are also very grateful to the Vice Chancellor, though he's not here either, but we thank him. He's also a former teacher. She's not here, Professor Folashade Ogunshola. I would like to say a very big thank you to the members of the College of Management and the Dean, to our teachers that came today, all of them, those that were here and those that weren't, those that have retired as well, we thank them. You know, without them, there will be no us. Our special gratitude, you know, to our teachers who've taken time to be with us today. We truly appreciate not just their presence, but their significant contributions towards making us who we are today. We've celebrated them and will continue to celebrate you in a special way. I would also like to thank everyone who's made time out to be with us today, including our faculty members of the college, the administrative staff, and some of the students as well, the Leslie Garber scholars too as well. And to my dear YBC family, thank you so much for making time out to be here. Some of us have traveled from different parts of the world, the United Kingdom, the United States, all the way from Australia to celebrate our 25th anniversary. It takes a lot, you know, to organize this. It takes a lot to find time out to come all this way, and we are truly grateful. Thank you for your contribution, your support towards making this ceremony and this week a success. And we look forward to having a memorable celebration for the rest of the week. Finally, I want to thank God for the success of today's ceremony and for keeping us all together for the past 25 years. I think it was Angela, Ronke's daughter, that said something about it's not. Ronke, what was it that your daughter said again? That about it's not. It was something that you always post about the fact that she said it's not given. It's a blessing. I'm paraphrasing here. Exactly, it's a blessing, and it is a blessing. You know, and out of the mouth of wisdom comes out of the mouth of babes. So I took that to heart when I read that this is what your daughter said, Angela said, and you're right, 25 years is no joke, you know. So we look forward to many milestone celebrations as a class, and you know, I wish all of you well. Thank you. YBC Y2K. Thank you.
Thank you. Thank you, Dr. Oke. Okay, briefly, want to call on Dr. Ronke Awe to speak to us on menopause. Please, a round of applause as she comes forward.
I know we are. So normally when I give this talk, I give it for 90 minutes. I've been told to compress it to 60 minutes. But now I'll try and compress it to 20 minutes. Just 5 minutes. 5 minutes is not possible. I stand on all protocols. Thank you very much, Mike. An honor to speak when you are chair. We didn't get anybody for Andropos, but I said I was going to say something to the men. Please go and check your PSA if you have not checked it. It could save your life. Have you got my slide? So I'll be talking about a few definitions. I will go through physiology. I'll talk about causes of menopause. I will do HRT, alternatives to HRT, questions and answers if there are any questions and answers. So I need to set my timer. I don't want to. I can talk for England, so I'll set a 20-minute timer so that I don't overrun. Okay, I'll try. So basically, like we know, menstruation is when the menstrual flow stops, and it's got to be 12 months. A lot of us know how it works. Initially, you think you're going through menopause. You stop bleeding for like 2 months. You're like, yes, finally it's here. And then it shows its face again. And then the next time is like 4 months, 9 months until you get to 12 months. So you need to be 12 months exactly. The average age for Nigerians is about 49, for Caucasians about 51, and it ranges between 45 to 55. If you stop having the period before you're 40, that is premature ovarian insufficiency. You can move on the slide, guys. Oh, I forgot it. The last one. All right, so we talk about we go to the physiology next. We all know the cycle. We have a follicular cycle, we have a luteal cycle. I won't bore you with all of that. We know what happens that in the uterus itself, you have the proliferative and you have the secretory cycle. And most importantly, there's a lot of estrogen and there's a lot of progesterone. And that's what we have that we stop making, that makes us get into menopause. What are the causes of menopause? There are different causes of menopause. It could be natural, because it's just time you use up all the eggs. Like we know all the eggs we have the most amount of eggs. When we're in our mother's womb, we have about 6-7 million eggs. By the time we're born, we have about 1 million eggs left. By the time you start your puberty, you have about 600,000-700,000. And by the time you get to menopause, you are at the bottom of your basket. So once you've used up all the eggs in the basket, you get into menopause. It could be iatrogenic, which means that it's caused by the doctors or something we have done. It could be surgical, and surgical could be cancer or not cancerous. So if you have cancer and you have to remove your ovaries, of course you're going to get into menopause. And it could be that you have endometriosis or something different, and you decide to have remove your ovaries as well as your uterus. It could be medical, and it could be from chemotherapy or from radiotherapy or some of the other medications that we use. The symptoms vary from person to person, and it could be, I won't bore us with it. Some people, about 80% of us will have menopausal symptoms, and there will be some of us that have no symptoms. I'm saying this also for the wives, because for the husbands really, because the partners, because when we are going through all of this, we have our partners who's suffering from it. I remember when I had my first episode of night sweats, and I woke up with a bed that was full. My husband thought I had wet the bed. I was like, "What's this?" And I had to explain and tell him about what's happening. Insomnia, at times we just can't sleep. We just find it difficult to sleep. The dominant reported symptoms are hot flushes, insomnia, fatigue, arthralgia, and cognition and mood effects. And it takes about 5 to 7 years for us to actually go through it. So if you're still going through it now, just know that usually it will stop, it will end. It can take up to 10 years. Most people are fine by the time they are 60, and unfortunately some people still need to use HRT when they are in their 70s. Right, so I'm going to talk about HRT. The reason I started giving this talk was because it was not, it wasn't equitable. I didn't have a lot of my African women, Afro-Caribbean women coming to ask for HRT, because a lot of people had this myth about HRT. So I wanted to dispose the myth and talk to them about what HRT really is. We know that we are trying to replace the hormones that we stop producing ourselves by giving us the chemicals. So it could be combined, or it could be estrogen only. If it's combined, it could be sequential, or it could be continuous. So with the sequential, if you're less than 50, or if you're still having a period, you're likely to be started on sequential HRT. And sequential HRT means that you are having the progesterone part of your HRT in the last 14 days, usually 10 to 14 days of the cycle of your HRT. The continuous means you're having both progesterone and estrogen
every day. If you don't have a womb, then you have estrogen-only HRT, because the progesterone is to counteract the impact of the estrogen. I always use this analogy that our womb is like a lawn. For the lawn to grow, you need your estrogen, and your estrogen is like your water, it's like your fertilizer, your sunshine, and your progesterone is like your mower. It mows the lining of the womb to keep it nice and thin. If it's too thick, that's when you have endometrial pathology, like hyperplasia with asphyxia, or things like endometrial cancer, which is what we don't want, yeah? And you can have it as a tablet. It could be a skin or transdermal. With the transdermal ones, it's usually skin a patch, or you could have the pumps to use for transdermal. There are side effects associated as written down there. So a few years ago, there was about 20 years ago now, actually, there was this Women's Health Initiative research that made everybody scared of using HRT. And one of the things we worry about was things like breast cancer, stroke, and things like that. Contraindication of HRT is pretty much self-explanatory, so I won't go into that. I will just share the slides. A very funny story. It's actually a true story. My aunt stopped, she was in her late 40s, and she thought she was into menopause, but she was actually pregnant. So if you have a patient or ourselves, if you're not having a period, please check your pregnancy test, because it could be a menopause baby. Right, so one of the things we worry about is the risk of breast cancer. And here in this pictogram is to see things that could actually cause breast cancer. If you look at it, the second one down, I think, is HRT, and you are, I think I told you as well. My eye is telling me differently. Yeah, you need an additional, you get an additional 4 cases of women having breast cancer from using HRT. But if you look down the line, you see that you actually other things like obesity. If your BMI is more than 30, it increases your risk. You have an extra 24 cases of breast cancer. So it's about understanding risk and putting risk in its place. Other things that are good for those of, I won't say those of us, because I'm not one of you guys, that have that exercise 2.5 hours in a week. It can actually reduce your risk. You get 7 cases fewer if you actually exercise. So let's encourage each other to have moderate exercises. Also, if you are using the estrogen-only HRT, also it reduces your risk of having breast cancer. Like I said earlier, we were worried about the Women's Health Initiative. People were quite worried that they are going to have cardiac problems. The WHI study was actually stopped because a lot of people were worried that people were having cardiovascular problems, or they were having, blood clots and things, and they stopped it. But now they've revisited it, and they realized that it does not actually increase the risk of cardiovascular disease if you start your HRT before 60 years old. Also, if you start within 10 years of getting menopausal, it does not have as much risk as we thought it once did. HRT, estrogen-only HRT also does not have any risk does not increase your risk, beg your pardon, of heart disease. If you're using the combined HRT, it also has little or no increase in risk of heart disease. What we've come to realize is that it depends on you as an individual, and if you have maybe other comorbidities, or if you have more risk factors for developing health disease. The tablet is becoming really old school. Now most people are placed on transdermal because the risk we have is associated more with the tablet, like the risk of the blood clot. So most people now, we tell them to have the gel or to use the patches because there is no increased risk of blood clots. And for every 1,000 women taking HRT tablets for 7.5 years, fewer than 2 of them will develop a blood clot. So the absolute risk is low.
Like I said, I give this talk because I just want to empower women, especially Afro-Caribbean women in the UK. And people ask me for alternatives to HRT, and my answer usually is, I'm not an herbalist, guys. I want to tell you the medical stuff. But if you are trying to practice equitable medicine, we have to make sure that everybody is accounted for. There are some people who prefer not to take HRT. It's their choice. Too much information. I'm not taking HRT. It's a choice of mine because I can manage it. Some people just cannot absorb it or respond well to HRT, and some side effects is too much. They rather go through the trouble because it's not benefiting them. And other people, HRT is cautioned because of other things they have. For example, if they have ovarian cancer, that is estrogen sensitive, they don't want to take HRT. So that's why now we're beginning to find alternatives to HRT, and it's an emerging group of evidence of HRT because we have low-grade evidence of just, they're not like level 1 kind of HRT evidence, that we have at LCT and things to do that. We have to be careful when we are doing alternatives to make sure that we're not using the bio-identical hormones because they're going to have the impact that the estrogen itself is going to have. So I'll start with simple things. So for the men in the room, your wife might start saying that, oh, I'm too hot. I need the AC on, and you might be freezing. These are things you have to begin to understand, and you have to adjust, that we need to keep the room cool at night. Let's wear light clothing. Let's take cool showers. Let's use fans, have cold drinks. Little things like that actually make a lot of difference. Let's reduce our stress levels. Some people, they have triggers. It could be caffeine or spicy food. If you smoke, cutting down or stopping smoking and reducing alcohol also helps. Taking lower intake of saturated fat and ultra-processed food is also quite good. And then regular exercise is good for menopause. The thing about exercise is, quite a number of people actually say their exercise helps them, with their HRT, with their menopause symptoms. High impact exercises are good, but they could have a side effect, especially if you have joint problems. But usually exercises are good for your mental health, and they are good for, basically for mental health and also for hot flushes. Next, we'll just read through a bit of the complementary alternative therapies that we have. So the one I will talk about mainly here would be the testosterone, because I'm not talking about it. Oops, sorry. I'm not talking about it again. How do I go back? I'm not talking about it again in the topic. Some people want to use testosterone because one of the things that you have in menopause is reduced libido and sex drive. So what I say for people that want testosterone is, before you start testosterone, make sure you optimize your estrogen level. So maybe increase your estrogen, get your GP to do, or your doctor to do your blood test to check your estrogen level, and use the maximum that you can get of your combined therapy if you still have a womb, or your estrogen patches, to make sure that we're not having things like breakthrough bleeding or having things like endometrial abnormality. If once you have enough estrogen level, you still have reduced sex drive, then I would advise to have a bit of testosterone. Testosterone can cause virilization, and once your voice is broken, you can't change it. Some things that happen, because you have to be careful, very careful with testosterone. Yeah. So with regards to hot flushes, one of the things we use is CBT, cognitive behavioral therapy. Is actually a level 1 evidence-based option, and it reduces the impact and not the frequency, and the impact of this CBT is usually sustained. Pollen extract is also something that people have used
it doesn't have only 27% reduction, and it's good for people that have hay fever as well because it is usually quite refined. Vitamin E is good, omega-3 is good. If you combine vitamin E and omega-3, it's actually quite good. Turmeric gives you a very good effect. I will come back to some of the side effects. I think about 3 milligrams of turmeric is what we need. Yeah, and you can see that even the placebo gave us 30%. So I think at times just doing something gives you that effect and helps you with HRT. Black cohosh is also good, about 40 to 80 milligrams, actually has a similar efficacy to using low dose estrogen. So that's very good for our breast cancer patients who do not want to use, minimal estrogen. Ginseng is good, apart from the Asian ginseng, which is called Panax. And then when we use SSRIs and SNRIs, they are good for hot flushes as well. Also as an alternative for those that do not want to use HRT. When it comes to hot flushes, the honest truth is that HRT is the best for hot flushes. And of the SSRIs, is the paroxetine is the best one. I think it has about 70% reduction. Next is arthralgia. We know how it is when you wake up and you're having aches everywhere. Vitamin D is quite good. And if you can't take the vitamin D from supplements, you can do eating oily fish, eggs, and they will help to reduce inflammation around our joints. Pollen extract was also good for this. Turmeric was also good for this because of its pro-inflammatory cytokines. And then other things like yoga, Pilates, and Tai Chi will help with reducing the joint aches. For cognitive function, what we realize that the things that affect your function include things like your flushes, your poor sleep, your mood changes. All of these actually have impact because if you're not sleeping well, when you go to work, you're not able to concentrate. And reassuring things that it's going to get better. This too shall pass. It will get better. So don't think that it's going to persist forever. But one thing we have to be careful is to make sure that we check for any red flags for dementia or ADHD. And CBT works really well for this, as does hypnotic induction. But this has to be done by people that are specialists in doing it. And the very important one is insomnia, and we all know what insomnia is. We need to, before we say we have insomnia, it's got to have the threes. If you are not able to sleep or to stay asleep for 3 times in a week for more than 3 months, then we say you have clinical insomnia. And we have to find out what actually is causing it. Are you not able to sleep because you are having night sweats? Are you not able to sleep because you are waking up to urinate? Are you not able to sleep because you have a sleeping disorder? We need to find out what it is. CBT is a first-line treatment for chronic insomnia. There's an app called Sleepio. I must confess I've not used it. It's just something I've read about. But apparently it's a digital self-help and it has CBT incorporated in it. So that's something we can try. Thank you. We have melatonin, pollen extracts, we have black cohosh and mitrazapine as well. These are all things that can help. For mood changes, some of us get really angry for no reason. So husbands and partners, please don't get angry with your wife if your wife is getting too angry. Just have to understand that it will also pass. It will also pass. Yoga, Pilates, Tai Chi will help you improve your mental function and energy. Black cohosh is good as well. St. John's wort is good, but we have to be cautious with St. John's wort. It's like the aloe vera of medicine, isn't it? It works for everything. You see it, you can buy it off the counter, but it also interacts with a lot of medication. So I will only advise this if it's a single therapy and you are using no other medication. Evening primrose is also being spoken about a lot, but it's not very useful from the literature. And also having SSRIs and SNRIs. That's my alarm. So I'll be rounding up shortly. Right, this is very important actually. The emerging supplements. I've never heard of this before, but apparently it's something common. I actually have it at the tea bag in my brother's house. It's called ashwagandha, and it has both estrogenic properties and also anti-estrogenic properties. So there's something called lion's mane mushroom, and there's rhodiola, maca, ginkgo, and they're very good for energy and cognition. Glucosamine is good for arthralgia. We have to be careful of the side effects that we can get from herbal medicine. With the SSRIs, there's a risk of nausea, of reduced libido, and sexual response, which is the opposite of what we really want. The black cohort is used by almost everybody, but we have to really be careful because in high doses, it can lead to liver toxicity. It increases your estradiol level. So if you remember my analogy of the lawn, if you're putting a lot of fertilizer, then you might have endometrial pathology. Kava causes liver damage. It's banned in the UK. Sage is good, but it doesn't work for everybody. And it also has estrogenic properties, and it's not should be used for people that have epilepsy. Turmeric, everybody uses turmeric. And I think we're only allowed to use 3 milligrams of turmeric. So I want to encourage or advise us that we should be careful the way we dump turmeric into everything we do, because it can cause liver damage. I think that for me is the most important thing, because everybody uses turmeric. And then we have the phytoestrogens. I will just run through this. I won't be able to talk about it because I think we can get this from our GPs anyway. We have some prescribable options. In the UK, there are 2 licensed options for flushes, and that's clonidine and the neurokine 3 antagonist. It helps with the flush. The NK3 antagonist actually works in the neural pathway, and that helps, and it works on time. It doesn't take time to work, unlike the other ones, like the SSRIs that actually might take up to 8 to 12 weeks to work. And I will just skip through the other prescribable ones as well. Then go to vulva. So apart from the systemic problems that we have problems in the vulva area. It's dry because we don't have enough estrogen. If you don't want to have HRT, you can still use vaginal products. Most women can use vaginal estrogen preparation, except if you cannot insert the vaginal preparation or when you have dermatitis from irritation. For the vulvar skin, I will advise that we wear loose underwear, not leggings or tight jeans or leather jeans or anything that irritates us down there. No douching. Use natural fiber toilet rolls and pads. Don't use liners because it irritates down there. Don't use wipes or anything with chemicals. Just keep it nice and clean. That's all we need. There are lots of things we can put in there. We can put emollients. And moisturizer. There are lots of them here. I don't know if we sell them in Nigeria, but in the UK there's something called the YES, Y-E-S, and that really works. Ointments are better than the creams, and you can actually get the vitamin E capsule. You can squeeze it down there to help. Coconut oil is also quite good, but if you're using condoms, beware because it can cause irritation. Hyaluronic vaginal gel is something new as well, and I think they help. With regards to the DHEA, pessary, they're usually no good for pessary. However, they can help with some of the female sexual functioning index. At least one of them you get better. Vaginal laser was quite new to me as well, but basically what that does is that it destroys the old cells and then refashioning and remodeling, and that helps with improving the symptoms. Right. So I'll be going to the conclusion now. That will be my final slide. Menopause affects all of us, whether directly or indirectly, and HRT can improve our quality of life with minimal consequences. Non-hormonal menopause therapies are emerging fields. You should remember that they are alternatives and they are not substitutes to HRT. Finally, there are multitude of lifestyle, complementary, and herbal options that we could use. They are not prescribable. Some of them don't have dosages, and we have low-grade evidence to support this efficacy. So most importantly is that we are all different. If you look at me and Diola, we are different. Look at me and Nana, we are different. Every woman is different. So we need to have individualized care. It's got to be personalized, and there has to be shared decision making. Because for some people, all they want is just their libido. For some people, all they want is just their what's it called? It's just their mood. And something I was.
Okay. Good evening, sir. Good evening, ma'am. Please introduce yourself.
I'm Dr. Princess Aderonke Awe. I'm married to this gorgeous gentleman.
My name is Tunde Awe.
Nice to meet you both. Please help us. The single people, come on. Come on. Okay. Okay, so the theme of the symposium today was impact of diasporan doctors on the Nigerian healthcare system, and we had a lot of presentations, including yours. What do you think diasporan doctors can add to the healthcare system in Nigeria at the moment? With the way the healthcare system is in Nigeria, what else do you think diasporan doctors can add to make it a lot more better?
I think I'll start by saying that a lot of us started from here, and without CMU, we would not be where we are. And we're so grateful for what we had, because the crop of doctors that were brought up here are world standard, and we are leaders wherever we are or where we all are now. So I think one of the things we can do, which is what I'm planning to do now, having spoken to a few of the professors, is that right now they want teachers, they want us to not just finances or projects, but to actually come and teach. And the good thing is that right now it can be virtual. So I am going to have a conversation with my colleagues who are in the obstetrics and gynae department, because I'm a obstetric gynecologist. I do a bit of reproductive endocrine and IVF work, and I want to see what I can do, what we can do together to help with the training. I think that's what I want to do now. That's what we need to do to impact training, and also, if possible, to get people across to us so that can learn skills that we don't have here.
So in the field of gynecology in Nigeria right now, the healthcare system, what do you think can be done to make it a lot more better? Because there are a lot of women who don't know seeing a gynecologist is important. They don't know that it's part of keeping yourself healthy as a woman, going to the gynecologist monthly, yearly, and all of that. So what do you think can be done to educate women further and to improve the care in gynecology medicine?
I think I will talk about obstetrics and gynecology, because they are like sisters, obstetrics and gynecology. And I was very impressed when I listened to our keynote speaker, Dr. Kelechi, talk about what we are doing now, how they are actually opening up and giving people finances, where if you go in and you have a complication, you can get treated for free. That's fabulous. What we need is education. We need education of the population. We need them to realize they should go for their cervical smear. Simple as that. We need for them to do their general checks. We need for them, when they have problems with their menstruations, with menopause, like talk about menopause, what we can do so that people are empowered to do what they need to do. All right, so that will be what I think. Educating the women, and maybe on television, having adverts, with the government making some things free. That would help.
So let me ask your other half. Okay, so I know you didn't do medicine, but you did study in University of Lagos. In the area of medicine, because you're married to a doctor, so I'm sure you hear a lot of medical things at home already. So in fact, you are a doctor already. So what do you think the healthcare system in Nigeria is lacking at the moment?
I think the healthcare system in Nigeria could do with a lot more skilled human capital. We need people, and as she's saying, we need to help with training, we need to help with equipment, we need to help with opportunities, so that the quality of the healthcare delivery team is better. because you really cannot give what you don't have. So as she's saying, when the healthcare people from here come, for example, to England and they have development opportunities to learn new skills that can be brought back home and serve the community and the population here, then we are doing in small steps some of those things that we need to improve healthcare in Nigeria.
So a lot of young doctors are coming into the society now. You see little graduates coming off. I saw a few of them from 500 level, 600 level. So are you going to advise them, because one of them want to do masters, they want to explore, they want the experience, the exposure. So do you think they could get that from the healthcare system in Nigeria, or do you think they still need to go abroad to get that experience to come and use it here?
If you ask me, I think they need both. When you work in a society like Nigeria, where things don't work and you still need to deliver, it helps your creativity and innovation because you find ways around delivering results. But the other side of the coin is true as well. When you go into developed societies where almost everything works, you see possibilities, you see how good things could become if things were working in Nigeria. So someone who's worked in England for a while, for example, coming back to Nigeria would straight away see a lot of opportunities and things you can do to better serve the community. And that would be my advice. If they finish and they find opportunities to gain exposure abroad, that is really good because it will help them to see what is possible here.
Well said. Ma'am, do you think we need more gynecologists in the Nigerian healthcare system?
Yes, we do. I think, I'm not sure of the numbers, but the ratio of doctors to patients, it's really not what it should be. We are one of those that have the highest level of maternal mortality, which is women dying when they're pregnant. So I think, yes, we definitely there's lots of trained obstetrician gynecologists so that they can be easily available, and the patients, the women, can go to the right people and not to people that are not trained or quacks.
Okay. So how does it feel to be with your classmates again after 25 years?
You can't measure, you can't buy. We didn't want to come because we're thinking of costs. This is our third time of being to Nigeria this year, but I'm so glad I came. I couldn't miss it for anything. It's amazing. You can buy it. Some of them have not seen since we graduated, so it's amazing to see them. And I know we'll see a bit more on the gala night, so I'm really excited. Really excited.
Thank you so much, ma'am. Thank you so much, sir.
And seeing your faces gives me hope, it gives me courage. Seeing dentists amongst us, I really want to be like you when I grow up. So it's Dr. Elijah Mercy. Thank you very much.
Let's give Dr. Elijah a big round of applause. And Dr. Arogure as well. Thank you very much, Dr. Elijah. So I know the day is fast spent. Let's give a round of applause to our chairperson. She came in here at 9 a.m. on the dot, even before, and she hasn't left that seat. What's the time? It's about 4:30 or so. So let's give her a round of applause, please. So let's take props like closing remarks. We are supposed to have our AGM. We are going to have a very abridged, because we know time has gone, we're supposed to go to tennis court. But let's props have closing remarks. And then after that, as a class, we'll decide on how to proceed because we don't have much time. Thank you.
Thank you. Thank you so much. So, YBCY2K. It's been a busy day. It's been well, I know that a lot has gone into all the preparation, all the Zoom meetings, all the donations, because the blue cartons are frightening us. We also love the pink boxes, but the blue boxes are very unique. We have never seen such a thing. We are so grateful, all of us, on behalf of all the teachers. We thank the Y2K class for remembering your teachers. We are so proud of you that you can do so much in 25 years. So you can imagine us that we have done 50 years. So if you achieve this in 25 years, you can imagine it doesn't seem that we did as much as you, because we are knocking on our 40 and 50 years and we haven't done so much. But yeah. And the prayer, just like all the other teachers said, the pride of teachers is that our students will be higher than us and achieve more. So we are so proud of you. We are proud of your giving back, especially your legacy projects, personal and together. So I think on behalf of myself, as the chairman of the day, and all the other teachers, we would wish you more success, more achievement, and more giving back. And that we know that you have large hearts, but it is not cardiomegaly. A giving heart, and we want you to do more. And the price of success is that we give you more work to do. Thank you very much.
Please, let's give proper a round of a standing ovation. Prof, thank you, ma. Thank you, ma. Thank you so much, ma. Thank you, ma. So, YBC Y2K. It's been a busy day. So we are supposed to have our AGM, but what we are looking at is because we are supposed to also go to the tennis court, and I know that everybody is tired. But we've had our electoral committee chairs here. First, Prof Utali. So he'll still be around. So we will have to move. So what we want to do is this. Yeah. Tolu and Fumi are here. So maybe what we can do is this. We can move the AGM itself. That's the report for the AGM, because we should give a report. The executive has to give a report and all that. We would have to communicate a convenient time, but we wanted face to face. It's always better when you are talking face to face. But the beach is not a good place to have an AGM. That's mixing business and No. So dinner, that's also business. So maybe what we will do is this, because we know that we're not the whole class. If we could use a virtual option, so more people will be there for. Okay, thank you. So some people will see, Prof. Thank you, ma, once again. Thank you. We are expecting you on Friday for the dinner, so that will be a less formal. Come with your dancing shoes. Yes. Nkem has a lot in stock for us for Friday. So I want to crave our indulgence that we can take a virtual option and we will communicate the date and time. But it doesn't stop the elections. The results for the elections are almost and so we will do this. Two things that we want to do for this AGM section. One, that we move a motion that the new executive will come into office from the 1st of January 2026.
Okay. Good afternoon, ma'am. Please introduce yourself.
Okay, my name is Dr. Nkem Okafor Abegunde. I am the reunion chair for the 25th anniversary of the class medical graduating College of Medicine medical. Oh, can you start all over again?
No, wait, keep going.
Okay, you edit that. Okay, for YBC Y2K College of Medicine University of Lagos graduating class medical and dental class of year 2000. I funny enough, 25 years ago, when we were graduating from medical school, I also did our dinner. I also did the gala night, but it was a bit different. This is not the first time, so we've been doing this for a minute. And it's been wonderful. It's been wonderful, yes.
What part of medicine did you dive into, or you just went to event planning straightforward?
Okay, so people think I'm doing that, but not. I do that for fun, to be honest with you. But what I'm into public health. Okay, so like some of my mates have intimated during the symposium, some of us have veered off slightly away from clinical medicine or clinical dentistry into public health, into public policy. But definitely our training here in College of Medicine, University of Lagos, prepared, whether you're in dentistry or in medicine, prepared us for what we're doing today. You know, the rigors of this college, the friendships that we formed, the exposure that we got, that we encountered has prepared us for what we're doing today, and our teachers as well. So they had a great impact on us.
So the theme for this symposium is quite catchy: impact of diaspora doctors on the Nigerian healthcare system. Why this theme, and how do you feel diaspora doctors can impact healthcare system in Nigeria?
Well, diaspora doctors have the opportunity to have great impact. Listen, this is home at the end of the day, and sometimes we would like to give back. We've left obviously for other opportunities, but there's one thing that's consistent. We got the knowledge that we have, the effort, the kind of vigor, the kind of tenacity that we have developed started from here. So it's upon us to go but come back and to impact others as well. And we hope that the new generation will do likewise as well. There are a lot of doctors that have come back. They've set up clinics, they've set up organizations, they've set up NGOs to give back. Maybe not just here in Nigeria, but in other parts of Africa as well. And it's important. The world is becoming very global. And it makes sense to circle back. Listen, you can only have great impact on where you come from, when you know what the needs are. You know what I mean? So while I wouldn't tell anybody, if you need to go abroad to do anything else, do what you need to do. But if you're a provider of care, then you should, if you can, because it's not everybody that's able, but if you can, you should definitely, give back. It has greater impact that way. Absolutely.
Okay. How does it feel to be able to bring your classmates back together again in the same place you guys started from?
To be honest with you, the class of YBC Y2K is a unique one. They don't need much convincing. Even 25 years ago, when we would hold parties or hold whatever, it was a very natural, organic thing. They would always sort of come together and do their thing. So this particular class it's not difficult to get them together, or get them to contribute, or get them to participate in one event or in one project or the other. We started, so a classmate of ours called Leslie Gaba passed away. He actually used to be one of the presidents of College of Medicine, one of the Students Association here, and we started something in his honor called the Leslie Gaba Scholars, and it has benefited 16 students that have passed through the College of Medicine and Dentistry. It wasn't difficult raising funds. It wasn't difficult finding, people in our class that could interview people and to get the right kind of candidates that would meet the requirements for the scholarship. It was very easy. I mean, I won't say easy, but it was an easy lift to achieve, and that's one of the beauty of this class. It's they're willing to give, they're willing to contribute of their time, their money, their expertise, and they're willing to share. So I am truly blessed to be a member of this class.
It shows with it really shows with the events today.
Absolutely.
You all have been so tight knit all morning till afternoon.
Some of my colleagues I haven't seen in 25 years, so it's like seeing them. It's like we start off from where we left off. No egos. It's like we were back in school. To be honest, yeah.
I think I'm going to ask this question on everybody's mind. Please, what's the meaning of YBC Y2K? We all want to know.
So, each class is called a YBC class. YBC stands for Yearbook Committee. Okay. Each class, each year is YBC. But Y2K is particular to our class. And Y2K actually means year 2000, because we were the class that went into the millennium, that were going to graduate in the millennial. And maybe for some of you Gen Zs and millennials, this is before your time. There was this craze that the computers were going to crash, that there was going to be a Y2K bug. So for some of you that don't know this, young ones, back then, computers were just becoming a thing, you know what I mean? And there was a fear that the Y2K bug would take over and crash, because you have to remember, the years beginning with the number one, figure one, had been around for 1,000 years.
True.
So, this was going to be a change. So that's pretty significant. Can you imagine when Y3K comes along? 10 generations of you won't be here anymore. So that was a big thing. And what had happened was there was that fear. And so it was everywhere. It was all over the place. And we didn't really have social media. In fact, we didn't have social media at all. Yeah. But we did have CNN. We had some other channels, but it's not the way it is now. So, and it stuck. So that was it's thick, yeah. So because we hear people say, it's our class. So we're cool that way. Yeah, we're cool that way.
Thank you so much, ma'am. Really appreciate your time.